in pulmonary medicine, prevalence of COPD in rural Bengal, the effect of interventions in terms of rehabilitation efforts in the rural patients, and many others. And Dr. Ongira Dasgupta, she is presently attached to B.R. Singh Hospital as the Chief of Pulmonary Services. She is a renowned academician. She has done her PhD, a very rare brand doctor doing PhD. She has a lot of publications, and she has been trained abroad also. So, and has worked with very high reputed scientists of global stature. So I request both of them to take chair and start the session. To initiate the presentation, I'm naming the first presenter, Dibakar Roy from Bose Institute.
Good morning, everyone. I am Dibakar Roy, working as a PhD student at Bose Institute under the guidance of Dr. Sudipta Saha. So,
Spotlight gila bond kar do.
so not coming.
Presentation কোথায় গো?
It's not coming.
Identification.
So as we know, an exacerbation in COPD more worsen the disease, and this exacerbation is linked to increased inflammation in the airways, and which is associated with the airway infection. And with the advent of sequencing technologies such as 16S rRNA amplicon and whole metagenome sequencing, we came to know that the dysbiosis in lung microbiome is associated with the exacerbation. So lung samples from the lung samples such as sputum or bile is sequenced to obtain the raw DNA reads, and these raw DNA reads are stored in the NCBI sequence read archive. So I have searched the NCBI sequence read archive for the lung microbiome data of COPD exacerbation with the gold stages, and obtained these two data sets of both amplicon and whole metagenome sequencing. I reanalyzed those data to find the altered taxonomic features as well as the associated altered microbial functional features. So I performed the alpha diversity test analysis and observed that the COPD gold for patients with exacerbation has the significantly lowest diversity than the other groups. The microbiome composition analysis of different groups also showed that the phylum Proteobacteria is most abundant in the COPD gold for patients with exacerbation. So at genus level, I have observed that the genus Moraxella is more abundant in the COPD gold for patients with exacerbation, and the similar trend is seen in the WMS data, where Moraxella catarrhalis, a species from Moraxella genus, is found more abundant in the COPD gold for patients with exacerbation. So next I observed the differential analysis and the microbial markers in different groups, and found that the Moraxella genus is more is upregulated in the gold for patients with exacerbation, whereas Veillonella is downregulated in the gold for patients with exacerbation, whereas Veillonella is upregulated in the stable group, and Moraxella is downregulated in the gold for patients with Moraxella is downregulated in the stable group, and the similar result shows in the WMS data also. So then I performed the differential microbial pathway analysis, and I have observed that there are several microbial pathways related to carbohydrate, fatty acids, and protein metabolisms are altered in each group, such as beta oxidation of fatty acid in Moraxella catarrhalis is more abundant in the COPD gold for exacerbation group. So there are some limitations of my work, such as there is no lung microbiome data available of COPD patients with organized metadata from Indian subcontinent, and sputum may represent the mixture of both oral and lung microbiomes. So in summary, I have observed that the COPD gold for patients with exacerbation has the lowest alpha diversity, and phylum Proteobacteria is more abundant in the gold for patients with exacerbation. And for microbial markers, I have observed genus Moraxella and species Moraxella catarrhalis is more abundant in the cold pore exacerbation group. And I have also observed the microbial pathways and found beta oxidation of fatty acid in Moraxella catarrhalis group is more abundant in the cold pore exacerbation group. So in future, I will try to construct the co-occurrence network to find the dynamics of microbial population, and I'll integrate the multiomics datasets such as metabolomics, transcriptomics, and proteomics to find the microbiome host relationship. Thank you.
All- তুমি বলো।
So, a very good presentation and
Mm.
indeed a very detailed, worked up research question.
Thank you.
But what is your research question?
My research question is like as we know that the in microbiome profile in healthy and the disease condition altered, right? So what are happening in each goal stages? First, if you see the when I perform the alpha diversity analysis between stable and exacerbation group, it showed almost similar kind of trend. But when I divided the exacerbation group into different stages, there are various differences in each group actually. So my research question is like the what is happening in each gold stages.
So, how do you define exacerbation?
So exacerbation is mainly it's not what to say. It's more worsening the disease, like the disease symptoms, dyspnea, or more cough or sputum, and it's because of there is increased airway inflammation in the lungs.
When we see patients in the clinic, we have to define a patient having an exacerbation, right?
Yeah.
So, you are correct by saying that there is more clinical symptoms, more
Yeah.
sputum and all that.
Yeah.
But if you don't have the correct definition in selecting the patients, then there might be what sort of a bias?
Yeah. Obviously.
Which bias?
Um, then we can say like that the exacerbation group fall into the normal COPD group as the stable group only.
No, what sort of bias you might have in this patient if you do not define exacerbation correctly?
I'm actually not clear.
So that's a selection bias.
Selection bias. Okay.
Very beautifully, you have showed us what the limitations of your study
Yes.
is. How do you want to overcome them in the next study that you want to do?
The next study I want to more focus on the viral profile in the exacerbation group. What are the viral
No, what taking in account your limitations.
to counter limitations? For like this, I took the sputum sample. It more mixture of both oral and lung microbiome. So I will take the BAL samples as to represent the lungs. And for the Indian subcontinent, I will try to find more data of from the Indian subcontinent with the exacerbation stages.
Okay, so during exacerbation, you would do a bronchoscopy to get BAL.
Yes, ma'am.
Okay, so it may not sometimes be the right thing to do.
Yes, ma'am.
So a better way of doing the thing would be to do an oral, that is a saliva microbiome, and then compare it with the lower airways, whether they are the same or they are not.
Yes, ma'am. But sometimes the saliva, the oral microbiome may not represent the lung microbiome
No,
actually.
not that. I'm saying it's when you say you get X in your oral microbiome and you get Y in your lung. So if they are different, if you do an analysis of these two differently, you might be able to find out
Yes.
which sample is contaminated and which is not.
Yes, ma'am. I got it.
কি আছে?
Thank you.
In clinical way,
Mm.
how can you protect this your
Okay.
theory?
Okay. Suppose I found the Moraxella catarrhalis group as a marker for goal for exacerbation. It can be treated as both as diagnostic as well as therapeutic. For diagnostic purpose, suppose a PCR can be used to diagnose the disease like Moraxella catarrhalis present. It may be the patient may be going to the exacerbation. Or as therapeutic, someone can give an antibiotic to treat the disease.
হ্যাঁ, ওর নাম কি?
এই তোমার নাম বলো।
Divakar Roy.
One thing I would like the participants to highlight here would be what your research question is. Dibakar answered it, but it was not in the exact format because you need to cover the PICO format when you are designing your research question. So I would like, if you can, I would like each participant to elaborate on that.
Okay.
Thank you, Dibakar.
Thank you.
Thank you.
Thank you, Devakar, for this exciting presentation. Our next participant is Priya Manna from University of Calcutta.
Naam, Priya Manna.
Riya Manna. Arai
Yeah.
Vaye.
All right.
Vaye.
Yeah.
Start your time started already.
Okay. Good morning, everyone. Here my presenting topic is evaluating the effect of parabenzoquinone in guinea pig lung, deciphering the role of vitamin C. COPD and lung cancer are frequently caused by cigarette smoke, and these two diseases are apparently antagonistic to each other. But COPD enhance the probability of lung cancer, and scientists consider these two diseases as the two opposite side of a same coin. Here is a statistics which shows 15% of smokers develop COPD, 10% of smokers develop lung cancer, and 40 to 70% of lung cancer patients have COPD. And so there must be some linking in between these two diseases in the showing the study of comorbidity, and in one paper we get a point there. They suggest as a hypothesis that tobacco smoking increase ROS in lung, which enhance the which enhance the apoptotic damage or emphysematous damage in the lung, and as well as ROS generate oncogene activation, and it promote cell cancer. And the COPD induced repair mechanism, it may be after a long time can activate the oncogenes and cancer promotion. Here, our main background is on PBQ, parabenzoquinone, which is very common pollutant or benzoquinone, which present in everywhere like cigarette smoke, any pollution, and it in form of parabenzosemquinone, and when it go through the lung, it converts to parabenzoquinone. And another our interest is vitamin C, as it play a role as an antioxidant to decrease the ROS generation, and like anti-proliferation, anti-tumor. And these two have a strong connection, which is also established in our lab, that in vitro analysis, PBQ high dose of administration, so that PBQ enhance the emphysematous damage in lung, and it also in low dose of administration trigger cell proliferation. But vitamin C can prevent both of these. And in vivo analysis by PBSQ intratracheal instillation in guinea pig model, it is also shown that emphysematous damage, which gradually increase in PBSQ administration, which is completely prevented by vitamin C. Here our objective is to decipher the molecular link in between two diseases, lung cancer and COPD, along with the role of vitamin C and the role of also PBQ. Here we choose guinea pig as model animal because they are vitamin C deficient animal as human. Here we treated the animal by PBQ injection, intramuscular injection, and vitamin C by oral supplementation. After experiment, we collect the lung sample in 4 time point: 50 day, 30 day, 45 day, and 60 day. Then we perform the histopathological analysis by hematoxylin and eosin staining, Western blot analysis, and oxyblot analysis to detect the oxidative damage. Here in our histological analysis, PBQ gradual increment of PBQ administration shown the emphysematous damage and and which effect is completely prevented by vitamin C. And in case of cell inflammation, congestion, and lymphoid nodule formation, we found several lymphoid nodular form in the PBQ administration, which is cannot prevented by vitamin C. So it is very surprising, or it is very contradicting. And then we study the oxyblot analysis. Here we see that oxyblot analysis, oxidative stress increase due to the administration of PBQ, and which is completely prevented by vitamin C, and PBQ adduct formation is also compressed by vitamin C. And when we study the apoptotic protein expression, then we see that apoptotic protein are increased with the PBQ administration and prevented by the vitamin C. Where we here we study the inflammatory protein expression, where we get a point that inflammation cannot be suppressed totally or by the vitamin C, which then we study the protein, proliferative protein or cell survival protein. Then we also get a point that vitamin C along with PBQ, along with the vitamin C supplementation, it shows greater expression of proliferative marker, which indicate cell survivability increase in presence of vitamin C. So here we can conclude that COPD and lung cancer have some common risk factor like EMT, inflammation, oxidative stress, and DNF damage, which is maybe alter after a long time the total lung microenvironment, and it promote cancer after certain time. But what about PBQ? We actually check this total phenomenon with the respect to PBQ, and what about vitamin C? It's really confusing to us. And PBQ binds with EGFR, and EGFR scientists predict that EGFR is the EGFR plays some crucial role in COPD-induced lung cancer. So we have to study on it further. So thank you, everyone.
Bolo.
The same question which I asked Gulakar, what is your research question?
Actually, my research question is COPD and lung cancer share some common risk factor which may induce to change the lung microenvironment. So I want to find out in with respect to PBQ what change it happens, and my focus is on EGFR pathway. So
when you are formulating a question, what do you finish the question with? A question mark?
Yeah.
So you have to frame a question which is a question.
Yes.
And not a statement or a paragraph.
Okay.
So how would you write your research question once more?
My research question: is there any role of vitamin C in cell cancer, pre-cancerous scenario create along with PBQ or smoking component? We see that by epidemiological study, even with cessation
Just
of
a question. We don't need a paragraph, so it's just a question. Is there a difference in?
Actually, we see some different in PBQ along with vitamin C. It change something like in the level of chronic inflammation and will the cell survivability, which is really confusing and contradictory. So we further study to find it the exact role of vitamin. Is there any advantageous or disadvantageous? We don't know actually.
What is the role of C actually?
It antioxidant. It uh, prevent prevent the emphysematous damage potentially, but in case of chronic inflammation, we don't find any result. So
What is your sample size, or how many samples you
okay,
put?
I have total 24 sample
Can you
guinea
show
pig.
that?
Uh,
I don't remember seeing that.
okay. Here I present just one sample, one slide from each sample, which is prominently shown the emphysematous damage, and and in our further this study, this result shows that which
So
I
how do
said.
you want to take this forward?
Okay. I nearly planned to EGFR pathway alteration member to check the member of EGFR for pathway which may be altered by the by presence of vitamin C along with PBQ, and the next vitamin C, I don't know when vitamin C how work. It's really confusing. So I repeat back my total study for that to get the assure that it works differently, and how to long time of this is only 60-day experiment to, so further experiment with long time, it may be answered something.
Okay.
Let us wait for that.
Yeah.
ঠিক আছে.
না কিছু
So the impression I'm getting from your presentation is that there has to be very clear-cut population intervention, control, outcome, and time for all experiments, be it animal or be it human being. So the problem is that I haven't heard that from Dibakar as well as you. So the next participant might just think about this PICO format. Thank you, Ria.
Okay.
Thank you.
Thank you, Ms. Manna, for the presentation. I would like to welcome our next participant from Bose Institute, Ms. Paramita Roy.
কি করছে করে ফেলে দেবে ফেলে দেবে পারমিতা
Good morning, everyone. I'm Paromita Rai, a PhD scholar working under the supervision of Dr. Shuddha Saha in Bose Institute. Today, the topic of my presentation is meta-analysis of lung and gut microbiomes of asthmatics. So, as we know, the dysbiosis of lung microbiome plays a very important role in development of pulmonary diseases like asthma. Nowadays, studies have also shown that the alteration in gut microbiome also can help in the progression of pulmonary diseases like asthma. So, studying the gut microbiome along with lung can aid in better understanding of pulmonary diseases like asthma. There are also several amplicon sequencing and whole metagenome sequencing studies have been performed with the advancement of sequencing technologies, and there are many publicly available datasets of asthma, COPD, and healthy subjects. But these studies were performed using different instruments and bioinformatics pipelines, so therefore they are not comparable. So my research question is there any specific microbiome, gut and lung microbiome signature for asthma? So to find out the answer, I have reanalyzed this data using a common computational pipeline and compared asthma with another obstructive pulmonary disease, that is COPD, as well as healthy group to find asthma specific signatures. So these are the data. So these are the list of datasets I have used for asthma, COPD, as well as healthy group. The datasets are of different lung samples like sputum, ball, and gut sample like stool, of different assay types like amplicon and whole metagenome sequencing. And this is the workflow and methodology of the work done. So we have analyzed the data, and for the diversity profile, the figure A shows the diversity of lung microbiome, where we can see that asthmatic lung diversity has increased. And in figure B, 3B, we can see the diversity profile of gut microbiome, where we can see the asthmatic gut microbiome diversity has increased. And in figure 4A and B, we are seeing the taxonomic profile, where we are seeing the abundance profile of the phylums, where in asthmatic sputum we can see the downregulation or less abundance of the phylum Firmicutes, whereas in asthmatic gut we can see the less abundance of phylum Firmicutes and greater abundance of phylum Proteobacteria. Next, coming to the taxonomic profile, from the lung amplicon data, we can see the abundance of the genus Atopobium, Haemophilus, and Streptococcus in asthmatic sputum compared to others. And in the WMS data also, we are seeing the abundance of genus Haemophilus in asthma sputum. Next, coming to the analysis of microbial markers, we have identified differential markers of the by analyzing the three groups that are COPD, healthy, and asthma, where in lung microbiome amplicon data we have found Streptococcus, Actinomyces, Haemophilus, Atopobium, and Campylobacter as significantly upregulated in asthmatic sputum. And also in from WMS data we have got the species Haemophilus influenzae, Streptococcus pneumoniae, and Venulella nakazavi as significantly upregulated in asthmatic sputum. Next, when we found the microbial markers of gut microbiome, from amplicon data we have seen that the genus Bacteroides is significantly downregulated in asthma compared to COPD and healthy. And similarly, from WMS data we observed that the species Bacteroides uniformis have been significantly downregulated in asthmatic gut. We have also done the functional profiling, where we have got the significantly upregulated pathways in asthma compared to COPD and healthy, and we have found that the pathways are also linked to the species Haemophilus influenzae. So to summarize, we can say that the diversity profile showed distinct signatures for asthma when compared to COPD and healthy lung and gut microbiomes. 5 major phyla, that are Actinobacteria, Bacteroides, Firmicutes, Fusobacteria, and Proteobacteria, are found in different ratios in lung and gut microbiomes. And the taxonomic profile also showed different abundances of bacterial genus in asthmatic groups in both gut and lung. The differential markers for asthmatics were identified. The amplicon data showed the genus Haemophilus, Streptococcus, Actinomyces, and the WMS data showed the species Haemophilus influenzae significantly enriched in asthmatic sputum. Similarly, in gut microbiome, we have observed Bacteroides and the species Bacteroides uniformis significantly downregulated in asthmatic stool. And we have also found the asthma-specific microbial metabolic pathways. So in future, I would like to identify the gut and lung microbial metabolites from the upregulated metabolic pathways that helps in asthma progression, so we can target the metabolite for treating the disease. I will try to construct the microbe interaction networks to understand the disease condition better, and I will try to test the gut-lung axis hypothesis. and the findings needs to be further validated experimentally using animal model. Thank you.
So this was a really nice presentation and your work is very, very good.
Thank you, ma'am.
Just 2 or 3 things. What do you think is the limitation of your study?
The limitation is I have got comparatively lower the whole genome sequencing data. So the species level study should be more, can be more
Robust.
Yeah.
If you have a greater
WMS data. And another thing is that there are several classification of asthma or subgroups of asthma, but we have grouped it together as we have found that in the beta diversity plots, the clusters are forming together. So we have grouped all the asthma samples together. But if we can see in each groups of asthma, that will be a better approach.
Do you think the inflammation that goes on in the lung in asthma is going to affect your result? Say, for example, eosinophilic asthma might have a different result as compared to a neutrophilic one.
Ma'am, I want to do that analysis to show if there is any difference or not.
So how did you prevent getting contamination from the sputum of the saliva? You know, that's a very common thing. So salivary contamination is very common in sputum induction, which is a reason why when we do a sputum quantitative assay, we need to pick up those portions of the sample where there are less number of squamous cells. So what did you do for your studies?
Ma'am, we are taking the samples from the studies which have already tried to decontaminate the sputum samples. I will try to find out the studies that has been tried to purify the sputum samples for using in experimental.
And how did you plan the purification? What did you do for it?
Ma'am, I have to collected the data.
You haven't? So I think that's one of the major limitations which you need to overcome. So when you see the sample, you have to identify those portions which are less contaminated, and that is done by showing that there is less than 30% of squamous cells in that particular sample.
Okay.
No problem.
Okay. Thank you.
Thank you, Paramita.
Thank you, Paramita, for the presentation. Our next participant is also from Bose Institute, Ms. Shazia Firdaus.
Good morning, everyone. I'm Shaza Firdaus, pursuing my PhD under the guidance of Dr. Sudipto Saha at Bose Institute. And today, the topic of my presentation is identifying differentially regulated pathways and subnetworks associated with allergic disease and cancer. So, as the title suggests, first we need to understand, is there any link between cancer and allergy? And the answer is simply yes. On the most basic level, the basis for this connection is immune system of our body. As we know, in case of allergy, immune cells become hyperactive and overreact, whereas in case of cancer, the immune cells often underreact and induce immune tolerance in the surrounding microenvironment. Therefore, we can say that immune tolerance in both allergic disease and cancer, immune tolerance is desired in case of allergy to control the allergic reaction, whereas it is detrimental in case of cancer progression, whereas it is detrimental in case of cancer progression. Further, according to several reported meta-analysis, an increased risk of lung, breast, and bladder cancer has been identified, whereas a decreased risk of pancreatic and colon cancer has been identified in persons having a history of allergy. Till now, various epidemiological studies have been performed to explain the association between allergic disease and cancer, and the combined study of allergy and cancer is called as allergo-oncology. However, the link between allergy and cancer has not been validated at molecular level. So, the aim of this study is to identify the possible association between allergic disease and cancer at pathway and molecular level. for AO biomarkers. Here, AO biomarkers refers to the common biomarkers shared between allergic disease and cancer. To, uh, to attain the aim of this objective, I have selected two databases. First is the DAV-V2 database to obtain the allergic disease biomarker, and second is the cancer BioExpress database to obtain the cancer biomarker. From BioExpress database, 5 different type of cancer were selected, such as bladder, breast, head and neck, lung, and pancreatic cancer. And the expression trend of the AO biomarkers have identified expression trend of the biomarkers have been considered to identify the correlation between the AO biomarkers. As shown here in this table, a very weak positive or no correlation has been identified between allergic diseases with these 5 different type of cancer. Therefore, next I have focused on pathway analysis. For pathway analysis, I have used ingenuity pathway core analysis, and in IPA, 2 threshold criteria have selected to obtain the AO enriched canonical pathway. First is minus log p-value, and second, minus log p-value should be greater than 2, and the percentage of the overlap with the data set should be greater than 10. Based on these 2 criteria, the significantly enriched pathway for each cancer type has been obtained. Here in this figure, the pathways that is common between allergy and lung cancer is represented. The red and green bar represent the positively associated pathways between allergy and lung cancer, and the blue and yellow bar represent the inversely associated pathways between allergy and lung cancer. Further, Venn analysis was performed to identify the common pathways between allergy and across 4 different type of cancer. For further study, we did not consider pancreatic cancer, as pancreatic cancer did not match the threshold criteria. After Venn analysis, 18 pathways were identified to be common, and these pathways are reported to be upregulated in case of allergy and downregulated across 4 different type of cancer. Here in this table, the list of the 18 pathways is provided. Identifiers of these pathways were extracted and imported to the string database to create a protein-protein interaction network at a highest confidence score of 0.9, and it was identified that among 18 pathways, only 13 pathways have shown physical interaction network for AO biomarkers. The pathways which have shown to have physical interaction network are labeled here in black color. These 4 common subnetwork biomarkers have identified common as across the 13 pathways. Here, the red color of the node represent the upregulated expression of biomarker in a case of allergy, and the green color represent the downregulated expression of biomarker across 4 different type of cancer. So finally, from this analysis, 24 subnetwork biomarkers have identified, and the expression trend of these 24 subnetwork biomarkers have further cross-checked at pan-cancer level, and the result is represented here in the form of a heat map. It have observed that almost all of the cancer have down-regulated expression for these 24 subnetwork biomarkers, except kidney cancer, and lung squamous cell carcinoma have shown the down-regulated expression trend of these 24 subnetwork biomarker, which are significantly reported. To summarize the work, when the allergy biomarkers were compared with cancer biomarker, no association was found, but at pathway level, some positively related, such as interferon, alanine signaling, and inversely related pathways have obtained. Further, 4 small subnetworks have identified to be common between allergy and across 4 different type of cancer. The limitation of this study include that the quantitative expression values were not available for the AO biomarkers, and the advantage of this study include as these 2 diseases are immunologically related, so identifying the expression trend of these molecular biomarkers will help to design new anti-cancer therapies. The future perspective include the experimental validation of AO biomarkers to identify their role as a risk factor or protective factor in mice model. These are my references. Thank you.
Now, do you think that there is relation between allergy and cancer?
Yes, sir. There are like epidemiological findings are present that validate that these disease are interlinked with each other, and on the basis of immunological perspective, like same key immune cells are regulating the pathology of both the disease. Like
So it's an association.
it's an association. So there are epidemiological findings present. We have tried to find is there any molecular correlation available or not.
So what was the sample size?
Sample size here we have taken the biomarkers. We have selected two databases. So the biomarkers that are present in databases are our sample. So we have collected the like we have identified the expression trend. Based on the expression trend of the allergy biomarker and cancer biomarker, we have tried to identify the correlation.
So
Like, is it positively correlated or negatively correlated?
Do you think that more sample size is necessary?
More sample size. Like, sir, like
Maybe validation with a different set.
So this is the future. In future, we will try to find the correlation at the by using the transcriptomics studies or RNA-seq studies. Like from there, a single sample population will be selected, and by using those biomarker, we can try to identify the correlation.
Putting your data, the title of your presentation, would you think that having a pilot study would have been better?
A pilot study.
Because it's just a preliminary data that we are discussing.
Yes.
I do thought of clinical application.
Clinical application, like, so here, like 24 sub-network biomarkers have identified, and here IL-33 have identified, like IL-33 is identified as alarming cytokines in case of allergy. And in case of across these four cancer, it is identified to be down-regulated. So this biomarker is based on this biomarker, we can try to explain the hypothesis that is placed to explain allergy and cancer inverse relationship. So this can be used as a biomarker to try to explain the inverse relation between allergy and cancer. Because it is.
Last question for you, and you have shown us the limitations of the study, but how will you overcome them?
Yes, ma'am. In the near future, we will try to generate some data in our lab by using mice model, and then we can try to identify the correlation. Like mice model, we will generate for asthma model and lung cancer model, and we will try to do some transcriptomic studies, and based on that, we will try to find correlation.
So I think we are done. So very good presentations, but unfortunately, the research question has not been well defined by any of you, excepting I think Ria. Whenever you write a paper or make a presentation, always try to work out the research question, because that helps you writing the manuscript well. So
these all meta-analyses are done from the data available in the net. So we do not know the quality of the data. Those who have placed it on net, or I do not know how the source has taken those data into their repository, and how trustworthy are all these data. Suppose I find an association after doing a dry lab research, it needs to be validated first.
Absolutely.
Otherwise, we can have a possible correlations idea about that, but we can't make sure sort of impression that this is going to be like this. I just want a comment from both Firdaus and you.
Go ahead, Firdaus.
Yes, ma'am. Like this is the limitation. Like we need to we have tried to make a hypothesis, and then we need to validate it experimentally. Like by using these bioinformatics analysis, we have find some biomarkers, and then we will try. The next step will be to try to validate these work on an experimental basis.
Do you know about the mode of entry of a data to a database, is there any filter to
Yes.
satisfy quality,
Yes.
or is there any system? And
Hmm.
what is the size? You are getting into a database. It can be of enormous size. It
Hmm.
can be a small size. We have no idea about the size of the data.
Hmm.
So
So,
I think this is why they
and we don't have idea about the cofactors. Like in our diseases, there are comorbidities. In a allergy-related data, could the comorbid disease related factors, other factors, they have been integrated or not, or just allergy? I mean, a lot of questions can come up regarding the methodology of collection of the data. And once you take a data of allergy, then you have to take into account any other factors, age, sex, height. These are all good
Yes.
things, but lot many other factors. So these questions always irritate your mind once you go and see meta-analysis. And I do not know. And another question is, how far weightage has been given to these meta-analysis nowadays by the scientific community? That you people may be knowing better than us. We are clinicians. We read our textbooks.
So I would not be able to talk about genomics that much, but for proteomics, I think there are databases which have their own credibility. For example, Panther, that's a very good database where it takes into account the cofactors as well. So when the analysis is done, and the results are published, you can see the cofactors which have been mentioned at one portion of the results. So I don't know about genomics so much, but proteomics is like this. Thank you,
Thank you.
Firdaus.
Okay, sir.
Anybody else wants to
Thank you.
ask a question to Firdaus or any of the presenters?
Chalo.
Your question is for when? We close the session.
Chalo. Thank you, brother. Thank you for all the four persons.
I think we'll close the session.
Thank you, ma'am. Thank you, sir. Thank you all the participants for such an interactive session. I would like to conclude the poster session first part on this Hall A, and our next session is for the poster presentation is on Hall B from 2 to 3 p.m. Our next session is from 11, so please enjoy the tea in between. Thank you.
सर नमस्कार आपके सामने nice to see you sir yesterday night I came yes good nice to see you sir
causing some change in the inside the body. This is very, very important for all of us to understand. And as we now know, so allergy is a disease, or any allergic disease occurs by specific interaction between our genes and the environment. So it is the outcome of a gene-environment interactions, like many other non-communicable diseases. So we now say it's an immunologically mediated and allergen-specific hypersensitivity. So that is what we mostly know about the allergy nowadays, and that holds very much true. Okay, so it can be seen in any organ. The hypersensitive reactions can be seen in any organ, but the skin and the mucous membrane, they're the most commonly involved, and it always, and not always, but mostly depends on the route of the interaction of the environmental antigen which causes the allergy, which we call an allergen, and which organ is there. So it could be a skin contact, it could be ingested, it could be inhaled, or it could be injected. So when it is skin contact, we have the atopic dermatitis, or we can have allergic contact dermatitis, or things like that. But it's ingested, like the food and drugs, we can have the food allergies, we can have the drug allergies. Inhaled, like all the pollen grains and the dust mites and so on and so forth. We can have allergic rhinitis, allergic rhinoconjunctivitis, allergic rhinosinusitis, then allergic asthma, and all these vagaries of the nasobronchial tract. Or it could be injected, like injectable drugs, or it could be the Hymenoptera stings. So this can lead on to these are various ways in which the allergen come in contact. So the disease could be the manifestation of that particular organ, or it could be a systemic manifestation of many organs and leading to some systemic signs and symptoms, as we see in case of the anaphylaxis. So it is an environment-induced disease. So allergy would be in the environment in which the patient is residing. So we say that allergy is a global disease with local flavors. That means we in India would be having the allergies to some substances. A person in the Netherlands would be having allergy to some substances. Person residing in the US would be having allergy to some substances. And not only that, whether we'll be having an allergy to a particular allergen or not, it is also decided by all the other environmental features, like what is the parasite load in the environment, what is the bacterial load, what is the viral load, what is our microbiota, what are we eating, what is the type of air we are inhaling, what is the pollutant level in our air, and many factors are there which goes on for the manifestation of the allergic disease in a particular individual. So we know that the prevalence of the allergy is increasing. Why the prevalence of the allergy is increasing? We have many issues. But first and foremost, always remember, climate change has come up to be one of the important factors causing a rise in the allergic disease. Because the climate change causes changes in mainly three types of diseases. One is the allergy, and the cardiovascular disease, third is the infectious diseases. Out of this, allergy is one of the important things. So as we have seen that allergy is because of manifestation of the environment. So it's the climate which decides, with the change in the climate, it decides how much allergies would be there. So that's why there's a big talk about the decreasing the greenhouse gases in the environment, decreasing our carbon footprints, and so on and so forth. So the urbanization, the industrialization, the pollution, the green spaces, the climate change, everything, it goes on for the manifestation of these diseases. And obviously our habits, like the smoking, the diet, the physical activity, the water we are consuming, the food we are eating, so all these goes on to manifest the allergic disease, and which we all call this the exposures. All taken together are the exposomes, and this exposomes goes on for the manifestation of the disease by interacting with the genome. So this is the very simplistic way of understanding the pathophysiology of an allergy disease. That is the type 1 hypersensitivity reaction. Now this is a very simple diagram. So I will just go into a bit of more granularity into it in my subsequent slides, so that you get some holistic idea of what's the thing which is happening. So there's an allergen, which we call is an antigen. Okay. So this antigen, it transgresses the epithelial barrier. It is then taken up by the sentinel cells in our submucosa, that is the antigen presenting cells. And the most important antigen presenting cells we know of are the dendritic cells. Now dendritic cells, they will just take up the, I think that, sorry. Anyway, how do I go back? Yes. And the cursor, yeah. Can you see the cursor? Yes. Fine. So these dendritic cells, they take up the antigen, they process it, and they then present it along with the billboard proteins. The billboard proteins are the major histocompatibility complex proteins, which then actually present the processed antigens or the peptides to the T cells. So they will then present it to the T cells in the draining lymph nodes, and there's the draining lymph nodes. The naive T cells, they then transform into the Th2 cells because of the signals they receive from the dendritic cells. Then Th2 cells then they release the Th2 cytokines, namely interleukin 4, 5, 13, 9. And because of this release of these cytokines, they causes the B cells. Else in the B cells, occurs the class switching of the antibodies. So from the primary to the secondary reaction, IgM then starts forming the IgE. Then the B cells mature into plasma cells, which releases the IgE into the system. This IgE goes and binds to the high affinity IgE receptor on the mast cells, which is present in the interface of the environment and the tissues. That is, it is beneath in the submucosa of the airway epithelium, beneath the skin, in the GI tract submucosa, all these places the mast cells are there. So once this IgE has been formed and it has gone and bound to the high affinity IgE receptors on the mast cells, this phase is called the sensitization phase. So that means the person has got sensitized to the specific allergen once a person is producing the IgE. So what happens when this individual encounters the allergen for the next time? This allergen will go and bind to the high affinity IgE receptor bound IgE. So it will go and bind to the high affinity IgE receptor bound IgE, and there will occur a cross-linking of the IgE which is there on the mast cells by these antigens, and this cross-linking of the IgE receptors is cause a coupling reaction which sends some downward signals and which actually leads to the degranulation of the mast cells, and there is release of the granule related mediators like the histamine, like the tryptase, like the chymase, like the platelet activating factors, and so on and so forth. And also it causes the increased synthesis of the cysteine leukotrienes to the arachidonic acid at pathways. So there they form the various cysteine leukotrienes C4, D4, E4, which are released sometime later. So with the release of this mediator, the signs and symptoms that we see in a particular organ in a particular disease is because of these mediators. So it is a mediator related disease or signs and symptoms which we see in that particular organ. So if it is a airways, the patient comes with the cough, shortness of breath, producing a phlegm, then shortness of all these things, then the runny nose, itching of the nose, blocked nose, and the skin, we can have the skin rash, the irritation, and the GI tract, we can have this nausea, vomiting, abdominal cramps, diarrhea, and things like that. So this is, in a nutshell, a very simplistic way we see that how an allergic reaction happens. That is a type 1 hypersensitivity reaction. So this is what we all know, and this is it suffices the entire thing. But let us go a bit deep into it so that we understand the enormity of the problem. So that's why our outlook towards this disease should also change, and we should have a more holistic approach rather than a very tubular approach of the type 1 hypersensitivity reaction. Okay. So what we know is that T cell, they are important to maintain the tolerance to any reactivity or any reaction. That means we should have the immune system, which on the one hand, it should be protecting ourselves from all this panoply of the microorganisms outside and also from the rogue cells inside. And on the other hand, it should not be so huge that the inflammatory processes, it destroys us. So this balance is what we call a tolerance. This tolerance is an important factor or important parameter of any immune system. To maintain the tolerance, we have the central and peripheral. So T cells, a particular type of the T cells, which is called the regulatory T cells, which is important to maintain the immune tolerance in any organ. Okay. So on the other hand, if the tolerance is reduced, we can have like the allergy, that is the allergy because of the Th2, or if the tolerance is reduced, we can have the reactivity among our own cells, that is the autoimmunity. So reduction in the tolerance actually manifests into different diseases, that is the allergy and the autoimmunity. So this is an important concept that we all have to keep in mind. So this reinstatement of the tolerance is the most important way how you treat or how we treat the allergic diseases. Okay. So this is the innate immune barriers. So any allergen, since we are talking about the environmental allergens, environmental antigens, these antigens have to cross these innate immune barriers. So when they're crossing or transgressing the innate immune barriers, after that only they reach the antigen presenting cells. So that means how the antigens are handled by an innate immune barriers, it decides that whether a person will have allergy or not. See, it's not that everyone will have the allergic diseases. Why? Because majority of our epithelial barrier, it acts excellently well and it is able to evade the organisms or any protein or allergens, whatever it is. So only in few subset of the individuals where it is not able to evade that and it just thinks it to be something very dangerous. So it's a dysregulated function of the innate immune system, which actually starts the entire orchestra of the responses which we have later, whether innate and the adaptive, both. So that means the starting point is how these allergens or antigens, they are seen by the innate immune cells. Maybe we call it we can say the epithelial barrier, which first comes in contact with the allergen, and how they respond to it. That is the most important thing. And this is the concept which should be ingrained among all of us. So it is the disturbed or dysregulated epithelial functioning which results in the allergic diseases. This disturbed or dysregulated epithelial functioning can be because of the epithelial injury. This epithelial injury could be caused by many viruses. Out of that, most important are the rhinovirus. Influenza is also very important. Then this allergen proteases, because these proteins in the allergens, the enzymes, like the house dust mite allergens, like we have the pollen allergens, or the environmental factors like the cigarette smoke, the diesel exhaust particles, the ground level ozone, the things like that. All these things causes a disruption of the epithelial barrier, or they disturbs the epithelial integrity. So this is very important. Now see, once this epithelial integrity is disrupted or disturbed, this decreases the barrier function. So this in one way, it causes the loss of the good barrier function which is needed for this innate immune cells to prevent the subsequent reactions that we see in case of the allergy. And so what these epithelial cells do, the epithelial cell sees this as a threat and they start sending the alarming signals. And these alarming signals are in the form of the cytokines. The major three cytokines that we talk about are the thymic stromal lymphopoietin, TSLP, IL-25, and the IL-33. And we talk so much about the TSLP these days, and we have the anti-TSLP molecules which has come into the clinical practice for the treatment of the severe asthma. So epithelial integrity is the key factor. Epithelial integrity lost because of some environmental insults, it results in the dysregulated or dysfunctional activity of the epithelium, which then targets the cells beneath it to react accordingly. So again, a bit we go close to the void, the loss in the epithelial integrity could be lost in the tight junctions between the epithelial cells or the mucosal membranes. That is what we see in allergic reaction. They gets disrupted. It could be many things. It could be the tight junctions. It could be adhesion molecules, or it could be the intracellular signaling molecules which are dysregulated. So on nutshell is that the epithelial integrity is actually disturbed. Now what happens? Once the epithelial integrity is disturbed, then this epithelial cell will start sending signals beneath to actually bring in the effector mechanism of the innate immune system to fight this threat. They see it as a threat because the allergens that become a threat. Now what are the main two effector mechanisms of the innate immune system? As I was talking, one is the antiviral state, which is not important, but the most important innate immune mechanism which is used by the body in any infection, any inflammation, anything is the inflammation. So we know that majority of the non-communicable diseases nowadays are inflammatory diseases. So it holds true for the allergic diseases. These are all the inflammatory diseases. Beneath what is sparking the entire thing is the inflammation. And this inflammation is the chief effector immune mechanism of the innate immune system. Now what they have to do, they are seeing a threat. The epithelial cells send a signal. See, there's a big enemy outside. Now you have to tackle that. I am not able to control it because it has evaded me. So now you start doing something. So now the innate immune cells comes in. So it is mainly sentinel cells. That is the dendritic cells, the mast cells, and the tissue resident macrophages, which will come in, send the signals, bring in the neutrophils, other cells of the innate immune system, which mainly belongs to the myeloid series of hematopoietic cells, and they will cause a big inflammation over there. Now it's important to understand, see, the inflammation occurs in many of the diseases. Okay, what's so special about the inflammation in the allergic disease? The special about the inflammation of the allergic disease is that this inflammation is actually a particular type. So that is, we say that it is a T2 or a Th2 inflammation, where there is mostly the eosinophils come in, the Th2 cytokines, IL-4, 5, 9, 13, which orchestrates and also perpetuates the entire thing. So to have what type of inflammation we'll have in the cells is dictated by the epithelial cells. The imprint or the signals is given by the epithelial cells. See, this is the type of injury. This is the type of the inflammation we should have. So if it is, they release the TSLP, then it is basically, or IL-33, they will have, the dendritic cell will give that signal to the naive T cells in the draining lymph nodes so that they produce the Th2 cells, and we have the Th2 environment or T2 environment or T2 mediated inflammation. If it is some other bacteria or some other things, they'll give the interleukin 12 or interleukin 8, and they will have some other sort of the inflammation. So you see how this epithelial cells has orchestrated what pathway of the inflammation that individual will have. And obviously triggers are the exercise, allergens, cold air, oxides of sulfur, and the particulate matter. So this is the driving of the inflammation, which is very, very important. That means the inflammation stays on. We have the concept of the minimal airway inflammation in the airways in asthma, and this inflammation is because it is being driven by the epithelial cells all the time. Like they will release the stem cell factors, which is necessary to make the mast cells stay in that interface. They will release the TSLP, which will actually release the chemokines 17 and 22, which will attract the Th2 cells, memory Th2 cells in that site. And also they will attract the dendritic cells, and they will attract the eosinophils. And this is the type of the inflammation which is entirely being orchestrated by the epithelial cells. So this is the main pathophysiology of the allergy that we know of. And this is what is important, which is actually maintains the disease and causes its perpetuation. A very new concept which has come up, something called a non-atopic allergy. So I'm just mentioning it because we need to understand the increasing role of the various members of the environment of this. One of the most important are the bacteria. So it is the bacterial superantigens, maybe the staphylococcal superantigens, which can actually directly cause the release of these alarmins, and also Th2 activation and maintain the eosinophilic inflammation irrespective of the environmental allergens. So this is what a concept is coming up. So it's important to understand that also. So the key message to take home is that allergy is a T lymphocyte mediated disease who is the king cell of the allergic reaction. Okay. But very important to understand what the king does. The king actually will give the instruction. Yes, you do this, you do that. But the king has to be informed about the state of affairs by the council of ministers which he has. Okay. So among the council of ministers, the most important are the epithelial cells and the dendritic cells, which actually give the specific information to the king to actually pass the information or give the instructions to fight the battle accordingly. Okay. So epithelial cell, it drives the allergic reaction. B cell, they are only the foot soldiers. Okay, what they do, they will release the weapons, that is the IgE, which is going to go and fight with the allergens. And the eosinophils, they are also the foot soldiers. They maintain the inflammation, releases lots of proteases and other chemicals which is needed to fight that allergen in that particular organ. So in summary, allergy is an immunological disease. A classical example of gene environment interaction. T lymphocyte is the culprit cell. It's an old disease with newer discoveries coming up, and epithelial cell is the most important hidden player. Thank you.
A small announcement: in Hall B, we are starting occupational lung disease symposium. So those who are anyway interested to be there, kindly requested to go to Hall B.
Thank you. So now we have another very interesting talk. There's a rational use of the anti-allergy medications, which is very important for all of us to understand in day-to-day practice. And for this, I would request Dr. Shambho Shamra Shamazda to please come on dais.
At the onset, I want to thank Dr. P.S. Bhattacharya sir for giving me this opportunity. And I'm really thankful to my mentor, Professor Shoibal Moitro sir, for guiding me all through this process of learning about the allergology. So maybe next 15 minutes, I will try to finish this topic on rational use of anti-allergy medications. So let's start with one case and assume as a pulmonologist, you are visiting one of your patient who is referred by one orthopedic colleague, and he had suffered from a fracture of neck femur. So pulmonary medicine referral was done for OT fitness. So you have an interest not only to check his lungs, but also to check what are the medications that are ongoing. And you are astonished to see this galaxy of medications. So I just want to name some of them, like a fixed dose combination of pregabalin, nortriptyline is there, along with Montelukast plus levocetrigine was there, plus ambroxol, along with one DPI glycopyrrolate formoterol budesonide combination. Over the counter, he was using hydroxyzine 25 milligram twice daily for last 1 month for urticaria. So now you can think, what is the reason behind that 3 episodes of falls and finally which leads to a neck femur fracture. Second case, which I had personally get in my clinic, that patient, 29-year male, suffering from erectile dysfunction for last 2 months, married for last 6 months, medical history of migraine. So he was taking clemastine, antihistamine, 10 milligram once daily for last 3 months for his allergic rhinitis and urticaria. And also she was consuming cyproheptadine 4 milligram twice daily for last 1 month. For migraine, she was on amitriptyline, pantoprazole plus domperidone for last 6 months. Again, now you can see what are the medications that could be responsible for this particular problem of erectile dysfunction. So when we talk about rational use of medications, WHO had given a clear-cut definition for rational use of medicines. First of all, patients receive medications that should be appropriate for their clinical needs. So clinical diagnosis is first of all very important. Then the dose of the medication, the personalized dose, and for duration that is adequate, along with the cost, the affordability. And that is why we often being taught about these 5 rights for our patients. These 5 rights are the rights of the patients also. The patient should be right, that is the clinical diagnosis should be the right one. Then the right drug at right time, right dose, and finally the right route. How we can have that, all those 5 R's? So we know these great people who are the Jawans, the CRPF Jawans. We proposed one strategy by which we can actually have this CRPF in our eyes to promote rational use of medicine, and that is CPRRF. So what is that concept of CPRRF? Actually, clinical pharmacological reconciliation, review, and feedback. These principles, if we apply in our day-to-day clinical practice, that can help us to reach the goal of medication without harm. First of all, as we can see in our 2 cases, the drug-induced disorder, which is a very common disorder but a neglected differentials. We need to treat adverse drug reactions to prevent their recurrence, and that is why by which we can actually avoid the prescribing cascade. That means I am using one drug, that drug is causing some adverse drug reaction, but without stopping that particular drug which is responsible for that adverse drug reaction, I am thinking this is a new disease and I am treating that adverse drug reaction with another drug. So this vicious cycle will be going on and on. Ultimately, the patient will suffer. So we need to prevent that cascade. And for that, we have a very good strategy to deprescribe those drugs. Substitutes within class also can eliminate this type of interactions. And almost of us should acknowledge we should have some special prescribing considerations while writing drugs for renal or hepatic compromised patients or elderly pediatric patients and even the geriatric group, pregnancy group. So we actually proposed these 10 principles on this CPRRF, and which had been accepted by American Journal of Clinical Pharmacology very recently. We had proposed 10 steps by which we can promote the rational use of medicine. First of all, we need to check whether I am writing whatever I am writing that is needed for our patient, or that I am not writing something which is actually needed by the patient, identifying omissions, commissions, especially during the transition of care, and individualization of therapy, identifying the adverse drug reactions, adherence improvement, of course the affordability and availability of medications along with the adherence, and polypharmacy, rationalizing it in elderly population with enhancing quality of life. So when we talk about all those weapons we have to treat allergy, these all are the list, but this is not at the complete list. There are other drugs too, but mostly maybe for next 10 minutes we'll try to focus more on those first part, that is antihistamines. Apart from that, we have cysteine leukotriene receptor antagonist. We have corticosteroids, specifically the non-systemic corticosteroids. The rational use of inhalational or intranasal corticosteroids that sometimes often missed by our prescriptions. And I think you all, the pulmonologists, are promoting the use of this inhalational and intranasal corticosteroid as much as possible where it was required. So that is also need to be promoted to facilitate the rational use of medicines. Of course, we need some immunomodulators, and we have that mast cell stabilizers, allergen immunotherapy. We have a discussion on that allergen immunotherapy with a pioneer in this country, Professor Rajkumar will tell us about that. Of course, now that this is a use of monoclonal antibodies and we have targeted therapeutics. Bronchodilators, decongestants, they are important for symptoms relief, and some other medications like vitamin D, crisaborole, which is a drug now being used for atopic dermatitis, and others that will come. So what is good prescribing? It is not a snapshot like things, and to promote rational use of medicine, we need to think this as a prospective project. So it is not only about the therapy initiation. We should have a proper dose titration, along with sometimes we need to deprescribe some drugs or sometimes add some drugs. So this is a whole galaxy of steps. So that we had done what we had presented the two cases. The anticholinergic burden is something concerning issues in our country. We had seen this is a community-based clinical pharmacology clinic. So we had found a significant patients who is receiving multiple drugs. They have high anticholinergic burden, and this anticholinergic burden is sometimes associated with cardiac autonomic neuropathy, which is very detrimental for our health. This is a list of drugs which is commonly noted as anticholinergic burden 1, 2, 3 scores. According to that, what is important, if a prescription containing anticholinergic burden more than 3, so that is something significant, that increase the chance of different atrocities associated with anticholinergism. So the first case we can see the fall, the elderly man who had an anticholinergic burden of almost 8. And when it is the second case, the erectile dysfunction case, the anticholinergic burden, it was 10. So if we just identify this anticholinergic burden associated with antihistamines, and if we can add those with concomitant drugs, so we can have a clear idea about the anticholinergic burden the patient is having. And if we do a rational deprescribing here, we can omit those side effects. Now coming to the second generation antihistamines and their renal in a renal impaired patients, we will discuss a few important issues. We can see from this slide, when we talk about ibastine and fexofenadine, they generally required no dose adjustment, whereas levocetirizine, they required some dose adjustment, and bilastine, when it is used with some concomitant drug like P-glycoprotein inhibitors, we need to use it cautiously. In the hepatic compromised patient, generally bilastine, desloratadine, fexofenadine, and levocetirizine, they do not require any type of dose reduction. And when there is some patients with cardiovascular disease, we need to be cautious, especially about the QT prolongation issues. But for fexofenadine, levocetirizine, and bilastine, along with also desloratadine, there is no specific issues. Also in pregnancy, the first generation antihistamines are mostly safe. Yes, the hydroxyzine and promethazine are pregnancy category C drug, but others are category B. Along with second generation antihistamines, we have cetirizine, levocetirizine, and loratadine, which can be considered as class B drug. Fexofenadine is often used in pregnant ladies, but there are certain studies which had shown the fexofenadine associated IUGR, and loratadine also, there were some case reports associated with some congenital anomaly with loratadine. So when we talk about antihistamine use in elderly population, so that is again something important, especially when we use fexofenadine. that does not have any contraindications, but there are certain limitations of using cetirizine in elderly patients, and especially when there is kidney function is compromised one. Along with, if we talk about bilastine, generally it is tolerable in elderly population, but as we had mentioned, if that patient is taking some other drugs like ketoconazole or erythromycin or even diltiazem, even the grapefruit juice, they are the P-glycoprotein inhibitors, and that can increase the concentration of bilastine. So otherwise that is also a safer drug. So one thing is important to note when we talk about antihistamines, we often think that this is an antagonist of H1 receptor, but it is not. This is an inverse agonist. So it is not only blocking the receptor, but also doing some inverse reaction when binding to the receptors, as we can see here. And that is something concerning because there are other histamine receptors inside us. We have H2 receptors that we all know, but we have also the H3 and H4 receptors, and the specific functions of H3 and H4 receptors is being studied, and there are certain concerns if we block those receptors, or rather inverse agonism to those receptors, that may cause some serious adverse effects. And that is why there is some cry of not using antihistamines for long durations. We know this concern with promethazine. If we use in pediatric population, there is some serious behavioral adverse, and that is why it comes under the black box warning. And what is important to note again, there is a concept against antihistamines that if we use it, it may produce tachyphylaxis, but a very well-designed study had shown it not produce any tachyphylaxis in the tissue level too, and it was with 10 milligram of cetirizine and 5 milligram of levocetirizine of 180 days treatment that does not produce any tachyphylaxis. But as we started with one case was using over-the-counter antihistamines, and this was a very important message we should promote to our patients about not to use over-the-counter antihistamines, specifically the first generation antihistamines. And you can see in the COVID time there was also the TikTok time, and there was a Benadryl challenge which had cost a lot of young patients' health. So another few concerning areas with long-term use of antihistamine, and that is actually associated with that H4 receptor modulation. We don't know exactly what happens if we stimulate H4 receptor inversely. So there were some studies which suggest if there is histamine 4 receptor activated in opposite direction, that may proliferate some tissues, and if we can stimulate H4 receptors, that can prevent some oncogenesis. So that is why there are certain cries against long-term antihistamine use. This was a study which had suggested some increased risk with antihistamine use more than 9 months with glioma, and antihistamine use and esophageal squamous cell carcinoma increased risk. That was also seen in this particular study. So we have some other agents too. So if we call about montelukast, that is we know the cystenyl leukotriene receptor antagonist. And if we go by this systematic review and meta-analysis, which had shown this is a very efficacious drug when we talk about cough variant asthma in terms of total effective rate, FEV1 percentage, PF percentage, FEV1 and PF ratios, and also the ADRs. In every aspect, they had shown some benefits, and we use montelukast, but at the same time, we need to think about the serious adverse reactions associated with Montelukast, and that is come in a FDA black box warning, which advises restricting use of Montelukast in allergic rhinitis. So what is important, Professor Moitro had beautifully described in allergy the beauty of balance. We need to be very much balanced while taking any decision of using any therapeutics. So this is the specific black box warning we need to think about, and that is why if we go by the ARIA guideline, we can see the use of Montelukast is not that much promoted, and that is why they are promoting use of intranasal corticosteroids and intranasal corticosteroids plus agilestin combinations. And why this is? Because in all the symptom score they had a benefit compared to the oral antihistamines. Along with, you can see the leukotriene receptor antagonist, the efficacy was much lesser compared to those intranasal corticosteroids plus and intranasal antihistamines. Even in allergic conjunctivitis, both in seasonal or perennial, the role of using Montelukast or oral antihistamine is secondary. First of all, we need to use those topical agents, and here also we need to emphasize the importance of immunotherapy. In allergic rhinitis guideline, ARIA guideline, they are also promoting the immunotherapy, allergen immunotherapy. And this time of precision medicines, we talk about biologics. There are newer biologics which are coming. I think there are separate sessions for this topic. I am not going in details of this, but we need to think about this more and more. Only issue is the cost. We know how the different biologics, like if we could talk about benralizumab, which can not only block the IL-5 receptor, but also they are recruiting the natural killer cells. And we have dupilumab, which is a dual blocker of IL-4 and IL-13, and we have mepolizumab, like IL-5 blockers. We have our omalizumab, which is an age-old molecule, but yes, there are certain roles still present, especially when we talk about Urticaria guideline. Independent of IgE values, we can use omalizumab in case of chronic spontaneous urticaria after antihistamine, after four times dose of antihistamines and Montelukast. Then we can use this omalizumab there before using cyclosporine. So the take-home message. So first of all, we need to acknowledge the number is increasing day by day, and we need to promote the healthcare seeking behavior, because this is very much neglected, and that is why even today the over-the-counter use of antihistamines are increasing day by day. We need to promote, we need to tell our patient about the hazards of unnecessary use of these antihistamines. Early diagnosis is important, because if we diagnose early, if we initiate early treatment, that can prevent the progression of the disease. And balance is the key. Balance is the key of any rational therapeutics. We need to do the balance between safety and efficacy of each drugs. And of course, there will be a discussion on allergen immunotherapy. There is also the rule of 5 is important, about to select the right patient, right drug, right composition of the immunotherapy at right time, at right dose, and of course in the right route. So again, I want to finish here. One thing is not mentioned, which is very important in managing allergy also. There are evidences coming up, and we use the terminology of balance many times. The balance is the key of life, and our ancestors told us about yoga. Yoga is something which also need to be promoted, and our great teachers once had told, Yogastha kuru karmani swangang tvaktva dhananjaya siddho asiddho samo bhutva samattang yoga uchyate. So samattang is the law of life, and we all should follow this principle of balance while managing allergy. Thank you very much for giving me this opportunity.
Thank you, Dr. Shamazdar. I think that was an excellent talk. And this clinical pharmacological reconciliation review and feedback is an important concept which has to be inculcated by all of us in our day-to-day practice. Okay, next we move on to our next very important two talks. One is immunotherapy for asthma, when and how, and then the Indian allergy guidelines, what are the salient points for the practitioners. And for these two talks, I would request Professor Rajkumar to please come on stage and give his deliberations.
Good noon, everyone. And at the outset, I thank Dr. Parthasarathi Bhattacharya for inviting me to this program. And I just saw the schedule of the program. It's a very good program which he has been doing. I think regularly he has been doing, and I congratulate him for success of this program. Now, my duty in 20 minutes is slightly different. In 20 minutes, I have been given two talks. One is the immunotherapy for asthma, when and how, and another is the Indian guidelines for the diagnosis of respiratory allergy, particularly respiratory allergy. So these are the topics which I have been given. Now, the first lecture which I am going to take actually should have been taken the last one, but still I will just try to see that everything goes in a smooth way. And these two lectures I'll be taking together. Before I start, only three things has to be understood when you are doing a allergy and immunotherapy practice. Number one, history taking is very important when you are discussing about diagnosis of allergy. History is very important component, because if you take the history properly, then further you are going to do the allergy testing, further you are going to do the allergy and immunotherapy. So means immunotherapy you are going to do. What I mean to say that if you do if you take the history in a detail, then only you will understand that this patient is allergic. The allergy test need to be done in this particular patient, first point. Second, when you have understood that history has been taken and you have understood that, okay, I am going to do the allergy testing. So your planning of the allergy testing is also the second component, which is very important. So which are the allergens I need to do keep in my kit so that I can do the allergy testing. So selection of the antigen is very important. Now you have selected the antigen also. Then you do the allergy testing, and then you understand and positive reaction or negative reaction. So interpretation of the reaction. So means we have done the allergy testing. Now the results are there with you. So how to interpret is the second component, very important. But because sensitization is different than the allergy. So you have to understand that component also. And then when you have understood about the patient and you come to know that this patient is allergic to that particular antigen, then you proceed for the thinking of immunotherapy or avoidance. So the third part is to understand the reaction and then accordingly do. So now again your history taking is very important, because you need to correlate the allergy testing test with the history of the patient. If it is correlating, then this is important, then only this is allergy, otherwise this is just a sensitization. So the third component is again going for the immunotherapy, and then you, of course, how you do the immunotherapy is another point, and of course avoidance is the best policy for these kind of the patient. So three component: history taking, then you're doing the allergy testing, and then interpreting the result and going for the immunotherapy. So these are the three components in which basically whole my lecture will be there for another 15 minutes and so. So I bring greetings from Vallabhbhai Patel Chess Institute, and these are the topics which I am going to touch upon, because it's very difficult in 15-20 minutes to tell everything, but still. So another part I have taken, the cases I have taken, about 4 or 5 cases I have taken, so that we can discuss. We'll spend some more time on that cases, and then we proceed basically for the diagnosis guidelines and so on. So again, if you see, this was the guideline which was made in 2017 about Indian immunotherapy guidelines, which has been published. So here also the focus is history taking. History taking is very important. And then again, diagnosis, how do you do the diagnosis? And then third, allergen avoidance. If you are able to avoid that allergen, that's the best policy. That's the best policy. Don't go for the immunotherapy. Avoid it. And of course, the next is the immunotherapy. So this also you need to understand when you are practicing allergy and immunotherapy, what is sensitization and what is allergy. Because sensitization, when you do the skin prick test, you get a positive reaction, you get a positive result. But that positive result does not mean that the patient is allergic to that particular antigen. Many times what happens, you do the test, positive reaction has come, and then you label the patient allergic to that particular antigen. You ask them to avoid it, or you go for the immunotherapy. That is not correct. You need to sit down again with the patient, and then you need to correlate the positivity with the history of the patient. And again, if it is the history and the sensitivity is correlated, then you label these patients as allergic and do the management and so on. So there is a difference between sensitization and the allergy. Now, allergen immunotherapy. The allergen immunotherapy is an immunomodulatory method of the treatment of Ig-mediated allergic diseases to control the symptoms and decrease the sensitivity towards allergen by giving sequentially increasing dose of antigen to induce the shift of the immunological response from Th2 to Th1. So Th2, whenever it goes high, then basically the allergic reactions start. So your whole thought mechanism of immunotherapy is to convert from Th2 to Th1, which Dr. Saibal had very nicely explained in his first lecture. So again, you need to have the balance. And if this balance is disturbed, then the problem happens. So what happens in the allergic individual? This balance is disturbed, Th2, and then actually what you do in allergy and immunotherapy, you balance it, and so you try to change from Th2 to Th1. That is the concept with the. And again, in the immunotherapy, when you are giving the immunotherapy, initial there is a rise of the Ig level, and then there is a fall. So whoever is giving the immunotherapy, if there is a benefit within 3 to 4 months, that's a psychosomatic. Scientifically, it is not there. Rather, there is an increase in the Ig level. So basically, there will be increase in the symptoms rather than decrease in the symptoms. So that is also very important when you go do the immunotherapy and so on. Indication of the allergen immunotherapy, we are dealing with the bronchial asthma, but rhinoconjunctivitis, then your venom allergy, and some cases of the atopic dermatitis also have. Now, selection of the antigen is very important, which I told you, and the level of evidence for the allergens are maximum with the house dust mite, then the pollens, then the molds, then the animal epithelium, and then venom and the cockroach and so on. So actually, what do you treat? You don't treat the reaction, you basically treat the clinically relevant allergen. That's also you need to keep in the mind. Again, sensitization. You don't treat the positivity. You treat the allergy basically. Again, there are 2 types of the allergen and immunotherapy. There are slit immunotherapy and the slit immunotherapy. I am not going into detail. Both works basically. There are ample of data are there which clearly says that both works, and compared to the placebo and so on. And when you are giving SCIT, there are different ways, conventional way of giving the immunotherapy. There are sometimes daily dose, cluster immunotherapy, rush immunotherapy. I'm not going to go into detail about that. the whole theory of the immunotherapy is slowly you increase the concentration of the allergen, slowly you increase the amount of the allergen, and slowly you increase the distance between two doses of the allergen. And actually this way basically you start with the 1:5,000, then you increase to 1:500, 1:50, and then initially you give twice in a week, then once in a week, then once in 3 weeks, and once in 4. So initially there is a build-up phase, and after the build-up you need to have the maintenance phase. That is very important in case of the giving the immunotherapy. So lot of data are there. There is a improved efficacy over the symptomatic medication, then increasing efficacy, reduction of the inflammation, reduction of the hyperreactivity, then the long-term efficacy is there, then prevention of the, and this is very important in case of you are giving the immunotherapy, there is a prevention of the new sensitization. So if you give the immunotherapy, the new sensitization is reduced compared to the control. Lot of data are there. And then if in case we have seen that the patients of the rhinitis, ultimately 70 to 80% of the patient develop bronchial asthma later on. In case of the immunotherapy, if you treat the rhinitis, the chances of developing bronchial asthma drastically reduced. All data are there. And of course, reduction of the steroids. And it works for the longer period, maybe sometimes for about 12 years and so on. So lot of data, I will not go into detail about that. Lot of data are there. This is the one of the case. His case is there, which I will just read it. A 48-year-old male presented with the complaints of the breathlessness, cough, rhinitis for 8 to 9 years, and he was on the low dose ICS and the LABA combination with SABA as needed and Montelukast levocetirizine combination 2 to 3 times weekly. Symptoms are perennial with more occurrence during the October and November, and symptoms were more at the home during the evening. His father and the uncle were also suffering from allergic rhinitis and so on. And these IgE, then your absolute eosinophil count and the PFT, these data are there. So what do you do basically? Suppose this patient, I want to go for the allergy testing and so. So this patient is a male, breathlessness is there. He has got the perennial symptoms with the acute exacerbation in the October and the November, and more problem in case of the home in the evening. So now when we discuss about anyone, means what are the allergens we need to keep in our tray to do the allergy testing? Anyone want to comment on this? Because as soon as this kind of the history is there, you want, if suppose you are going to go for the allergy testing, then you need to prepare your kit also. What are the allergens to which I am going to test it? Anyone? Pardon? Okay. So the why house dust mite? So the patient has a indoor, mostly in the indoor in the evening. So it's a so maybe why only house dust mite? I can have the insects also. So now here we need to have idea that what are the indoor allergens are there, and which causes the perennial problem sometimes also. Again, anyone else want to just put anything more? Apart from your house dust mite, insects, pardon? Mold, okay? Pollen. So pollen also is very important, because if you see the history, it's a October and the November. The patient has a problem, exacerbation during October and the November. So that means there must be something which is prevalent at that particular month. So the pollens also need to be taken into account. So now with that, our tray is ready. You have to go with me only. Your tray is ready. So you have put the tray in which all the antigens which are prevalent perennially and the indoor have been kept for the allergy testing, and some of the pollens. Now again, here is very important that we cannot keep the tray with all the pollens. It's very important, because in the market, if you go and see, in the market there are 200 allergens are there for the testing and everything. That is not advocated basically. So there, the role of the pollen calendar comes into the picture. That means you should know the flora or fauna of Calcutta rather than having the flora and fauna of the Himachal Pradesh or something like that. We should know what are the allergens which are prevalent, pollen allergens prevalent in Calcutta, because you are going to test the person who is residing in the Calcutta. They are not exposed to the allergens which are there. So again, flora and fauna idea. So the pollen calendar is very important. So now we need to keep the allergens which are more in October and November and which are more prevalent in Calcutta. So these are the allergens we need to keep, and then we do the allergy testing. Again, I told you these, if yes, then what are the allergens? I have already discussed with that. Now, whenever you are doing the allergy testing, your testing room should be also perfectly planned and everything. Wherever you are doing the test, adequate light and everything will be there, should be there, and your chart, your paper and all those things should be there. So skin prick test was done, and this is the result of the skin prick test. Anyone who wants to just comment on this skin prick test? Anyone? Yeah, you can comment, no problem. Yeah. Partho, can we have 5 minutes, 7 minutes more? Okay, good.
So first and foremost, that the individual's controls are fine. So that means we can test is good, well, properly done.
Okay, so his comment is test is okay basically because the control and your histamine is there. Okay, they are reacting and they are fine. Absolutely, yeah.
Yes. So if we go by the premise that anything which is 3 millimeter and more than the negative control is positive, so we get the sorghum to be positive, the gandropis to be positive, wheat dust to be positive, house dust mite to be positive, housefly to be positive, mosquitoes to be positive. So that is by that premise, all are showing the positive sensitizations in this test.
So this interpretation is because we at our institute we have lot of allergens to which we do the test, and these were the positive tests. But again, in your center, because we'll be discussing that also in the guidelines, so you need to keep the allergens which are prevalent in that particular area. So after that, basically there is a pollen calendar. The role of the pollen calendar comes in between. Here the sorghum was also positive, and the gynandropis was also positive in case of the allergy testing which was done, apart from your house dust mite and the insects and everything. So now how we need to interpret this also. Suppose we are going to go for the immunotherapy in this particular case. So what are the allergens to which we are going to do we are going to go for the immunotherapy and so on. So now because shortage of the time is there, so for me sorghum and the gynandropis basically is not significant. You will say that it is there in the August, September and October, so why it is not very important. But for me, the perennial problem is there. So perennial problem is that the house dust mite is the important component. And in case of the house dust mite, in the winters or these August, September rainy season and everything, the quantity of these allergens increases basically. The house dust mite allergen increases. So for me, if I go into detail history and everything, then ultimately I will choose that I will go for only for the house dust mite, and I will do the again pollen calendar is there which I told you, and then ultimately the SPT was positive with all three, but since it is most significant positive with the house dust mite, and house dust mite can increase the problem during September, October and November. So only one allergen I will choose, and I will go for the house dust mite for doing the test. And again, I told you that the house dust mite, you start with the 1:5,000 and then 500 and then 50. Slowly you increase the concentration of the allergen, and slowly increase the amount of the allergen and the distance between the two doses of the allergens. So again, If suppose the person does not want to go for the immunotherapy, and so the patient doesn't want to go for the immunotherapy, and the person says ki, okay, something else need to be done, can be told to us. So again, avoidance, basically how to avoid it. So there are already literature, there are already datas are there how to avoid house dust mite and so on. So I think I will not go for the second, third case. We'll go to the second component of my lecture, and if the time permits, then we'll revert back to the again cases and so on. So coming to the Indian guidelines for the diagnosis of respiratory allergy, this is the first time which was consensus statement was taken by around 30-40 doctors, all the allergy practitioners, and then it has been published in the Indian Journal of Chest Diseases, the Indian Journal of the Journal of Allergy, Asthma and Immunology. So in this again, the key component are allergy history, physical examination, confirmatory test, skin prick test, and of course basically how to correlate it with the history of the patient or no. In these 3 groups were made, and all these 3 groups concentrated about, first group concentrated about history taking and the relevant allergen. Then the allergen in the respiratory allergy, means there was a lot of questions, lot of hue and cry was there, which are the allergens should we keep in our basket to do the test. So we came out with the conclusion that okay, pan India or a person who is there in the north, south, east and west, wherever practicing, these are the common allergens. You can test it, and then again you can delete the allergens or you can add the allergens as per the pollen, as per the pollen calendar of that particular region. Already we searched PubMed, Google's, then your around 3,000 national and international journals, and around 1,000 articles were studied in detail and whose reference has been put into this guidelines, and we consulted all the other guidelines which have been published across the world and so on. And then again, classification of the level, evidence and the grading and the recommendation was taken into account and so on. And it was a questionnaire based basically guidelines was made. So history taking and the examination is one of the component, one of the very important. Again, I re-emphasize this because after history taking only you are going to go for the allergy testing and so on. So I will not go about detail about all the questions, but wherever it is needed, I will slightly emphasize on that. So what are the common respiratory allergic diseases has been taken into account with all the references. What are the symptoms of the respiratory allergy? What are the signs of the respiratory allergy? Age of the onset of the phenotype? What are the family history of the, then importance of, again, what is the importance of area of the residence regarding respiratory allergy? That has been dealt into detail. So from where the person is coming, from the rural background, from the urban background, so knowledge about the area wise allergen predominantly helps in the identification of the allergen, then subsequent followed by appropriate testing and the treatment and so on. Then what is the relevance of the indoor and the outdoor symptoms with regard to the respiratory allergy? So if the symptoms are more outdoor basically, then the allergens will be different. If the symptoms are more indoor, the allergens will be different. So these also has been dealt into this guideline. Then again, symptoms. So symptoms increases indoor or symptoms increase outdoor. So accordingly, basically, which are the allergens which has to be taken into account. What is the importance of the seasonal variation? Again, change of season. So the pollens is very important. Which are the pollens which are more prevalent in the April, May or the October, November? Then what is the significance of the work and the occupation exposure of the respiratory allergy that has been done? What is the significance of the recurrence of the symptoms on the repeated exposure of the particular allergen has been taken? Again, food allergy has been taken separately, and for the food allergy, I just wanted to put across the golden standard for the diagnosis of the food allergy is the double-blind placebo-controlled control trial. There is a far difference between the perceived food allergy. The perceived food allergy is around 60%, but the actual food allergy is around 4%. So please, when you advise your patient that don't eat this particular food, see that the person is actually food allergy. Otherwise, don't advise to stop. What is the relevance of the treatment history? Of course, treatment history all is very important, because when you do the test and everything, you need to see that the patient is not on other drugs which interfere the test and so on. Then the part B was the allergen in the respiratory allergy. So again, it was very methodically what are the allergens which are prevalent in our country. We have gone into detail about that, and all the allergens name has been written, their local name has been written, in which month basically these allergens are prevalent and in which area they are there. So for every, like north, south, east and west, we have divided into 4 parts, and then accordingly this has been dealt into very detail basically. Then what is the role of the pollen calendar? Yes, the role of the pollen calendar is very important, and the pollen calendar is important in the respiratory allergy for taking seasonal prevention. And what is the importance of the pollen count? Respiratory pollen count is also very important basically. Pollen count, we are doing at Vallabhbhai Patel Chest Institute the pollen count, which has published for the public also, and I think the pollen count station should be everywhere, just like the pollution level and everything, and that's very important. Again, detail we have gone, because the 30 to 40% of the people are sensitized with the house dust mite, so we have gone into detail about the what is house dust mite, and then about the fungus we have gone, about the insects we have gone, then the common dog dander, animal dander, we have got into detail and everything. How will you choose the allergen for screening in the allergic disease in patients, adult patient and asthma? Here basically what we did, because lot of people were doing the allergy testing with 100, 200, 50 or so and so. So we tried to give a box which has a pan India, and then the north, south, east, west, what are the common allergens which are prevalent, and accordingly basically you can delete it or add whatever the allergens are there. So these are north, eastern, western, everything is there. So you can take that guidelines, you can implement it at your place. And so the last part of guideline was basically a lot of controversy is there, which test need to be done, diagnostic, in vivo test, in vitro test. So for that also the questions were was put, what are the in vivo test for the diagnosis of the respiratory allergy? Of course, skin prick test, intradermal test, patch test, allergen provocation test. These allergen provocation tests are not routinely done. These are the tests which need to be done in the tertiary or the research center. And what are the in vitro tests for the diagnosis of the respiratory allergic diseases? So I think some of them we will be discussing here. Which test is better for the diagnosis of the respiratory allergy, in vitro, in vivo? So skin prick test is still the golden standard for the diagnosis of the allergy. Skin prick test. What test is considered to be the gold standard for this? I have already mentioned. What are the qualifications? It's very important. Sometimes a lot of hue and cry comes. What are the qualifications required for performing in vivo allergy test? Nowadays, till now, nowhere even the diploma or the MD or the DM is going on as per sanction of the NMC basically. So we thought ki how to come out, who are the people who should be doing allergy testing and everything. So the allergy specialist or the physician or a pediatrician formally trained in allergic testing should perform in vivo allergy testing. It's a 3A. The nurse technician trained in the allergy testing can also perform in vivo allergy testing under the supervision of the experienced allergy physician, 3A. An experienced physician well versed in the management of the anaphylaxis reaction, along with all the necessary equipment for the same, should be present whenever in vivo testing. It's very important whenever you are doing the test and everything. Your emergency tray should be ready at your. What is the appropriate time for performing the test performed? It should not be performed in the acute phase. And what are the indication of the skin prick test, which already we have basically done? What are the contraindications that you can put it? What is the lower lower age? That's also very important. Sometimes the question comes, what are the lower limit of the age for performing SPT? The based on the literature review and the experience with the expert panel, it is recommended that SPT should be done, preferably done in the children more than 5 years to A, and with the strong clinical indication, SPT may be done in children less than 5 years under the supervision of the pediatrician, because few pediatricians were also there in this guideline board. And what is the maximum number of the allergen, that I told you, that depends upon you. Basically maximum you recommended the maximum 60, but it should be maybe 15, 12, 15 or 20. That should be enough for doing the test and everything. How should you your patient prepare for the allergy testing? This is a practical demonstration, allergy testing room, different forms, then how the procedures, how to interpret. Just it was told it should be a wheel diameter of more than 3 mm of the negative control should be taken into account. What are the complications? What are the indication of the intradermal test? Then the relevance of the IgE in the diagnosis of the respiratory allergy. What are the indication of the specific IgE? Specific IgE is only done in case there is a contraindication of the skin prick test only. But some of the food allergy, basically 1 or 2 food allergy tests, specific IgE is taken into account for the diagnosis of the food allergy. And the role of the nasal provocation test, I told you that these provocation tests should be done in the tertiary center because it's tedious to do. And what is the role of the FeNO, and that was also taken for the patient of the assessing the treatment response with the asthma has been taken. So what I mean to say, this already it is there. Anybody can search it from the these 2 sites, and they can take the help of these guidelines. And just once I just wanted to show you, this is our allergy testing room which we have at our institute. It should be like lighted, well lighted when you are doing the test. When you are doing the test and everything, the patient should be comfortable. The person who is doing the test should be also comfortable. Oxygen and everything should be there. And with that, again, I thank Dr. Partha Sathi for giving me the opportunity to share some of my views on this allergen and immunotherapy. Thank you so much.
Thank you, sir. So now I would request Dr. Ornashish Hota and Dr. Tashankar Malik to please come on dais, and Professor Rajkumar to be seated, please, over here, and Dr. Shambhu Shamrar Samazdar also. So we'll have a panel discussion, maybe 2 or 3 salient questions we can have. So first of all, I would request Dr. Ornashish Hota and Dr. Tashankar Malik if they have any questions for Dr. Rajkumar, if they want to ask anything. Question.
Sir, I have a question that allergy immunotherapy basically is a balance between Th2 and Th1. So when we decreasing the Th2, whether the chances of increasing Th1 and causing autoimmunity disorder, there is any possibility?
No, there is no possibility as such, basically, because these inflammatory markers and everything is going to reduce, and this modifies basically. At the molecular level, there is a modification from Th2 to Th1, so there is no chances of having the autoimmune diseases after giving the immunotherapy.
I'll just add that if you have seen my first slide, where there was a balance between the autoimmunity on one side, allergy on the one side, and this autoimmunity is maintained by the T regulatory cells. Allergy immunotherapy mainly entails to increase the activity of the Treg cells to maintain this balance. So it's not that one is tipping over to cause another disease. It's not that. It's increasing the tolerance.
So first of all, I will thank every speaker for nice deliberation and detailed presentation. So before that, I asked Dr. Professor Rajkumar, is there any your experience regarding that during the test, any anaphylactic reaction or any should we keep the intubation facility before advocating the test? So do we commonly do it in our clinic or any your views actually?
Yeah, so there can be reactions basically, but our experience we have seen basically one or two anaphylaxis, which usually managed by adrenaline. You should have a tray prepared. All the emergency drugs should be there, so that if you give the adrenaline immediately, that's going to take care. But I think one or two cases I have seen throughout my 25 to 30 years of the career.
Any incidents of intubation? Any?
No, I have not till now. No incidents of intubation and everything. One of the food challenge we were doing, and that was patient who reacted to that food challenge test, and then we could manage the with just adrenaline, and though there was some bronchospasm also, so bronchodilator was given.
Okay, thank you.
After immunotherapy, any antibody we have to monitor, like IgG4, IgG41, like this antibody, and how long we have to monitor?
The recommendation is very clear. Nothing has to be monitored. Only the symptoms, basically medication score and the symptomatology has to be monitored. Although for the research purpose, we were monitoring the inflammatory markers, and we are doing the inflammatory markers. But as per the guidelines, then nothing. Only the symptoms and the medication score need to be monitored. That's all.
Yes, for the effectivity of immunotherapy is a composite symptom medication score which we have to monitor. Measurement of the IgG4 or the interleukin 10, they are all in the research basis. Okay.
Just one question to Dr. Sambo.
Yes.
If there is any, there are many situations there are polypharmacy is required. So as a physician, we cannot trace the maybe interactions of the drugs. Then what should we do? Should we recommend any clinical pharmacologist before taking any decision?
No, actually for polypharmacy many time can be a legitimate one. So we often use the terminology as rational polypharmacy. So if you yourself can also assess the prescription, just you need to give some more time. And there are also some easy tool now available. I had shown in one of my slide about that anticholinergic burden calculator. So if we just put the drug's name, they will give you the calculation of the anticholinergic burden of particular prescription. And according to your clinical need, you can deprescribe one drug and you can use alternate medicines, alternative drugs. So it is not only to just refer to someone else. Yes, if you feel referral is required, there are certain clinics who are doing this type of services like prescription reconciliation, review and feedback services. They will send you back what are their observation, and according to your clinical decision, you can think the how to modify the prescription, how to reduce the burden. And there are other tools also. When we talk about elderly prescribing, there are Beer's criteria, there are stop-start criteria are there, or even in your internet, you just check the medication inappropriateness index. So there are 10 questions. So you have to just answer for each drug. The 10 question is there. So you just to put that question and the answer, what you are feeling about one particular drug, and the app will give you some numbers. But again, that need to be correlated with your clinical decision making, because app is not the absolute thing. So that also we need to keep in mind. Thank you.
Thank you.
Okay, thank you. So now I would like to ask the same question to both Dr. Anushish Hota and Dr. Tarashankar Mullik, that you please answer according to your experience. Okay. So what do you think is the place of the estimation of total IgE in allergy practice, or in diagnosis of allergic diseases?
The total IG in case of, total allergy IG is indicative only maybe positive in allergic ABPA, or not in the diagnosis of asthma or anything. Only ABPA could be a specific allergen specific IG had some role in the food allergy actually. Is that already Dr. Professor Rajkumar has mentioned. So no specific diagnostic role in diagnosing asthma or any food allergy. There is some role, or ABPA mostly.
Total IG, I will send for total IG in asthma patient to not for only just allergy purpose. If it is more than 1000, it will direct that there is a possibility of ABPA. and after confirmation of diagnosis of ABPA, it will help for treatment also to increase the dose of steroid or taper the dose of steroid. And also if Ig also in Indian context, the Ig is also high, and we also look for the parasite infection for before giving some omalizumab or mepolizumab. Parasite anti-parasite medicine also should be given if Ig is very much high.
Professor Rajkumar, sir, what is your take on total IgE?
For diagnosis of allergic disease, no, I agree for the ABPA that is okay, and we have put this also in the guidelines also.
Thank you very much. So I think this message is very clear and succinct. There is no role of total IgE estimation in the diagnosis of allergy as of now. If we think of allergy, we have to go for a skin prick test or maybe specific IgE to aid our diagnosis. Thank you very much. I thank Professor Rajkumar. I thank Dr. Shambhu Shamra Samazdar and the panelists. And we conclude this session today morning. Thank you.
So after this lively session, we are now going to pass to our next program, which is the lecture by the awardee of Acharya Prafulla Chandra Roy, who is Dr. Somiran Ponda this year. And to chair this session, may I request Dr. Robin Misra, one of our senior faculty from Kolkata. Dr. Misra is known with vast experience in treating diseases, and he has been a guide to all of us in several activities. I hand over the mic to Dr. Misra to introduce Dr. Ponda, and after that we'll pass the memento officially to him.
Dr. Somiran Panda, alumnus of National Medical College and School of Tropical Medicine, is a renowned clinician scientist of more than 2 years standing. He is a leader in the field of HIV prevention and care in Southeast Asia. Research area Dr. Panda currently focuses are on evidence of policy and action related to retrovirus vaccine in India, diarrheal disease outbreak investigation in natural disaster setting, health of women and children in underserved areas of Sundarban, and epidemic situation of bloodborne infection in the northwestern border of Punjab. He has made substantial contribution through his research in the field of public health. Dr. Panda was associated with NICET and also holds position in decision-making bodies of the Department of Biotechnology, Government of India, Ethics Committee of Academic Medical Research Committee. He has worked as consultant of World Health Organization in the delivery of antiretroviral therapy for injection drug users. For last 2 decades, he played a key role in supporting National AIDS program in India. He was also director of National AIDS Research Institute. He is now editor-in-chief of Indian Journal of Medical Research.
Thank you, sir. It's my august duty to request Dr. Ponda to take chair. I've had a long-term association with him since my college days, and he has scaled himself to a much higher level. Please come. And I request, may I request Dr. Misra to hand over this memento to Dr. Ponda. So, Dr. Shomiran Panda, sir, the stage is yours.
All right. So, good afternoon. And as the title says, it's all about uncertainty. So probably it won't be right to be with uncertainty for half an hour. That was the time period for the speech that I'm supposed to. Maybe I will try to shorten it as much as possible. But whatever we decide to do here, those of us, which includes the audience here and also those who are not in this room, to find out an answer to a question, we have to live with uncertainty. So during my presentation, I will try interact with you. So if you are quick in terms of responding, then it makes my life easy and your life easy, because we will be able to finish this talk as quickly as possible. Whenever you look at the term uncertainty, what comes to your mind? Anyone? We need not to shy away. We are trying to, yes? Okay, everything meaning, particularly what kind of feeling? We are in the medical field, maybe in the medical research, or even clinical management, but we are not sure all the time. So whenever, yes, sir.
The heading was chaos, predicting the unpredictable. That was the heading. Now, I didn't understand anything about chaos theory, but I liked the way he started the article. In the beginning, he said, if I get a cold and fever and go to my doctor, I would like to hear something like this. Take this tablet, 3 tablets a day for 5 days. By day after tomorrow, you should be fit enough to join your office. And in about 7 days' time, this will pass away. And then he comments, I am asking for a lot. I am not only asking for a cure, I am asking my cure to be predictable. You see? And there is a famous quote by a man called Julian Huxley. He is the younger brother of Aldous Huxley. He said, you can predict the sun, the moon, and the galaxies, but you cannot predict where the housefly is going to sit next.
Excellent.
So
excellent.
That's what you will have to live with.
So
why Jyotishis are so popular?
Yes.
Because they predict.
Yes. So I take it from there, and whenever we talk about uncertainty, the terms we are familiar with is confidence interval. We create a proportion for any disease, whatever we are seeing, or even a mean, and there is an uncertainty bound. And then wrongly we say the mean of this particular attribute will fall if we know about the universe, and the mean, it will fall within this range. Absolutely wrong. Mean will not fall anywhere. Mean will stay wherever it is. So it is our experiment that has created this bound, and it's a possibility that 95%, if we are talking about 95% confidence interval, 95% of the times if we do the experiment, our mean would fall within this range. Universal mean doesn't change. So it's all about uncertainty and us feeling comfortable with the uncertainty. So uncertainty, of course, as Dr. Parthasarathi Bhattacharya said, everything, meaning fear, panic, and whatnot. So about uncertainty, these 2 years are very important. 1697. Why so? I will tell you. So swans, and if we think of swans are all white, gorgeous looking. And in 1697, William D. Fleming, he was in an expedition in Australia, and then he came across a black swan. Till that time, we believed that all swans are white. So it's all about an evidence, even if it is one. That was one black swan which said, no. Proposing this as an axiom might go wrong. And 2002, what is so important about it? I will draw your attention to what is written on the slide. It was Donald, Rumsfeld, the defense minister and the secretary. He said that, well, we know what we know. And most of the presentations yesterday and today were delving upon that, which is a good thing. to refresh our memories. But some of the presentations, and particularly from the young researchers and the clinicians, which I had the opportunity to listen to yesterday, and a little bit of discussion today, which talked about we know that it needs to be known, but we do not know that as yet. So with a little bit of push and experiments and inquisitiveness, we might try know what is yet unknown. So the first thing is known. So we have to have something known. Otherwise, how do we manage patients or deal with problems? But then there are certain things which we don't know, but with a little bit of effort, it is possible to try know that. And there are things which we don't know that we don't know, which is unknown. And I'll come to this. It is not just philosophical. It actually hit us, the whole world, shortly within the past 3 years. So numbers are there everywhere. I was having lunch yesterday, as all of you were having upstairs, and then a clinician was sharing her anxiety with Dr. Arunalok Chakraborty, saying, "Sir, we are coming up with a whole lot of cases in the hospitals. How do we present it? But if we present it in a journal, it's all about the cases that I'm seeing. So it's all about the cases, their age and sex distribution, the severity and all. And what does it mean? So because it is all about numerators, what we are seeing. But when we talk about numbers, if they stand alone, they are actually weak. So, but if the numbers are examined against a context, then they speak. And they can really be very engaging in nature. So they're not cold numbers. They're quite exciting if we know how to think about the denominators and context. I will share one of my favorite most quote, which Einstein said. He said that things that count in life and in our practice even may not be countable. So everything is not in the digits and the numbers that you think. So things that count in life does not necessarily can be counted, and all the things that can be counted may not count in life. So only describing a group of patients and their attributes may not mean anything until and unless we don't know how to do it. And sometimes the qualitative description of things matters, and that is not just the number. And then as we so let's say we buy food products, it is in the can, and what do? We lift the can and try see what is the expiry date with the manufacturer. Do the same thing with the numbers. I will request experienced ones know that, but the young minds, I will request that whenever you come across numbers, you say, okay, what is this saying and what is it not saying? And is it saying something from an ideological spin or political spin? Try know that. I mean, no harm in talking things very frankly and openly. And then, is it a number which is being examined against a denominator? So what is the total picture against which I am seeing something? I'll come to some of the stories shortly. I do not know. While Sir was introducing me, very kindly he talked about my work with the injection drug users. These are the buildings and the open spaces that you are seeing. These are the addiction treatment centers. But on the left-hand side, it is from one of the neighboring countries. And the man who is injecting another man on the street, he is known as HIT doctor. So he is also a doctor there. So don't think of you and me as a doctor, only doctors who are doctors. There are terms like HIT doctors. Why so? Because they are injecting buprenorphine, which is an addictive substance. And he is known amongst his friends as HIT doctors because he can find the veins very easily. And that's the scenario. And while I was moving from one addiction treatment center to another, I saw something among the young injecting drug users who are trying to give up their habit. And they were having something like this. All of you know this is multidermatomal herpes zoster. And the age group of those young people whom I was visiting was 15 to 20. Which is not a common age group for herpes zoster. Herpes zoster you expect either in children or elderly people where immunosuppression happens. So I will come back to the question that I came across during lunch yesterday. So this was happening with the numerators in the addiction treatment centers. But when we went to the hospitals, and amongst the hospital outpatient attendees, we tried to record how many were from herpes zoster. So it was an institutional data. And yesterday, the lady doctor who was interacting with Dr. Ronulak Chakraborty, she was asking exactly that question. So I told her that your denominator could even be outpatient attendees. So if you have outpatient attendees, you see that the line which is going up, that immediately followed the upper two graphs, they followed exactly HIV epidemic that happened. So listen to this story very carefully. Young injecting drug users, they were injecting drugs, they were sharing their syringe and needle. That was the reason for a rapid explosive epidemic of HIV. That's the big line which goes from below to the top. And then the upper two lines which are following are herpes zoster. So while a group of young people, they were suffering from HIV, herpes zoster being a marker of early immune deficiency, immediately there was an herpes zoster epidemic which happened. So that's called satellite epidemic of herpes zoster in Manipur, 1994. I had much more hair, okay, those days, and I was a little thin, but whatever I wrote from Manipur, the British Journal of Infection thought it was interesting and they published it. But the point I'm trying to make is that even if you are you are attached with a hospital or a treatment setting, maybe you do not know what is out there in the community. But if you look at the numbers in the context, what was the context for me? The context was injection heroin use. The context was the HIV epidemic. And I was seeing something in the addiction treatment centers. Then I went back to the hospitals, and when I looked into the data, the numbers. So here comes the numbers and how to look at them. I realized that a satellite epidemic was happening which nobody bothered to care for. And this actually helped to serve as a surrogate marker for HIV test, because people were scared. They don't get themselves for HIV. So if there is a young guy who is coming to you with multidermatomal herpes zoster, it could serve as a surrogate marker for you to suggest, why don't you go ahead and do an HIV test in order to know why are you having this? Okay, so that's one of the story. Now my question to all of you, can you figure out who this person is? And this sentence might appear a bit confusing to you. If you are wrong, you were right. That will come to later on. But anybody wants to take a guess? Who is this? Because this is the person who is considered as the greatest biomedical research philosopher from Austria. Okay, I will help you to get the name, but listen to what I am saying in terms of explaining this sentence. Karl S. Popper, 1994, he expired, from Austria. Greatest philosopher. Why? What he is saying is directly linked with the swan story that I told you. You are wrong. When I am saying you are wrong, that's a present tense, right? I am wrong now. Why? In the light of the evidence that has come out today. So before that piece of evidence, which is available now and which has proven me wrong, until then, I was right. So with the available evidence, we said, oh, all swans are white. So it was a right statement. But when the contrary evidence was generated, so that's the crux of all medical research that we do, even clinical trials. Clinical trials try to generate evidence, and you say, no, null hypothesis, they are same. Null hypothesis you never accept, right? You reject it. So they are same, and then when you reject it, you say, no, it is not the same. So clinical trial is based on exactly this philosophy. Now, we all faced, Dr. Ganguly sir was talking about uncertainty and the probability and how much is certain about what I am saying to my patient or to an inference that I am talking. So these are a couple of faces with the masks below there, and that's a caricature of masks. But the questions were: does mask work? Does steroid work? Does vaccine work? And even Anjanda was sharing a video clip with me and saying that What do you think, Shomiran, about it? Because you are at the helm of affairs in terms of the vaccines. Do the vaccines work? Because people are saying that even after 2 years or 3 years, increased blood clotting and associated cardiovascular phenomena and the strokes, those are happening in increasing number. What is your take on that? So whenever we see something, we have to see this in the context. That's the point I'm trying to make. And does convalescent plasma work? And do the vitamins and the antibiotics? The cell really went up during the COVID-19, not knowing that whether they work or not. So the point I'm trying to make is that we have to live with uncertainty. And if we know that any evidence that we generate, anything that we say has got certain uncertainty around it, then during pandemic, it becomes easier for us to step back and think. Not to respond from a knee-jerk reaction, because pandemic is also associated with another word, P, not panda. That's my family name, of course. But pandemic goes with panic. So when we are panicked, we are unable to step back and ask questions. We do things which are out of panic. So a knee-jerk reaction. And it has been finally found out that many of those convictions proved to be wrong, except for steroid, of course. That was a great thing, but I will come to that. Even wrong usage of steroid, what did it do to us globally? There was the satellite epidemic of mucormycosis. Why am I bringing this here? Because in Manipur, I was telling you, sharing with you the story, there was HIV epidemic, following which there was herpes zoster epidemic. So there was a satellite epidemic. And what was causing that? It was caused by the main epidemic of HIV. So it was not due to any human endeavor. But here you see the bar diagram that you are seeing is, again, this is hospital-based data. So what I'm requesting to all of you, the young researchers and the clinicians here, even if you are attached with a treatment center, it's possible to look into the data carefully in order to figure out what is happening. So the bar diagram and the highest bar actually indicates when there was increased number of COVID cases getting admitted. And the red line is a graph which talks about mucormycosis. So it is a satellite epidemic, but it was happening due to inappropriate use of steroid in too much dosing and for too long a period. So the tapering, which was supposed to happen very quickly, did not happen. So this was an immunosuppression which was happening due to inappropriate use of steroid in a pandemic setting out of panic. So what all I'm trying to say is that it's very, very important for us to examine the numbers in their context and trying to understand what are the numbers talking about, and to know how much certain are we about the numbers that we are talking. So we face problems. If there are clustering of herpes zoster cases, if there are clustering of mucormycosis, or anything that we are seeing, because the lady doctor who was talking with Runalok Chakraborty, she was talking repeatedly about something happening, something coming to her notice in the institute that she is associated with. So finding ways out, and there are hurdles, and we have to be aware about the hurdles in terms of fear. Okay, we are trying to find an answer. What will happen if I fail? So you have to overcome that, because if you always suffer from uncertainty is fine. So let's accept that we might fail, but what could we do so that the failure rate would get reduced and the uncertainty will be there, whatever I propose or I suggest, but then again, the uncertainty can be reduced depending on my method of collecting data. So we are talking about breakthroughs. And in order to be able to breakthrough can happen even at home, on a daily life, at the clinic, or even at the hospital. But for breakthroughs, we have to recognize this risk of fear and failure, and then how to overcome that. Now I will quickly go to the story of HIV outbreak in a village named Unnao. I'm sure some of you know, it's a 3 hours drive from Lucknow in UP, and it was happening in a village. All of you know how is HIV spread, and there were no injection drug users, and no prostitution, sex work, unprotected sex. So how do you explain HIV outbreak in a village? And we had the opportunity to be invited because sir introduced me as once upon a time I was the director of the National AIDS Research Institute. So nobody expected the director of a National AIDS Research Institute to go and have a meeting with the panchayat there and with the BMOH there and also setting up a laboratory there, because my life is with uncertainty. That's why I chose this title, Walking a Path with Uncertainty. And then what we realized, look at this table carefully. So HIV positive people, we did a case control study. HIV positive people and HIV negatives in the camp, they tested. So we had the database, and I had a surrogate marker of hepatitis C, and you see the hepatitis C antibody prevalence amongst those who were HIV positive was significantly higher, 85% compared to 56%. But there was another indication. Those who are HIV negative, how come 56% of them are hepatitis C positive? So something is going wrong here. And this was about the same syringe and needle being used in therapeutic setting by so-called traditional doctors. So you see, there is no injection drug use, there was no unsafe commercial sex, but we realized that unsafe injecting practices were happening. Jhola jab doctor aap कहते हैं ना, जो village setting में they use the same syringe and needle with a cocktail of medicine. So if I give 20 rupees because I am poor, I get 1 milliliter of shot. If Partha Bhattacharya, not a doctor but a villager, if he can pay 30 rupees, he gets 2 milliliter or 3 milliliter of the same medicine from the same syringe and the same needle being used. So it's in that setting when HIV is spreading, and we were able to even do a phylogenetic analysis, and phylogenetic analysis said very clearly that the HIV had a monophyletic origin and the hepatitis C which was spreading. So it is not just one epidemic. Two epidemics were going on, hepatitis C, and that was monophyletic in origin. That means there is a single source from where it was spreading. And then you can see that satellite epidemic, that pattern you can identify, or even the HIV outbreak that you could identify. It's all about your willingness to live with uncertainty and your willingness to solve puzzles, knowing that you might fail. Now, what helps? This small little guy who is on the shoulder of another person, that guy can see farther, not because that small little person who is on the shoulder has a very good eyesight. No. Probably he has poorer eyesight than the tall person. So it is on the shoulder of the tall person, that position. So always try to remember, because I remembered what I saw in Manipur, and that helped me during COVID to figure out, hey, this is a satellite epidemic, what is happening. Similarly, if the previous researchers have done something, even if they have succeeded or failed, doesn't matter. But recognizing what has happened before, so on the shoulder of the giants, you are able to see farther. So that's exactly what is very important for us to know. And then I have come to the end phase of my presentation. Let's assume that you have succeeded. All the young researchers here, clinicians, you have succeeded. And you want to tell the world, what have you found out? So you want to write it up and publish, and you will be rejected. So uncertainty there as well, okay? So you have done a great job, but not necessarily you are able to publish. So will you take a call on who these two persons are? Anybody? I can give you a clue. These two, and if you call that invite, this person on the left-hand side, young looking, he would present he will start his presentation with those letters. The upper left is a rejection letter from nature. The lower one is actually an enlarged view of the Gastroenterological Society of Australia. That's again another rejection letter. So it's all about rejection letters. And you will say, hey, what's that? That's not interesting. Rejection is not interesting. None of us wants to be rejected, wants to get rejected. But we do get rejected. We do get rejection letter when we try to publish our articles. So he starts with that, and they are Nobel laureates. No. They are Barry Marshall and Robin Warren. Robin Warren was a pathologist, and Barry Marshall was a clinical registrar working with him in Australia. And Robin Warren said, why don't you study this interesting bacteria which is comma looking, Helicobacter, yes, you are right. So Helicobacter pylori, its association with dyspepsia and peptic ulcers. So rejection is going to happen. If it has happened with the Nobel laureates like them, for the same work, they got the rejection letter. So let us accept that there will be uncertainty, not only in conducting the research, not only in terms of our fear and feeling inhibited, but even if we have succeeded in completely, or in somehow having some idea about what could cause a clustering of herpes zoster or what could cause a mucormycosis, it is still possible to get rejected, and it is possible to live with it. This person is a favorite person of me because of the poems he writes, Charles Bukowski. And forget about writing and sending it to the journal and getting rejected. It could even be writer's block. You want to write, but you are blocked. How do I have my first sentence? What do I write in the introduction? And he is saying writing about a writer's block is better than not writing at all. Excellent. Excellent. So, okay, I'm having a problem. Let me write that. What is the problem I'm facing? So that's the need of the hour. I mean, I went through all of this. So I think that this whole session was geared towards Dr. Parthasarathi Bhattacharya wanted me to say something which would help the young clinician and the young minds and the young researchers. And I think this is very important for us to realize. That's my last slide. But here I'm saying that it's okay to feel stupid. Relative stupidity is about our school days. Okay, some of our friends will know the answer to the question that the teacher is asking because he read the book, I did not read the book. So that's relative stupidity. Relative to him, I am feeling like stupid in the class. And there are absolute stupidity and then productive stupidity. Productive stupidity is all about research. You are trying, you are productive, but still you are feeling that you are stupid, you are not able to find out the answer. And then that leads to diving in the unknown. Because you are ready to, but if you think that, anything that you are attempting, you are not able to make a headway, probably you are not taking enough initiatives. So this is a freely downloadable article. Maybe you can print it and keep it on the table where you comb your hair, or every day you see yourself. I have one that I'm not going to share right now. And on the upper right hand side, I should have a disclosure there. So that's a book by Peter Meravois, and he's a Nobel laureate. He's saying advice to a young scientist. My disclosure is, if you buy that book, I don't get any cut money from the sale of that book. Okay, that's a disclosure statement. But whatever you do, another book which we cannot afford not to read and not to possess our own copy is The Immortal Life of Henrietta Lacks. Because HeLa cell, we all know about HeLa cells, and HeLa cells are used, but Henrietta, actually from Henrietta Lacks, it is HeLa cell. No permission was taken from her before taking, because she was suffering from cervical cancer. And those are the immortal cell lines which have been produced. And there is a movie even. But if you are interested in all these aspects, do buy this book and possess. That's ethical research. So in the zeal of conducting a research, josh jisko hum kehte hain, so with that we should not forget that there is no scope for doing things unethically, because whatever we do, it has to be based on ethical considerations. Thank you very much for your patient hearing.
Absolutely great, and he has fulfilled my expectations more than what I expected. And what all messages he has sent to our junior young minds is very worthwhile to remember. And finally, I would say that when he said that you work hard, you try to publish something, but it is not published, so that's where the uncertainty. We can do anything, but at the end of it, we do not know whether we'll get a result. So that's how I felt at the initiation of his lecture. I said everything is uncertain, but the uncertainty gives you a push. Well, let me try, see something I can go beyond my boundary or so. So thank you, Shomiran, for all your efforts, for giving us such a wonderful talk.
No, thank you.
So we are really obliged. Thank you. I hope everybody has enjoyed. You will find him available in the lunchtime for interaction. Thank you, sir, for your chairmanship. So with this, customarily, we do not allow this questions after the guest lectures like that. But we'll pass on to the next session, which is somatizations and reaching to a pulmonologist with problems. And that is, the topic is dysfunctional breathing and others. And can I request Dr. Vishwanathan, Vishwasharan as a speaker to join and to chair the session. We have Dr. Somnath Kundu, who is a professor of the SSKM Hospital and is a renowned pulmonologist in Kolkata, and Dr. Bishwajit De. Dr. De, please. Dr. Somnath, please, sir. I request them to invite Dr. Vishwasharan and initiate the session.
So we invite the speaker, Dr. Vishwasharan, please, to come up and to say about a topic. The new name is there. Actually, we used to say psychogenic dyspnea, hysteria, functional disorders, but this concept has now structured as dysfunctional breathing. And many of us must have faced this problem in some situations or the other, especially when it coexists with organic disease. So it will be an interesting talk. Dr. Vishwasharan, kindly introduce yourself and go for the discussion.
Thank you, the chairpersons, and first of all, I'd like to extend my gratitude to Dr. Bhattacharya sir for inviting me here. It's always good to be back in Calcutta. And generally, we are invited to speak more about interventional pulmonology, but this time, sir has given me a very interesting topic, which is somatization as pulmonology problems. Though it sounds little theoretical, but this is what is most of the cases we see in our routine OPD practice. Many a times, you will see patients coming to you just with somatization, and we inadvertently treat them with so much of medications, which is really not needed. So having an awareness about somatization is of utmost importance, especially if you are a clinical person, because this is something which you are going to deal in and day out in your clinical practice. And greetings from Yashoda Hospital, Somajiguda, where I am currently practicing and where I am also conducting my fellowship program in advanced interventional pulmonology. So what is really a somatization disorder when it comes to a pulmonary practice? It is a group of breathing disorders, and it results in chronic changes in your breathing pattern, which can manifest as either a dyspnea or even often a non-respiratory symptoms, like patient coming to you saying that I feel weak most of the times, I'm not having energy, I'm not having a drive, or sometimes they come even to you with a pseudo-hemopsis or a factitious hemopsis. And sometimes patient may say that I'm having a febrile illness which has been undiagnosed, and he would have visited so many doctors before landing up with you. And it can occur in the absence. That means the patient may not suffer from any of the problems, but he may manifest symptoms. Or sometimes the patient may really have a problem. Let's say patient is having an asthma or a COPD or an ILD, but the symptoms that he manifests is in excess of an organic respiratory disease. So even in that case, it can be a somatization. And it can be a functional breathing disorder, it can be a breathing pattern disorder, or it can be even a behavioral or a psychogenic breathlessness. So broadly, when we come to dysfunctional breathing, we divide them into two major aspects, which can be either in the form of a thoracic dysfunctional breathing or an extrathoracic dysfunctional breathing. When you speak about the thoracic dysfunctional breathing, we have a functional thoracic dysfunctional breathing, which can be a pattern breathing disorder, which I will be dealing it in some time, or it can be a structural thoracic dysfunctional breathing, like you really have an organic pathology, like in the form of a phrenic nerve palsy. Or you move on to the extrathoracic dysfunctional breathing, which can be either in the form of a functional one, where the most classical symptom presentation is the vocal cord dysfunction, or it can be a structural extrathoracic dysfunctional breathing, which can occur in subglottic stenosis. So why are we really concerned about a dysfunctional breathing disorder, or is it really important for us to understand this? So this is a very good paper which says about the impact of the dysfunctional breathing on the level of the asthma control in difficult asthma patients. So we see as pulmonologists the most common disorder that we see in our routine practice are the asthma and the COPD. And if you note, any patient who has got these dysfunctional breathing disorder, they tend to be associated with a poor asthma control and even a low quality of life. And if you see the prevalence of the dysfunctional breathing disorder, it is about 6 to 10% in general population. But however, when you see an asthmatic patient, it is as high as 29%. Which means many a times a patient who comes to you with an exacerbation of an asthma might not really have had an exacerbation of an asthma, and he is just suffering from an underlying dysfunctional breathing, which we are misdiagnosing as an exacerbation of asthma, and we are over-treating these patients with the steroids and other medications, and thereby rather than treating his actual problem, we are deviating from the actual problem and treating with something else. That is why as a pulmonologist, it is of paramount importance for us to understand that there is an entity called as a dysfunctional breathing disorder, and it is not just an exacerbation of an underlying asthma or a COPD. And a well-controlled asthma has a lower prevalence of significant anxiety than a dysfunctional breathing when measured by the hospital anxiety and depression scales. So when do you really suspect, or what could be the triggers for these dysfunctional breathing disorders? So most of these patients generally have an element of an anxiety or stress. And sometimes whenever they are going through an acute illness like a chest infection or a pneumonia, that is the time they may attribute their symptoms more than what actually it is, which can result in somatization. Sometimes it can be seen in long-term patients, especially asthma and COPD, because there is an emotional component of the disease aspect as well, rather than just the physical manifestation of the disease. Sometimes the dysfunctional breathing disorder might be secondary to a prior traumatic event, which can be either in the form of a physical or an emotional. And sometimes chronic pain can also trigger this dysfunctional breathing disorders, and even a digestive issues like a reflux or a hiatus hernia, which results in some sort of a trigger for the patients to perceive more of their symptoms. So when we move to the classification, we have multiple classifications, and these are the broadly accepted ones. So the one is by the Boulding et al., where they try to classify the dysfunctional breathing disorders as either into a hyperventilation syndrome or a periodic sigh breathing or a thoracic dominant breathing or the forced abdominal expiration form of breathing or a thoracic abdominal asynchrony. There's another classification by Barker and Ewart, which classifies them into the thoracic and the extrathoracic dysfunctional breathing, as well as a functional dysfunctional breathing or a structural dysfunctional breathing. But the latest one, as per the European Respiratory Society or the ERS guidelines, is this is how we classify these dysfunctional breathing disorders in the form of either an hyperventilation syndrome or a periodic deep sighing or a thoracic dominant breathing or a forced abdominal expiration or a thoraco-abdominal asynchrony. We'll touch upon each of these in detail. So the first one, and which is the most common perceived way of a dysfunctional breathing, is what we refer to as a hyperventilation syndrome. And it is the most commonly described as well as the research form of dysfunctional breathing. And to have a diagnostic criteria, we are often taught that a patient comes to you in emergency having a breathing disorder. You check the saturation is essentially normal. You take an ABG, you can demonstrate a hypocapnia as well as the respiratory alkalosis during the attacks of hyperventilation. But however, certain forms of hyperventilation can even have a normocapnic values. And the most common way of diagnosing is not just clinical history as we are taught. We have dedicated questionnaires for it. And the Nijmegen questionnaire is the one which is broadly accepted as the diagnostic criteria for diagnosing these breathing dysfunctional disorders and especially for the hyperventilation syndrome. In addition to this, we have something called as an exercise-induced hyperventilation, where there is a chest comfort and dyspnea during a cardiopulmonary exercise, and it is independent of the bronchospasm, and it is generally unresponsive to your beta agonistic therapy. So most of these times, what we generally say is when a patient comes back to us with an exercise, post-exercise, patient is having a breathing disorder, we label them as exercise-induced asthma. And we start these patients on inhalers. But if your patient does not get response to those bronchodilators, that is where you need to understand that there could be an element of an exercise-induced hyperventilation. In addition to this, there is something called as a postural hyperventilation. So whenever there is a change in the posture from supine to standing, it can be associated with hyperventilation, and it occurs because of alterations in your vestibular apparatus. So people have tried to understand these by certain maneuvers. What you're seeing here is the respiratory movement measuring instrument, where when a patient is suffering from these things, they try to understand what is the pattern of breathing in these patients. So what you're seeing now in the graph is nothing but the breathing pattern of a healthy volunteer. And when you see a patient with a hyperventilation syndrome, what you can classically see is these patients have a rapid respiratory rate and a tidal breathing which is close to their inspiratory capacity. So in addition to this, there is another form of a dysfunctional breathing disorder which we refer to as the periodic sigh breathing. So these are characterized by frequent sighing and irregular breathing pattern, and sometimes it overlaps with your hyperventilation. And sighing is generally defined as the breath which is taken, which is almost like 3 times your normal tidal volume. And generally it is observed as a crescendo on a slow lung volume trees. And though sighing is a common manifestation of healthy individuals and asthmatics, when it becomes more frequent, that is almost like 15 times in 15 minutes period, and the patient says that while sighing he is complaining of some sort of a breathlessness, that is where you need to understand that this can be a part of your dysfunctional breathing disorder. In addition to this, we have another form of a dysfunctional breathing disorder which we refer to as a thoracic dominant breathing or the apical breathing, where the patient tend to use the upper aspect of the thorax without the lack of lateral costal expansion. This we would have pretty much observed when a patient coming to an emergency. You will see that the patient will be using more of his accessory muscles of respiration of the neck and the nostrils. But actually, if you see, the lower portion of the chest hardly moves. So we think that this is an exacerbation of an asthma, but primarily it may not be, and it may be just a thoracic dominant breathing of a dysfunctional breathing disorder. Again, as we have seen earlier, you need to have certain questionnaires like the Nijmegen questionnaires, which can exactly identify whether your patient is suffering from an exacerbation of an underlying OAD or it is just a dysfunctional breathing disorder. And this is characteristically seen amongst patients with a chronic respiratory or a cardiac disorders, as well as in obese patients. And if you see the pattern of breathing in these patients, they will have large volume breaths, but with minimal inspiratory reserve capacity. So we have something called as a thoraco-abdominal asynchrony, and this occurs there when there is a delay between the rib cage and the abdominal contraction, which results in ineffective breathing, or what we refer to as a paradoxical breathing. Though it can be seen in upper airway obstruction, neuromuscular disorders, and even in certain patients with advanced respiratory failure, if you have ruled out all the pathological causes and you see a thoraco-abdominal asynchrony, then it can still indicate that there could be an element of a dysfunctional breathing disorder. So this is what you see when the thorax is when the patient is taking a tidal volume. If you see the rib cage and the abdomen are moving in different directions, just like what you see in an OSA patient in a sleep polysomnography without the evidence of an apnea, then probably this is a form of a dysfunctional breathing disorder. And understanding these dysfunctional breathing disorders is of very importance, because you have effective techniques to get over these dysfunctional breathing disorders rather than just resorting to your inhalers or stepping up their medications with steroids. In addition to this, you have something called as a forced abdominal expiration. It is the least form of described dysfunctional breathing disorder in the literature. It is generally seen in patients with COPD, and they have an inappropriate and excessive abdominal muscle contraction in the aid for expiration. It can also be seen in obese patients and patients with decreased functional residual capacity and chest wall compliance. Another most important thing which is often missed, especially amongst the pulmonologists, is vocal cord dysfunction, because 90% of these patients are labeled as cases of severe asthma, and there are instances where these patients are even started on biologics, thinking that the patient is just having an asthma without evaluating, getting an ENT opinion to rule out a vocal cord dysfunction. So what essentially happens in a vocal cord dysfunction is that the vocal cords do not abduct during the time of inspiration. But this is not always the case. Sometimes you can have biphasic vocal cord dysfunction where it doesn't abduct during the inspiration and it doesn't adduct during the expiration, and therefore the patient can have biphasic stridors as well. And the most closest differential for these is generally there are 3 different varieties. One is exercise-induced asthma. We know that the patient goes in for an exercise, he comes back after 10 to 15 minutes, the patient classically complains of wheezing. But when you have an exercise-induced asthma, if you give a bronchodilator, it should respond. If you see that the patient is having an exercise-induced asthma-like presentation, but the patient is not responding to your bronchodilators, that is when you need to suspect that this patient could have had an exercise-induced vocal cord dysfunction. Apart from these 2 things, there is a third entity which is called as an exercise-induced laryngomalacia. So when you have ruled out vocal cord dysfunction, when you have ruled out exercise-induced asthma, but the patient goes in for an exercise and comes back and says that he's having breathlessness, it can be because of a laryngomalacia, and the only way you can do it is you need to do a laryngoscopy to see if there is a laryngomalacia. If this is there, the treatment is a surgical intervention like a laryngoplasty. So understanding these different forms of breathing disorders is important because each of them has got a particular intervention which can result in cure for these patients. In addition to this, the habit cough is another form of a dysfunctional breathing which is predominantly seen amongst children, where there is a characteristic loud, harsh and barking cough. But the most important thing is when the child goes to sleep, the child will not cough. Many a times we consider the classical closest differential is an asthma, but the difference between an asthma and a habit cough is that asthma tends to be more common with the cough during the night times, unlike your habit cough, which predominantly occurs when the patient is in the daytime, and this might be a part of an attention seeking on the side of the kid as well. So the most important things to deal with are the suggestion therapy, and even hypnosis has been tried. So how are we going to diagnose these dysfunctional breathing disorders? It's not just ruling out the pathology as well as a clinical history. You have dedicated questionnaires such as the Nijmegen questionnaire, which is most widely used for identifying patients with dysfunctional breathing disorder. It contains 16 questions related to the complaints and the frequency of symptoms, and you got a scoring which ranges from 1 to 5. And the sensitivity is as high as 91% and the specificity is as high as 95%, making it an excellent ruling in and ruling out test for when you are planning to diagnose a dysfunctional breathing disorder. In addition to this, previously people used to use this hyperventilation provocation test, which requires the patient to breathe as deeply and quickly as possible for a certain length of time, which is ideally between 2 to 3 minutes. But however, it does not differentiate between symptoms caused by the hypocapnia as well as the test-related anxiety. And generally, these are not now considered as the diagnostic standards when you are coming with for diagnosis of a functional breathing. And people have even tried an incremental cycle ergometry test, which are a form of a cardiopulmonary exercise testing to identify whether the patient is having a dysfunctional breathing or not. But the most easiest and the standard one of late, if you really want to diagnose your patient with a dysfunctional breathing disorder, is the utilization of the Nijmegen's questionnaire. So whenever we speak about a dysfunctional breathing disorder, it does not relate only to your respiratory symptoms, as you see from the right-hand side of your circles. It also involves physiological aspects like the cardiovascular events. It is associated with the social effects. That is why we are concerned, because many of the kids or the persons, until and unless we clearly identify them as a dysfunctional breathing disorder, they have a social inhibition because they feel dyspneic most of the time and they tend to limit their activities, and it inadvertently affects their quality of life. It is also associated with a lot of psychological aspects in these patients. You can see many of our patients, even in an OPD practice, landing up with depression and anxiety. So understanding this dysfunctional breathing disorder and treating them in an appropriate way not only brings about a change in their lung functions, but also brings about a change in their psychological as well as the social aspects. And in addition to this, you also have to use certain instruments, as I showed you before, to exactly diagnose what pattern of breathing the patient is having. So this is the reason why we are really concerned, because when you feel breathlessness, you become fearful of the activity that makes you breathlessness. You try to avoid that activity, which in turn leads to less initiation of that activity. Your muscles become weaker and you enter into the vicious dyspnea cycle. And this is more so when you're dealing with a patient with a chronic respiratory disorders like an asthma or a COPD. So having understood about the dysfunctional breathing disorder, is there really any treatment for this? The answer is yes. And these are not just routine treatments. These are backed by enough scientific evidence to say that this brings about a change in the quality of life of these patients. There's something they follow what we refer to as the window breathing. So you keep your finger onto the left uppermost corner and you ask the patient to trace it as they breathe in, and you go down as you ask them to patient to breathe out, and you keep doing it in the form of a window. This is what we refer to as a window breathing. This helps in bringing about a coordination or a conscious sensation of you breathing properly. So these are certain measures which can be taken when your patient is suffering from dysfunctional breathing. In addition to this, there is something called as a tummy breathing. You make the patient comfortably sit on a chair, either in a reclined position or in an upright position, and place a hand gently onto your tummy, just beneath your ribs, but do not press hard.
Make sure that your breathing is as steady and relaxed as possible, and it should not be a deep breathing. And you should feel your hand is raising as you breathe in and your hand is going out as you breathe out. And such conscious breathing techniques can help in bringing about a reduction in your perception of dyspnea secondary to your dysfunctional breathing disorder. In addition to this, there are certain other breathing disorders which are extensively studied in literature, which is referred to as the Papworth method of breathing, where the patients are taught diaphragmatic breathing with an emphasis on a controlled and a slow nasal breathing. So this again helps in reassuring the patient that the breathlessness is secondary to dysfunctional breathing and not necessarily to the underlying respiratory pathology. We have something called as the Buteyko technique, which is a use of a nasal breathing and increasing controlled passes with the aim of reducing the hyperventilation over the time. And it plays an important role in patients with thoracic dominant breathing patterns by the way of increasing your breath holding time. And as we have seen from the lot of data which is with respect to the yoga, certain postures of yoga, when done properly, can also help in mitigating the harmful effects of your dysfunctional breathing disorder and can impact the quality of life of these patients. And diaphragmatic breathing, which is extensively studied amongst patients with obstructive airway disease like COPD, can also help in bringing about the dysynchrony between the thoracic and the abdominal wall and can bring about an improvement in the breathing aspects of your patient. But in the end, if nothing works, what really works is your pulmonary rehabilitation. And this becomes a cornerstone of management of all of our chronic respiratory disorder patients. And this also has a role in treatment of patients with dysfunctional breathing disorder. So I'd like to end my presentation here, and if there are any queries, we'll take it.
Well, thank you, Vishesharan, for covering this topic, less heard of, but we do frequently encounter it. Personally, I would like to say that when dysfunctional breathing coexists with asthma, that is the situation where pulmonologists, we come to the picture. Previously, a patient of asthma with hyperventilation comes to us. So will you just tell us something about it? Asthma in the context of dysfunctional breathing.
So
how to suspect, how to assure, how to diagnose, especially brittle asthma and this aspect.
So whenever we label a patient as severe asthma, so basically we are seeing a patient who is either uncontrolled asthma or a severe asthma who is coming to you repeatedly. The dictum always goes to say that whether you have really properly diagnosed asthma or not, or you are missing some other etiology. That should be your first thought. Because most of the asthma that we generally see gets controlled with a routine dose of bronchodilators and inhaled corticosteroids. So once you have ruled out an alternate etiology, one of the closest mimics of your asthma is your vocal cord dysfunction, which is a form of a dysfunctional breathing disorder. So it is always wise to get ENT opinion. But unfortunately, these vocal cord dysfunctions are correctly diagnosed only when a patient lands up in that particular episode. And that time you need to have your ENT to look into the vocal cord to see if the vocal cord is getting partially adducted or not. It's adducted during the time of inspiration or not. So once you have ruled out vocal cord dysfunction as well, then you need to really see whether your patient is having a severe asthma phenotypes, like you look into their eosinophils or you phenotype these patients, treat them accordingly for the phenotype of asthma. And even then, if you find that your patient is not having control of asthma, but you have truly diagnosed him as an asthma, that is when you really think about a dysfunctional, other sorts of dysfunctional breathing disorder. And you can, all the techniques that are required for the treatment of dysfunctional breathing disorder are pretty simple, so that you can offer them as and when you feel that your asthma is not under control.
Thank you. History helps also. I'll tell you one story to end this session. So a little girl, she was a student of class 12, occasionally takes inhalers for asthma. She was actually a daughter of one of our staffs. And then one day came to my OPD. Her father rang up, my daughter is very ill. I'm bringing her in an ambulance. She came in oxygen. Got admitted. I was in a referred case. I found that she's under oxygen, has already received medications. Didn't look about not showing the objective features of asthma. Then went to take the history, and the history was very important. Got the history from her mother, and it said that she was constantly irritated and she was constantly threatened by the peers in the school. তুই পরীক্ষায় পাশ করবি, will not pass in the examination, and that created a sort of a fear psychosis, and that led to this sort of this hyperventilation. So this history, the psychological background, that also becomes very,
Plays a
very
very
important. Yes, that becomes very, very important in the setting of dysfunctional breathing. Thank you very much for giving us a structured approach for this approach, which we less discuss it, but we always face it. Thank you very much.
Thanks.
Thank you, sir. Now I request everyone, the lunch is open. Kindly, I ask you to go upstairs and have your lunch.
না এমনিতে এমনি বড় সেন্টার আরো এরা মণিপাল সবকিছু নিয়ে নিয়ে চলে যাও বড় সেন্টার বানাতে পারে। হ্যাঁ কিন্তু টিম দেখো কলটা টিম মাইক মাইক ম্যাম এটা আছে ম্যাম একটাই ফেলে
ওদের বাজার আছে তাহলে প্রথম থেকেই আছে ফার্স্ট রাউন্ড থেকেই যে এই তো না ধীমানদার তো
Check. Hello.
ম্যাম ডেকে নিন
Good afternoon. Okay, after yesterday's very interesting round
Hello.
of quizzing, now we have our final quiz round. So let's call the 5 teams that qualified from the 12 teams yesterday who participated very enthusiastically. So the first team is of RG Kor Medical College. Give them a big round of applause. Postprandial splanchnic circulation jano na jaye, please. Acha. Second team is NRS Medical College and Hospital. Tulisha chotpot so that we don't waste time. All the teams please come stand forward so that when we call you, you can take your place. Third team is of Medical College, na? No, Shakur Datta Medical College. Shakur Datta Medical College. Team 3. Two of you please come ahead. Fourth team is SDMH Jaipur. He's only a sole fighting member. Give him a very, very big round of applause. And the fifth team is Calcutta National Medical College.
ফিফথ টিম
Calcutta National Medical College. Hi, Ora. Hatche, Calcutta National Medical College team. এখানে কেউ আছে ন্যাশনাল ওরা হাইপোগ্লাইসিস ঠিক আছে সো ওরা যতক্ষণ না আসছে we will anyway start if they don't come on time they should have known it starts at 2 o'clock okay
অভিষেক একবার দেখবে ওই ম্যাম 5 minutes will start so give him 5 minutes.
No, don't give 5 minutes. No, they were told to be here at 2 o'clock. If they are not, we should start.
Partibas at 2 minutes.
It's their loss, not anybody else's.
Okay. So the scoring system.
Or Arindam, you go ahead and tell them
The scoring system is direct question will come to each of the team 1, 2, 3, 4, 5, and you will score for correct answer +10, for wrong answer -10. If the team which is having the direct question cannot answer, it will pass to the next team in the order. And if they can answer, they will score +5 for correct answer and -5 for wrong answer.
very straightforward.
Yeah.
Be very clear
Please
about
ask.
Direct question +10 if it is correct. If wrong, -10. If it is passed and correct, +5. If wrong, -5. Okay.
So we are starting with team 1. Okay. Time. So we have Dr. Raghav and Dr. Shiva ma'am as our scorers.
The
Time for answer is 30 seconds for all the questions. There is no lengthy question. All the questions are very simple. So we'll start from the question team 1. Direct question. First round, it is about pulmonary infections. So as per current EORTC guidelines, what is the cutoff for combined bronchoalveolar lavage and serum or plasma galactomannan for diagnosis of invasive aspergillosis? I think they have come. The team from CNMC has come.
CNMC, please come and join quickly.
Okay. The time has started. Timer ta start kore that. Start the timer. You have to tell the values, cutoff values of galactomannan in lavage and serum if combinedly they are considered to be positive.
Team 1.
Pass. So
Pass.
it goes to team 2, team 3, team 4, team 5.
You know the answers?
So nobody is trying to,
The
audience, try to give an answer. Yeah. So if you are having a direct question and answering is correctly, you will get +10. If you miss your question and answer it wrongly, then -10. If you get a question by way of passing, then if you correctly answer it +5. If you answer it wrongly, -5. So you are not trying to answer this. Na? So we'll go to the answer. So two low positive test result when combined are considered to be positive. In that case, the bronchoalveolar lavage fluid guideline cutoff is OD value should be less than more than equal to 0.8 and serum or plasma ODI value should be 0.7. If they are individually taken, then it is 1 for both of them. If they are taken in combined, then there is a values of 0.8 and 0.7. These are from the URTC guideline 2021. That is the most accepted guideline for invasive fungal infections worldwide. They have not attempted 0. So the direct question for team 2. Which principle is used in Vitek 2 for diagnosis of MDR organisms or for identifying the organisms also? The same principle is used in Vitek 2. It's a
Multiplex PCR.
no. It's a wrong answer. -10. Question passed to the next team. Will you try team 3,
What
4?
is the principle?
We just asked the principle.
Not the type.
And it is definitely not a multiplex PCR. It's not multiplex PCR. Team 5. Team 1. Nobody is trying. Anybody from the audience want to try? So it's a colorimetry.
It's a principle of colorimetry.
Principle of colorimetry. Then we can elaborate on which principle is used for which one. It is colorimetry. Now a direct question for team 3. When gene expert or MTVRIF can give a false positive result. That means the gene expert is positive, but is falsely given a rifampicin resistance result. In which situation?
So you hope you understood gene expert positive but false rifampicin resistance. Ekdom. So gene expert is positive but false rifampicin resistance is shown. That is what we are trying to ask.
So should we consider pass? Yeah. Team 4. Team 5. Team 1. Team 2. Anybody from the audience?
What's that?
Sir, the answer is like that. In case of presence of silent mutation, as there is if there is a silent mutation, then it doesn't match the probe. So it will give you a false positive resistance report. But the resistance is not phenotypically positive. So we go with the direct question to team 4. You have to identify the causative organism. This is the CT, then there is a bronchoscopic, and then when it is taken as a biopsy, it looks like this.
So it's an organism.
It tells the organism. It's so much self-evident we have not
Hydrated cystic Echinococcus granulosus.
Very good.
Very good.
Big round of applause. First, khata khola.
Team 4, direct question, correct answer, +10. So now the last question of the first round goes to Echinococcus lung infection. Team 5. And it's a question for which gene mutation cause resistance to amikacin in Mycobacterium species, be it Mycobacterium abscessus or Mycobacterium tuberculosis. We'll go to you. রাঘব টাইমিংটা ঠিক হচ্ছে না টাইমিং দেখলে না
Pass.
Team 1, Team 2.
EIS and RRS.
Yeah.
Say again.
Say again. Say loudly.
EIS and RRS.
Yes, we'll take it.
RRS is the accepted answer.
We'll take the answer.
Huh.
RRS, so 5 plus for team 2.
We'll take the more prevalent. So it's a plus 5. ERB 41 is also there, but we are taking the most prevalent. Most prevalent is RRS.
RRS, ERB 41 and ERS, all three would be acceptable, but RRS is most prevalent.
Most prevalent. So we here conclude the group round 1, and please tell the score.
Team 1 is 0, Team 2 minus 5, Team 3 0, Team 4 plus 10, Team 5 0.
Okay.
Leading is Team 4 with 10 points.
So now we are going to the round 2. It's a round on lung cancer.
Team 2, it'll be your first question.
First question directly to team 2. YPT1N0M0. It's a expression of a tissue. What Y and P represent in this nomenclature? Direct question for team 2.
Y is new for neoadjuvant chemotherapy and P is for pathological.
Correct.
Very
Plus
good,
10.
well done. Very good. Please give them a round of applause.
Now we'll go to the question number 2, which is a direct question for team 3. As per ESTS guideline, what are the indication for EBUS mediastinal staging even if PET scan is not showing any FDG avid mediastinal lymph node? As per ESTS guideline. So guideline is not important. These are common indications I am asking on. The most commonly acceptable guidelines, so I have incorporated the name. What are the indication of doing EBUS mediastinal staging in case of a lung cancer even if the FDG positive lymph nodes are not there on PET scan?
Pass. You're not going to try?
Team 4.
কোর্সের ভেতরে
হচ্ছে না স্যার 30 সেকেন্ডে আগেই সবাই পাস করে
বেশি দিচ্ছে ইমানদা 30 সেকেন্ডে বেশি দিয়ে দিচ্ছে ওদের
Team 4, will you try? Team 5, Team 1, Team 2.
Anybody in the audience? PET negative, sorry, PET negative, but you still
Want to do a EBUS? Or is it indicated EBUS? Yeah, please. Size criteria is there.
Yeah.
So if there is a central tumor and if the tumor is more than equal to 3 centimeter in diameter, then even in a PET negative patient, you should do EBUS staging before going for a surgical resection of the tumor. So now the direct question for team 4. Which antibody is most commonly found in lung cancer with paraneoplastic CNS syndrome? Paraneoplastic CNS with lung cancer.
This
Please.
I think everyone will know here. CNS syndrome. Time out. Anybody?
Yeah, team 1 is one to try. Sir, team 1 is trying. Then
Anti-HU antibody.
Correct.
Very good.
So you are getting plus 5 bonus marks. Now we will have a direct question for team 5. Taina ma'am.
Team 5, team 4 or team 5?
Team 4 is
Team 5.
no, team 5.
Team 5.
I am in the fourth question. What is the most important prognostic marker factor for atypical carcinoid? First. So it goes to team 1. Do you want to try? Team 2, Team 3, Team 4. So nobody is trying. Anybody want to answer from audience?
You want to answer off the record? They were trying to, maybe off the record if they want to say something.
Yeah, they will not get a point.
So KI67.
That's correct.
You should have tried.
But that's okay. You may lose your 5 points also. So now the last question, which is a direct question to the team 1. It's a question number 5, which is the current recommendation for frequency of LDCT in adult with lung nodules by UPSTF. That is USPTF. I have mistakenly named the short form, United States Preventive Scheme Task Force.
Low dose CT.
So this is the only task force who have given recommendation. So I have put the recommendation from them only. What is the frequency of doing a low dose CT
Recommendation.
recommendation?
This is simple. Try it. Give up. Okay.
Team 2.
Annually.
Yeah, correct.
Very good. Annual.
So can you tell me how long they should be repeated? Perhaps shown the answer. So stop screening once a person has not smoked for 15 years or has a health problem that limits life expectancy or the ability to go for surgery.
But we'll give you +10.
No, plus 5 now.
No, why? That's okay.
Direct question is to team 1.
Oh, direct question is to team 1. Oh,
So it's
+5.
a fast
Sorry.
question. So they will get +5 and we end our second round here. Ma'am, third round.
You keep going. Copy color.
Okay. So round 3 is about pulmonary labs.
0.
So here we start from team 3. Right, ma'am?
Oh, they got an
Direct
team.
question to team 3. What is lung clearance index? That is the first question. Team 3 direct question. If you don't try, then you go for the next team.
Okay. Team
Team
4.
4. You want to try? No. Team
Team
5.
5.
Team 1. Team 2.
Anybody? Lung clearance index? No. तुम्ही बोले दो.
So the answer is the total number of FRC size breaths that are required to reduce the nitrogen concentration down to 1/40th of its initial value in multiple breath nitrogen washout test. So if you can tell the multiple breath nitrogen washout test, we'll give you the number. So okay, now we'll go with a straight question to team 4. What is PD20?
This is simple.
It is used for
No. You have to tell what is PD20, but not for it used for. What is PD20?
We need a definition of PD20.
You have to give a definition. Otherwise, question becomes very simple. There should be
What is used for
little
everyone
twist.
here knows. But what is PD20?
You try if you want to try.
The idea of this round is for you all, when you're sitting your exams, to know the uncommon, the uncommon
pulmonary labs.
definitions in the pulmonary lab tests that you need to know about. That is the entire idea.
So we want to know the definition.
The
Will-
definition of PD20.
Will you try?
Time up.
Time up. Next team. Team 1, team 2, team 3. Nobody is trying. Anybody from the audience want to tell? Yeah, please, Abhishek.
20% fall in FEV1.
Correct. We don't have any audience prize. Sorry.
No, Parsada will give an audience prize. Yes. No, very good.
Which the sir is giving the prize. So now we will go with a direct question to team 5. Correct?
Yes.
Which value obtained from cardiopulmonary exercise test is considered as a contraindication for lung resection generally, because nowadays people going beyond the usual limits for lung resection for lung resection which is considered contraindication, which value are obtained from a cardiopulmonary exercise test.
So most objective test to find out how a person will do post lung resection. No more climb the stairs, no more 6-minute walk test. If you do CPET, what is the value? That will tell you that it is a contraindication to lung resection.
Time over.
Team 1, Team 2, Team 3, Team 4. Nobody is willing to try? Anybody from the audience? Yes, please.
Very good. Excellent. VO2 max less than 15
So
ml per kg.
the unit should be milliliter per kg per minute. Less than 50 to 60% predicted. That has a lot of lozenges. So we will go for question 4, which should be a direct question to team 1.
Yes.
What is the criteria for vasoreactivity during right heart catheterization? We are not asking for the drugs. After drugs are applied, which values, if obtained, we will call it a vasoreactive test positive.
Pass. Team 2.
Fall in the pulmonary artery pressure by less than 40 millimeters of mercury for sustained 15 minutes.
So we will not give you the number.
40 centimeter of water pressure.
You have to make a statement, make a complete statement.
We want a better answer, not just a number.
We will not give you number on this answer.
Okay, team 3, you want to attempt? Team 4?
Yeah.
A reduction of more than or equal to 10 mm of Hg with an absolute value of less than 40, with or without increased cardiac output.
What? MPAP, APAP?
Pulmonary artery pressure, mean pulmonary artery pressure.
Mean pulmonary artery pressure. Will you give the answer?
We'll give the answer. Madam, there is a small problem. It should be without any fall of CO.
But we'll give
So
them.
we'll give us +5.
Okay, +5. Very good. Nobody is clapping for them. Such difficult questions. I wouldn't be able to answer in your place.
Now we'll go for question number 5, which is a direct question for team 2.
iOS.
It's an iOS graph. You all know it is reactance and resistance. You have to tell what is that small and large dotted lines represent. The board line is normal, large and small dotted. Direct question to team 2.
Team 2, direct question.
Ma'am, small dotted lines represent small airway obstruction and large dotted line represents large airway obstruction.
I accept. Correct answer.
Well done.
This is very easy to remember. As peripheral resistance, the reactance line will go down. So now we have completed 3 rounds. Before going for round 4, please tell the scores.
Just give us a minute.
One is 5. 2 is.
We have 2 rounds left, 10 more questions. এখন একটা নতুন সিস্টেম হয়েছে
415 5 team 3 and team 5 still need to open at 0. Team 4 is leading with 15. Sorry, team 2 is leading with 20. Team 4 is 15. Team 1 is 5. Again, team number 1 5. Team 2 20. Team 3 0. Team 4 15.
See,
team 5 0.
There's 2 rounds still left. Everything can change.
Yeah.
So team 2, buck up even more.
will
All of you open your accounts.
You will have more interesting questions. It's the intervention.
Easier ones, much easier ones.
Interventional pulmonology. What does this is a direct question to team 4. What does blizzard appearance in radial EVAs signify? Blizzard appearance in radial EVAs signify.
Time up.
Team 5.
Ground glass opacity GGO.
Correct.
Very good.
+5. So we will now go with a direct question to team 5. Which of the following features of a lymph node does not predict malignancy during convex probe EBUS? Round shape, distinct margins, central nodal vessel, coagulation necrosis site. Which among these four, if present, does not support a diagnosis of malignancy?
Coagulation necrosis sign.
Wrong. -10.
-10. We'll give only one pass and one more try.
Yeah. Team 1.
Any of you who know the answer, lift your.
Team 3.
Team 3, go on.
Round shape.
Sorry?
Round shape.
Wrong.
Wrong. No choices. Anyone in the audience?
Yeah, please.
Go on. Huh?
Wrong. So it left with the possibility of central nodal vessels. So this is a
Nodal vessels.
This is a small chart. You will find it anywhere. This is where it is as good the margins, there are more chances in
It's
malignancy.
going to be malignant. And central
Correct.
nodal vessels, remember, is a very, very common feature of a
Finding.
normal lymph node. And that's what you try to avoid when you are entering with your EBUS needle.
Okay. So we are now going to team 1 with a direct question. So please identify the instrument.
Theatre, team 1.
Team 1.
What is the instrument?
No clue, ma'am. No clue.
No
When the
clue. I'm not giving any
If
clue.
you give a clue, it will become very easy. আমার মনে হলো যে clue দিতে যাচ্ছে।
Time up.
Now
Team
time
2.
up. 4 seconds.
That's
4
4
seconds.
Will you try?
Yeah, now
Will
time.
not try. Team 2.
Navigational bronchoscopy.
Wrong. -5.
-5. I thought they were going to say navigational. Huh? Sorry?
क्या
What?
क्या बोल?
EBUS.
Yeah.
-5.
-5.
That
Yeah.
was.
Are anyone else?
Robotic bronchoscopy.
Very good.
Very good.
+5.
+5.
So this is robotic
It
bronchoscopy.
is ion robotic system. There is another one to robotic system. I just want the name of robotic bronchoscopy. Ion, if you tell, that will be better. So now we'll go with a direct question to team 2. Direct question. Rule of 4 is implied for which airway procedure?
This is one of the interesting ones. Which airway interventional procedure? Rule of 4. Only one has it. Pass. Next.
Team 3, team 4.
Endobronchial laser photoresection.
Very good. Well done. +5. Team 4.
Photo resection, you should not add that term because many things are now being done with
Yeah.
laser.
So endobronchial laser therapy.
Endobronchial laser therapy. That should,
Show
but
them
we will
the-
give you the number.
Show
There is
them
no
the
issue.
answer.
So this is the number. And this is the thing, ma'am, want to show you that there is lots of 4 in the answer.
Lots of, so the
And
length
this is by
condition
one
has
of
to be
our
4 centimeters.
Indian scientist.
Yeah. Duration
Dr.
of lung
A.
collapse
Mehta.
should be less than 4 weeks. Life expectancy should be more than 4 weeks. Procedure time should be less than 4 hours. FiO2 requirement should be less than 40%. And pulses between cleaning should be less than 40. Total number of repeat laser treatments should have been less than 4. And 4 persons are needed. That is an addition there. So that is the rule of 4. So endobronchial laser therapy has rule of 4. I'm sure you will not forget this after
This is
today.
a very popular rule. So now the last question of this round, which will directly go to team 3. Which procedure is being shown here? It is being shown
Look
from-
very carefully.
from an Indian interventional pulmonologist from Jashoda.
Very carefully.
One of his colleague was here. Ms.
No, you
Vishweswaran.
don't need to tell them that.
Okay.
Don't be in a hurry. Use your 30 seconds. Sorry? EBUS. Minus. How much? 10. -10.
EBUS
That's why I
is
said don't be in a hurry.
is definitely an EBUS,
It's an EBUS.
but we cannot give you number on the EBUS. Okay, you have the pass chances. So go to team 4.
Mediastinal cryobiopsy.
Correct.
Very good.
Last 5.
This is mediastinal cryobiopsy. EBUS is there, but you could see the cryoprobe. Should have seen that.
Chalo. So we have ended the 4th round here. And before going to the last round, please tell the score once again. So everybody buckle up for the last.
Last round, nothing to lose. Plus 10, minus 10 doesn't matter. Take all the chances.
No.
You can only be wrong.
Okay. I'll start from team 5 at -5. Team 4 leading at 30. Team 3 -20. Team 2 15. Team 1 5.
So the
Last
last
round to
round,
go.
round 5,
Big round of.
it is about pulmonary.
Everyone's doing very well. सबका সবাই খাতা খুলেছে।
সবাই খাতা না ম্যাম মাইনাসে আছে।
মাইনাসে আছে। এবার প্লাস হয়ে যাও। চলো।
Chalo. Last round is about pulmonary therapeutics. So we'll start from team 5.
Right.
Direct question directly to team 5. Which drug was recently approved for treatment of class 3 pulmonary hypertension, particularly DPLD associated pulmonary hypertension? Which drug has been approved recently after a very landmark trial?
Class 3 pH. Many drugs, but class 3 pH.
Approved.
Give up. Team 1. Team 2. 3. 4.
Trepoprostenil.
Correct.
Very good. Yes.
The trepoprostenil is only been given at present inhaled ways.
We're just asking the drug name.
Which are now direct question for team 1. Which are the new drugs approved for treatment of cystic fibrosis? There are 3 drugs or more than that. You can name any one of them.
New drugs means duration.
So what are the new drugs approved? For
cystic
fibrosis has not had new drugs in a very long time. So there are 1 or more drugs that have been
approved.
So approved. If you know more than 1 drug, that is what we are looking for.
Ma'am, Ivacaftor, Lumicaftor,
Pulmocare.
And 3 drugs. If you can tell all 3, you've got the marks. But if you can tell all 3, that'll be
If you want to try.
Anyway, we'll give you the marks. So
Now the triple therapy has recently been approved. That is Elixacaftor, Tezacaftor, Ivacaftor. Lumicaftor is also a corrected drug. You can change any of them. Triple therapy, you can add 3 drugs together.
those 3 together for cystic fibrosis now.
Now we have a direct question for team 2. Right? No? Team 2.
Yes, team 2.
Which TKI, tyrosine kinase inhibitor, has shown survival benefit in completely resected EGFR mutated lung cancer? The EGFR mutated lung cancer after resection, which TKI, if continued, will prolong the survival? Very recent trial published in NEJM.
It's an oral drug.
Oral drug. Time up.
Give up. Team 3. Team 4.
Osimertinib.
Correct.
Very good. Osimertinib.
ADURA trial. ADURA trial. Maybe, but I asked from the ADURA trial. Osimertinib to be given after resection only. That's okay, but the drug is osimertinib.
We are asking
We asked the drug only.
Yeah, not the trial.
So now we have a direct question for team 3. Genix trial published recent in last year has been planned to find the dose and duration of anti-tubercular drugs. Which is the drug? Name of the drug.
This you should be able to tell.
This
Xenix trial has been completed, is now being incorporated.
in the various national programs.
Give up?
Linezolid.
Linezolid.
Correct.
Xenix trial is for linezolid.
Now we go to the direct question to team 4. Last question.
Jaipur is on a roll, huh?
Corticosteroid is sad, is sitting also. Corticosteroid is contraindicated in which pneumonia?
Influenza.
Correct.
Influenza what?
Influenza pneumonia.
What influenza pneumonia?
H1N1.
Influenza pneumonias are many. A, B. So you need to classify that.
Can you tell why it is contraindicated?
And why it is contraindicated. Why? We'll give you extra.
Why we have, no, you have get the point. We are giving steroid right and left in COVID, but we are saying it is contraindicated or should not be given. Contraindicated is a more harsh term. Influenza pneumonia. Why? It has shown to have increased the chances of secondary bacterial pneumonia, influenza pneumonia. And it doesn't reduce the inflammation in influenza pneumonia.
Yeah. So influenza.
But there is always
H1N1.
controversy.
It
At
reduces the
present, it
gamma
is not being
interference.
used.
It reduces the gamma interference which is required for the influenza removal. Clearance.
So influenza removal can be delayed. That was a question for COVID also. The COVID removal may also be delayed due to steroid. Okay, we end up, we will not go for round 6 and please the final score.
I think are we finished on time?
We have finished before time.
Great.
1 minute বাকি আছে।
Parthoda will be happy.
ভরা অডিয়েন্স কেউ জানে সবাই শুনেছে না পাবলিক করেছে আমরা কি সবাই শুনেছি
+1, 2 and 3. Parthoda, first, second, third or first and second only? First, second, third. So, after a really, really good round, we have our winner. Team 4 is the winner and with 55 points. So, very good. Well done. And he was the sole contestant. He didn't have any help at all. So, even bigger round of applause for him. These two? Oh, no. Oh, yeah. So, team 1 and team 2 are tied in the second place. We will have one tiebreaker question for second and third place. So it is RG Medical College and NRS Medical College. So you will have a tiebreaker question, so buzzer question. Okay?
কোথায় গেল ছেলেগুলো? Organizers please.
Buzzer আছে তো কাছে।
বাজার আছে অভিষেক একটু দেখেন। বাজিয়ে দেখে নাও বাজার দুটো। Okay. We can see which is team 1, which is team 2.
Team 1 is green.
Yeah, 1 and 2. Yeah.
So we'll go with a single question, buzzer question for tiebreaker. What are the 3 mediastinal compartments as per IMTIG classifications?
Any negative marks?
No, it's a buzzer question. If you know, you try. If you don't know, you don't try. No issue. We'll go to another tiebreaker question if you don't try.
No, he's tried. Team 2.
Team 2 is trying. Okay.
Prevascular, vascular, and prevascular.
Correct.
Correct. So they get the marks. So team 2 is in second place, NRS Medical College, and team 1 is in third place. Big round of applause for team 4, 3 and team 5 also for being very good participants. Parthoda, prize will be in the end. Parthoda, prize will be in the end for them. Okay. So that's it for the Pulmocon quiz for 2023.
Thank you, ma'am.
Thank you very much.
Thank you very much.
Thank you very much. Now we begin with our next session, that is Education, Training, Career and Ethics. And our speaker is Dr. Dhiman Ganguly. And to chair the session, I would like to introduce Dr. Vishwanath Das. Dr. Das is a retired professor of statistics from Calcutta University. He has several papers to his credit. I would like to introduce Dr. Das. Please come on stage and proceed over the meeting.
I have an announcement to make. There is a sleep workshop which is going on in Hall B. So those of who are interested in attending a sleep-based workshop, they can attend in Hall B. Thank you.
Just taken over. Just 2-3 মিনিট বলবো তারপরে আমি বিমানকে ডেকে নিচ্ছি Good afternoon, everybody. We are now going to start this session. Ladies and gentlemen, let me first congratulate the organizers for choosing this important topic: education, training, career, and ethics, getting the balance right. I also thank the organizers for giving me the honor to chair this important session. Friends, ethics or moral philosophy, as many of us present here know, is a branch of philosophy. The term has been coined from the Greek word ethos, meaning character. And ethics seeks to resolve questions of human morality by defining such concepts as good and evil, right and wrong, virtue and vice, justice and crime, and the like, and to prescribe based on standards established what humans ought to do in given situations and contexts. The advancement of a nation in various fronts, including that of healthcare management, largely depends on its human resource development via quality education and good training. Gateway to the career building of an individual, two, is good education and right kind of training in specific areas. And this good education and training involves a lot of ethical issues. It is of paramount importance to have a good balance between an education oriented or education guided ethical life on one hand, and career oriented trained life on the other. And it is precisely the topic of today's discussion. The speaker, Dr. Dhiman Ganguly, I know, has a very, he's very fond of this topic, and as a conscientious campaigner, he always does his homework religiously and puts forward newer ideas and thoughts every time he is called upon to speak on the subject. Friends, without wasting any further time, let us turn to Dr. Ganguly for listening to what he has on offer today in his speech on the subject.
Forward.
Thank you, everybody. Dr. Dhiman Ganguly, please.
Thank you. Good afternoon, friends and colleagues, and my dear chairman, sir. It's become a ritual for the last maybe 10 years or so for me to speak on something related to ethics in this Pulmocon every year. So it's getting more and more difficult for me not to repeat myself every year so that I don't even bore myself, let alone the audience. So it's difficult to find out some new way of presenting similar thoughts year after year. So this is how I decided to select this heading, Education, Training and Career. Now this is something that worries all of us. In fact, our parents didn't worry too much about what I was doing in schools and colleges. But the present generation of parents, they start planning their children's career even before the little thing, the unfortunate poor thing, hasn't come out of his mother's womb. So they start planning their career. And then looking for a good school, good institutions, looking for good coaching classes, then karate classes, swimming classes, singing, dancing. You see, it's all nicely planned long before the baby is even born. So now things are quite different. And then there are coaching hubs. You see, we never heard there was a small town called Kota in Rajasthan, which is famous for coaching classes for entrance to the higher education. I read in a newspaper later that the yearly turnover of Kota as a coaching hub is 6,000 crores every year. You have heard me right, 6,000 crores every year in that small town in Rajasthan. And the flip side is there has been 52 suicides in that small town among the students in the last 4 years. That's what happens when you do not get the balance right. You see, that reading that newspaper article, I decided that could be the topic of this year's lecture, how to get the balance right. I'm not saying education, training and career is not important. It's of course important, but it's important even more to keep the balance right. Before I get into the subject, there are two important things, the basic facts about human life, that I think we have to remember before we get into the subject. First is, life is inherently uncertain. A little while ago, Dr. Panda was talking on the same topic. Life inherently is uncertain. So whatever you do, however meticulously you plan your life, things can always go wrong. In fact, it hardly goes the way you plan it. So that is the first truth. And the second truth is, although we all look very different, We all have our different likings and dislikings. We all have our own principles and prejudices. We have our dogmas. But there is one thing that unites all of us, the all of mankind, is our pursuit of happiness. Although we do not quite know what happiness means, but nonetheless, we spend a lifetime looking for happiness, not knowing quite clearly what it is. We keep on skipping from one target to another in search of that elusive happiness. So basically, if you are talking about the balance, on one side you have education is supposed to stimulate your ethical sense. I mean, if you consider from the time of Hippocrates, over the last 2,500 years, the society has tried to shove down a sense of ethics down our throat with various means, sermonizing, passing laws, and court and all that we have now. But it has not succeeded. That's why you still need a talk on ethics in medical conferences. Education was supposed to do this work for us, but it hasn't. And on the other side of the balance, you have a career-oriented trained life. Over the last 100 years or so, the medical education has leaned more and more towards training rather than education. So we'll spend a little time talking about education. What does it do to us? Richard Stanley Peters was a British philosopher. He was born in colonial India. He was actually born in Mussoorie. Later on became very famous for his work on education. And he edited a book called The Concept of Education in 1967. And this is how he tried to explain what education is supposed to do to us. He said, to be educated is not to have arrived, but to travel with a different view. Every day we have to react to circumstances, we have to respond to circumstances of various nature, and how I interpret a situation, how I interpret a communication, and how I react to it depends on my consciousness and my ethical sense. So I'll try to explain this problem a little further. John Stuart Mill, some of you must have heard his name, was a very well-known, initially he was a British civil servant, then later on he became a member of the British Parliament, a Liberal Party MP. And this is what he had to say about education and its effect. It is really of importance not only what men can do, but also what manner of men they are that do it. That means if you and me both polish a shoe, the quality of the polishing will depend on what quality of human being I am, not exactly how I polish the shoe. Among the works of men, which human life is rightly involved in perfecting and beautifying, the first of importance is the man himself. So that's what education is supposed to do. It's supposed to improve or inculcate perfection. That's what Swami Vivekananda said. And some of you might know John Stuart Mill was a favorite reading of Swamiji. So to come to training part, you see our Upanishad says Sa Vidya Ya Vimuktaye. That is learning that sets us free. Free from what? Free from our dogmas, free from our prejudices. Unless I have a free mind, free from preconceived ideas, it's difficult to see things as they are. That is why Abraham Lincoln said that things appear to us not as they are, but as we are. It depends on my way of looking at things, how I perceive an occasion. To be educated, must you have a broad perspective, and it should touch the student at a personal level. It should change the student personally, not really sort of adding information to his consciousness. Whereas training has a narrow focus. It's more applicable to vocational qualifications, like an electrician or a plumber. That's training. But medicine is not really training. The educational process should be valuable as an end in itself, not because it enables somebody to do something else. And we talk of students being trained to be doctors rather than being educated in medicine. So the emphasis is on training. This has happened over the last 100 years or so. So when you say training, the question comes, trained to do what? Where this is more applicable to vocational qualification. But these questions do not fit the educational process. So to summarize, education is supposed to make a qualitative difference with your personality. It changes our way of interpreting what we see, hear, or feel with our sense organs. Now, as I was thinking about a suitable subject, this is a document that came to my hand. Tomorrow's Doctors is a document published by General Medical Council in United Kingdom in 1993. There it was said the good doctor must be an educated doctor, and this is one of the major areas where arts and humanities subjects might make a contribution. So in 1993, it was realized by some experts that teaching you anatomy, physiology, and pathology and forensic medicine may not be enough to produce what we can call a good doctor. So how does humanities subjects help medical education? There has been, I haven't got enough time, there has been works in various universities all over the world. This paper was published in the year 2000 from Durham University. There they started including humanities in medical education. They actually appointed teacher, lecturer in medical humanities in that university. What they did is a long story. I haven't got enough time, but it's nice to be able to tell you that way back in 2000, there are people, there are universities who thought of including humanities in medical curriculum. Now, what is it supposed to do? It introduces you to problematic life situations and how individuals respond to it. The problem with the student community is they generally belong to upper middle class families of the country. But the day they become doctors, they are supposed to communicate with all strata of socio-economic life in India. So this is reading literature is one way of making them aware of what some of the great thinkers of the world are thinking, and they can then start considering different ways of perceiving the world. It's not just cars and biryani pulao. There are other things to worry about in life. So in general, to conclude in one sentence, it's improving their quality as a human being. And unless you have a good quality human being as a medical student, you cannot produce what the society considers as a good doctor. The raw material must be good. Otherwise, you can't produce a good finished product. Now, in India also, people have started thinking in the same line. India has changed. This is, I think, in 2019 or 2020. The authorities decided to change its MBBS curriculum after 21 years with focus on attitude and ethics. And this is what the Medical Council of India was calling it. It's competency-based curriculum for Indian medical graduates. And it included a course called Attitude, Ethics and Communication, which will run across years. I am not concerned, not exposed to undergraduate medical education in this country for many, many years. I don't know what exactly is being done in undergraduate courses, but this is what theoretically they said they will do. There will be choice of elective subjects for the students. Now, as I was going through these literature, I was feeling a little worried that why is it nobody in India thought in these lines before the British people published their paper on tomorrow's doctors. Then I came across a little life story of Jamshedji Tata, and this is the quotation I found there from Jahangir Tata. Jahangir Tata, you may know, is known as father of Indian aviation. He is the son of Jamshedji Tata's cousin, Ratanji Dadabhai Tata, and is responsible for Indian Airlines in early 1950s. Now, he was the president of the Court of Indian Institute of Science between 1955 and 93, I think. And he used to deliver a lecture every year as president of the court. And this is what he said in their Golden Jubilee celebration. He said, "It has been said education is what makes a man. Men and women pursuing advanced studies in our institute little time or opportunity to expose themselves to literature, arts, drama, poetry, music, history, philosophy, which though unconnected to their study or research work, are essential elements in the makeup of a civilized, educated person, as Jamshedji Tata had in mind." Look at the far-sightedness of this man. We know him as an industrialist, but he had this wide vision about the future of India. It's generally agreed now by many authorities that taking part in some form of artistic activity, even as a spectator, viewer, or a reader, is needed to build up a complete man. Now, I will now talk a little about career, you see, and then end up talking a little about ethics. This photograph, the man in the center, the white-skinned man in the center, his name is Scott Nissen. And I'll give you his short biography. I have many more examples, but for the time available, this is what I think is important for all of you to follow. Scott Nissen was born in 1961 in Edinburgh, in Scotland. Belonged to a poor family. He was in 1966, when Scott was a 5-year-old boy, his family decided to emigrate to Australia in search of greener pastures. His mother found a job as a cleaner in a school. His father found a job in a defense establishment. Scott went to school and dropped out of the school at the age of 17 without a school leaving certificate. He didn't get through any examination in whole of his school career. He later on said in an interview that I was a terrible student, and had it been today, I would have become a drug addict or a antisocial element, but somehow drugs were not that easily available in those days, so I didn't meet that fate. So he left school at the age of 17 without a school leaving certificate. So he enrolled himself to a chronically disabled, chronically unemployed person with Australian government, and eventually found a job as a drive-in cinema company operator. He used to move around in a car with a projector and a screen and held cinema shows in parks. And then he became a film promoter, he became a film buyer, Eventually, he became a managing director of distribution arm of 20th Century Fox in 1986. He emigrated to USA, Los Angeles in 1993 as marketing manager of 20th Century Fox. He became a vice president of international marketing of 20th Century Fox. By that time, he had a palatial building in Los Angeles. He had a fleet of luxury cars in his garage. He even had a luxury yacht to spend his holidays. And 10 years later, he became president of 20th Century Fox International. It was under his guidance that films like Titanic was prepared. Now, he said later in an interview that he realized by the time he was about 40, 42 years old that he was getting more unhappy the more he was getting. He didn't know what he should do really. So in the year 2003, he decided to have a holiday for 5 weeks. And in the meantime, he became close to Dalai Lama, became influenced by Buddhist philosophy. So in 2003, he took a 5 weeks holiday and decided of all the places to spend his holiday in Cambodia, Phnom Penh. The day he reached Phnom Penh, he asked an old lady in the street to show him the poorest and filthiest place in that town, in Phnom Penh. The old lady took him to a 18-acre area garbage dump where naked skeleton-like looking children were rummaging through that filth and was eating something from that garbage dump also. So he asked through his interpreter that what are these children doing here? The lady said they are looking for something that they can sell to earn some money. And if there are rotten things, rotten foodstuffs, they will eat also. And they were all skin and bone like moving skeleton. When he was standing there, he stood there on that first day. It was a very hot sunny day and he could feel methane gas coming out of that garbage dump. And his phone rang. And on the other end of the phone was a Hollywood film star who was complaining that the private jet that was sent to pick him up was not good enough for somebody like him. He stayed there for about 20 minutes. He touched the little girl right in front of him and found out that the skin was hot. The girl was running a high temperature. So he said that this girl has high fever. The lady said, yes, they get typhoid fever. Many of them die in this garbage dump, and that's very common. So he picked up that girl, contacted her parents, got her admitted in a hospital on that first day. He spent his 5-week holiday in Phnom Penh, went back to USA, and decided that he cannot do anything sitting in USA. So he resigned his billion-dollar job. He sold his palatial mansion. He sold all his luxury cars, his luxury yacht. And on the following year, he moved to Cambodia permanently. He built up a NGO there called Cambodian Children's Fund. You can read about him in the internet if you want to. And that Cambodian Children's Fund is now looking after 3,000 Cambodian children and has programs to help another 12,000 children. And that little girl whom he got admitted to hospital with typhoid fever has now got a postgraduate degree in marketing and finance. She works with the Cambodian Children's Fund. So the purpose of telling you the story is what I said in the beginning, that career planning is important, But you got to keep in mind that life is inherently uncertain and things may or may not work out the way you want it to work out. So this man, this is not a fairy tale, this is not mythology. He is still alive. He is about 63-year-old now. He lives in Phnom Penh. He is penniless. He has received some international recognition. Maybe someday he will get a Nobel Peace Prize if he is lucky. But he is still working there. If you look up internet, you will see the heading of his biography given there is From Rags to Riches to Rags Again. He is a pauper now. He doesn't have any money. He runs this children's fund enthusiastically over the last 25 years, nearly 20 years. Now we come to ethics. If you look up a dictionary book, moral, it will tell you, the Oxford English Dictionary will tell you moral principles governing or influencing conduct. So that brings you to another term really. What is moral and what is immoral can be debated. So the important thing to specialize is, it's not a set of rules. It's not guidelines. It's not like GINA or gold guideline for asthma or COPD. It's not a written thing. You see, written laws can change. We have altered our constitution more than 100 times since 1947. So laws change, but what is ethical and moral wouldn't change. It's forever. Swami Vivekananda would have defined ethics as unselfishness. As long as what you are doing is not directly or indirectly related to your personal interest, you are ethical. But that's a difficult criteria to fulfill. Usually from daybreak till we go to sleep, all we do all through the day is looking after my self-interest. Otherwise, if I can be selfless for 5 minutes in 24 hours, that is a good achievement. Why is it so difficult? Because selfishness is a basic instinct. Most of the time. I said most of the time because there are instances even in animal kingdom where a mother tiger will easily risk her life to protect her cubs. So it's not that we always look after my own special interest. Love also is a natural phenomenon, is a natural instinct. The problem is to enlarge your faculty of loving beyond your own family, beyond your close circle. And there are people who would say that being principled is good for life, but being principled also has a flip side. People who say they are principled are often prejudiced. Now, what is the difference between principle and prejudice? To give you an example, supposing I am a vegetarian. I think vegetarianism gives you a better health, a better spiritual life. It's good for everybody. And you are a non-vegetarian and you think the same thing as for non-veg food. You think non-veg food is good for health, is good for spiritual growth, etc., etc. This is principle. You have a principle, I have a principle. But the problem is, if I start thinking, because I am a vegetarian, I am a better quality human being than you are. You are worse than me only because you are taking non-veg food. That's prejudice. So it's very difficult to remain principled without being prejudiced. Keeping your mind open that there are people who wouldn't agree with you, but nonetheless they are as good as you are. About 4 years back, I have a surgeon friend who lives in USA. He came to India in 2016 and we had a 2 hour long chat on this very topic, this eternal problem. The first quotation that you see on the slide, there is no doubt that unselfishness pays in the long run, but the problem is that we do not have the patience to practice it. That's a quotation from Swami Vivekananda. As I quoted, my friend said he does a lot of social work with Lions Club. He used to come to India twice a year at one time. He's a plastic surgeon. He had some connection with some missionary organization in Kerala and would stay here for 15 days and operate on 150 young children with cleft lip and cleft palate. He used to do that twice a year, every year until 2016. He said that, Dhiman, let me play devil's advocate. The problem is selfishness pays me right now. Why do I have to wait for the long run? That's what is the basic problem. You see, you have to have infinite patience and infinite perseverance to be able to remain ethical all through your life. Thank you, ladies and gentlemen. I think I have finished in time. That's all that I had to say. Thank you. You can.
I am afraid there is not enough time for questions to be taken up by the speaker. Maybe you take up with him one by one. I mean, when you meet outside. So thank you, Dr. Ganguly, for this excellent talk. We have enjoyed, of course, we have enjoyed. You have definitely added some new material, new thoughts, new ideas. Thank you very much.
Thank you, sir. So before we proceed to our next session, that is a symposium on pulmonary hypertension, I would like to request Dr. Sarthi Bhattacharya to give away the prize for Dr. Bhanu Pratap Singh as the first prize for Pulmo quiz.
Thank you, Bhanu Pratap. Since you are leaving, we have to give you a little privilege. All the best for you.
Thank you, sir. Now we move on to our next session, that is Symposium on Pulmonary Hypertension. To chair the session, I would like to invite Dr. Parthasarathi Bhattacharya. To coordinate the session, I would like to invite Dr. Parthasarathi Bhattacharya. And the first talk in today's session is, we will see the definition and etiology of pulmonary hypertension. And this will be given by Dr. Pawan Agarwal. I welcome you, sir.
There is a list of chairpersons for this particular session. May I request Dr. Sujan Bardhan, Dr. Sujan Bardhan, Dr. Rupak Ghosh, Dr. Soumitra Kumar, and Dr. Devanu Ghosh. Kindly project their bio slides so that the audience can, although they are famous and they do not require any formal introduction. Sujan, please take a chair. We have planned the session in a way that I, as a coordinator, I'll coordinate everything, means I have got nothing to do. The speakers will give their talk, and after the end of all the talks, the experts in the panel. They will discuss the issue. Questions will be raised, maybe by me, maybe by them, and the speakers will be involved. So it is a collaborative effort of the speakers and the expert panel to finalize the answers of the questions, if any. And without any further delay, may I request my good friend Dr. Pawan Agarwal to start the first talk. Pawan, please.
Thank you, Pathuda, and a very good afternoon to you, friends. So I think you must have enjoyed the last 30 minutes, and we are going to move from the sublime to the mundane. So the last 30 minutes were very thought-provoking, and what we are going to say in the next sort of 90 minutes or so, all of us, is the mundane. So my task this afternoon is to talk about the definition and the etiology of pulmonary hypertension. And I think this is a very complex clinical condition. And whenever we have to manage a complex clinical condition, we have to have some kind of organized schemata in our head, which can be applied consistently when we see patients with this clinical condition. And like all other speakers, I think today what I'm going to say is based a lot on the last joint guidelines published last year by the European Society of Cardiology and the European Respiratory Society. As all of us know, pulmonary hypertension is not really a specific disease. It's not a disease entity, but it's more of a pathophysiological disorder. And this can be the end result of multiple clinical conditions. So why are we interested in a disorder which is relatively less common? Because it has a significant morbidity and some mortality to it. And it is encountered by varying different medical specialties. So it's not a pulmonary or a cardiac problem only. Rheumatologist, liver specialist, general internist, a large number of doctors will see patients with pulmonary hypertension. The definition of pulmonary hypertension till 4 or 5 years ago was a bit arbitrary. It was not really based on comprehensive data, and the cutoff point of 25 millimeters of mean pulmonary artery pressure was rather arbitrary. Now there has been a revision of the definition, and the basis of this revision is both based on what we call normative data, or what happens in the normal population, and also on clinical outcome data. And the whole idea behind this revision was that we could detect this condition a little earlier, because as all of us are aware of, most of the time the diagnosis of pulmonary hypertension, like interstitial lung diseases, is usually delayed. And any delay in diagnosis of a fairly difficult clinical entity leads to increased morbidity. However, a caveat is that the evidence for specific pulmonary hypertension pharmacotherapy, and especially in group 1 patients where it is used, is based on the older definition. So what this means is perhaps we have to generate newer data whether this larger pool of patients who are now found to be pulmonary hypertension, to have pulmonary hypertension, really will benefit from the drugs we have. The central investigation in terms of guidelines for the definition of pulmonary hypertension is based on hemodynamic measurements made by right heart catheterization. I mean, later on we could discuss whether in resource limited settings this is really applicable all the time, or can we have alternative means of definitely diagnosing pulmonary hypertension. However, pulmonary hypertension is not just a number. The final diagnosis of a patient and the classification into the relevant group should integrate the clinical context and also all the results of the diagnostic workup which we do in these patients. From our days in physiology, we know that the pulmonary circulation is a low pressure circuit, i.e. that is low resistance and high compliance. And the compliance is high because the pulmonary capillaries can accommodate 3 times the normal blood volume during exercise. So if you look at the equation, the mean pulmonary artery pressure is a function of cardiac output multiplied by the pulmonary vascular resistance, to which the left atrial pressure is added. And in normal individuals, this is around the figure of 14. Now, where does this figure of 14 come in? Is it just plucked out of thin air? And the basis of this is that the definition of pulmonary hypertension has changed. So now in the newer guidelines, to define somebody as having pulmonary hypertension, the mean pulmonary artery pressure is more than 20, whereas in the earlier definition, it was 25 millimeters of mercury. And the exercise criteria used in the earlier definition, whereby a pulmonary artery pressure of more than 30 millimeters of mercury on exercise in everyone was considered to be pulmonary hypertension, is no longer tenable. Now, as I mentioned a little earlier, where does this figure of 14 come in? So if you look at various studies done on healthy individuals who are asymptomatic with right heart catheterization, and if you see in different cohorts, for example, males or females in different countries across the world, in different age groups, less than 30, 30 to 50 and 50, all of them have a mean pulmonary artery pressure somewhere around the 14 millimeter mercury mark. And this is the reason for choosing that as a normal reference standard. So this study, which looked at data generated from nearly 50 studies across 13 countries, 1,200 asymptomatic individuals who underwent right heart catheterization, the average mean pulmonary artery pressure was found to be 14 with a standard deviation of 3.3. So if you take 2 standard deviations above the mean, it comes to around 20 millimeters of mercury. And that is why in the new guideline, this has been chosen as the cutoff mark for pulmonary hypertension. Now, why was the exercise part of the definition removed? Because it has been found that in people who are aged more than 50 years, at least 50% of them will develop a pulmonary artery pressure of more than 30 on slight exercise. And from the equation, you can see why will that be so? Because as the cardiac output increases in exercise, the pulmonary artery pressure will increase. So you can't really have a situation where 50% of individuals above the age of 50 who have no disease are going to be classified as having pulmonary hypertension. So we talked about normative data, and this is outcome data. So if you look at outcome based on the levels of pulmonary artery pressure from this, you can see this was data generated from the US veteran system, more than 21,000 patients. And you can see that the inflection point for an increase in mortality is somewhere around the mark of 19 to 20 millimeters of mercury. So once your pulmonary artery pressure increases above this, there is more or less a linear relationship in terms of increased mortality. So as per the earlier definition, if you look at this data in those patients who have a mean arterial pressure between 19 to 24, even they have an increased mortality risk, that is 23% more risk of dying than those who have a pressure of below 19. If you look at it from the point of the pulmonary vascular resistance, again in the new definition that's been changed from 3 to 2, because from this data you can see that patients who had a PVR of more than 2.2 had a much increased mortality as compared to those who did not. So obviously this is a high risk group. Now the new definition in terms of the exercise pulmonary hypertension. So in the older definition, only the pressure was used, so more than 30 millimeters of mercury. So that was found to have a very low specificity for actually diagnosing patients with pulmonary hypertension. So rather than having just the pressure, the newer definition includes pressure as well as flow. So it's the pulmonary artery pressure over the cardiac output slope which is now used. And this has increased the specificity to nearly 100% in the diagnosis of pulmonary hypertension. So anybody who has a ratio of more than 3 millimeters per mercury per liter per minute is associated with a higher risk of cardiovascular events and a high mortality risk. That means if your cardiac output is below 10 and you have a pressure of above 30, then you probably have this entity called exercise-induced hypertension on exercise. So if you look at the new hemodynamic definition of pulmonary arterial hypertension, so pulmonary hypertension is more than 20 millimeters of mercury. And then if we split it into precapillary, isolated, postcapillary, combined pre and postcapillary, for precapillary, you have to have a raised pressure that is more than 20, your wedge pressure should be below 15, and your PVR is more than 2. For isolated postcapillary, you have a wedge pressure which is more than 15 and a PVR of less than 2. And for combined, you have features of both. That means a wedge pressure of more than 15 as in postcapillary, and a PVR of more than 2 as in precapillary. So now switching to the causes of pulmonary hypertension from the definition. So there are three variables in the equation: the cardiac output, the pulmonary vascular resistance, and the left atrial pressure. So conditions which lead to an increase of any of these three entities will cause pulmonary hypertension. So for example, if you have increased cardiac output due to congenital heart defects, due to cirrhosis, anemia, even rare diseases like thiamine deficiency can lead to pulmonary hypertension. Increase in the left atrial pressure due to heart disease, especially left-sided heart disease, left-sided valvular disease, and even restrictive cardiomyopathies. And then you have the classical so-called primary pulmonary hypertension of the past, where the main defect is a vasculopathy in the pulmonary arterioles, which leads to increased pulmonary vascular resistance. So for example, idiopathic pulmonary arterial hypertension, which we as pulmonary physicians face all the time, that is due to most of the lung diseases. If you look at it schematically, so you have the precapillary on one side, the capillaries and postcapillaries, and you can see that the group 1 is predominantly a precapillary disease, although this is not entirely true because some of them do have a postcapillary component. Most of the group 3 and 4, that means what we see as lung specialists, falls under the same hemodynamic pattern as the precapillary, and most of the heart disease related group 2 is postcapillary. So the newer classification of pulmonary hypertension keeps them into the same 5 groups as before. There has been some minor changes in the way they are classified. So for example, pulmonary arterial hypertension, the idiopathic variety has been split into 2. One who are non-responders at vasoreactivity testing, which is the largest group, and a very small group who respond at vasoreactivity testing. Similarly, in group 3, for example, the change has been that obstructive sleep apnea has been removed and it's been included as part of the hypoventilation syndromes as a cause of pulmonary hypertension. So if you look at it from a mechanistic point of view, the group 1 pulmonary arterial hypertension is predominantly due to an increase in the pulmonary vascular resistance. The pulmonary hypertension caused by left heart disease, which is the largest group of patients with pulmonary hypertension, is a post-capillary phenomenon due to an increase in the pressure in the left atrium. Group 3 and group 4 are very similar to group 1 in their hemodynamics. That means predominantly the mechanism is of increase in pulmonary vascular resistance. And group 5, which is really the miscellaneous or unclear group, so whether they have elements of all 3 or even elements we do not understand is not known. And one of the diseases which falls under this, which we have to manage, is sarcoidosis. However, it's not always very clear cut because every disease does not fall neatly into one group, at least in terms of mechanisms. So if you look at something like scleroderma, for example, scleroderma is a prototype of group 1 because secondary to connective tissue disease. However, we know that patients with scleroderma also can have associated restrictive heart disease sometimes. So there could be elements of group 2 there. A large number of these patients have interstitial lung disease sometimes, so they could be group 3. There's an increased incidence of pulmonary embolism, including in situ thrombosis in scleroderma. So there could be elements of group 4. So they cannot be put into very narrow categories always, at least in terms of their mechanism. In terms of pathogenesis, all of you have seen this an umpteen time. This is the holy trinity in the pathogenesis of pulmonary hypertension. So it's the upregulation of endothelin pathway and a downregulation of the nitric oxide and prostacyclin pathway. And this mechanistic pathway has been the reason why so many drugs, it has been possible to develop so many drugs for pulmonary hypertension in the last 20 years or so. So if you look at the group 1 of pulmonary arterial hypertension, most of it is idiopathic. About 50% is idiopathic and 50% is non-idiopathic. There is a heritable form, and predominantly it is due to the germline mutation in the bone morphogenetic receptor 2. However, this mutation is of low penetrance because only 20% patients with BMPR2 will develop pulmonary arterial hypertension. A large number of known and some unknown drugs can also lead to pulmonary hypertension, and we are all aware of the in the past the anorexigenic drugs, and of course certain newer chemotherapeutic agents, for example dasatinib, is also one of the important causes of pulmonary hypertension. And of course it's secondary to other diseases, for example connective tissue disorders, congenital heart disease, portal hypertension, HIV infection, and schistosomiasis. These are some of the drugs. There's a definite association with some of them, and there is a putative or possible association with some others. Pulmonary arterial hypertension is not a very common disease overall. However, if you look at certain cohorts, it is much more common. And in these cohorts, it becomes mandatory to think and screen for this condition. So for example, up to 10% of scleroderma patients will develop pulmonary hypertension. A significant number with chronic liver disease might have portal hypertension. And if you do not repair an ASD, up to 10%, and if you do not repair a VSD, up to 50% will have pulmonary hypertension. Now, group 2 pulmonary hypertension, or that associated with left heart disease, is the commonest on a worldwide basis. And the reason for this is that the incidence of heart failure has doubled in the last 30 to 40 years. And a large amount of this is naturally because of the aging population, increasing incidence of diabetes, obesity, and of course recognition of the entity of heart failure with preserved ejection fraction, which was not really there many years ago. Now, most of this hypertension is post-capillary. However, as disease advances, there are changes in the pulmonary vessels, and there is a precapillary component, especially in heart failure with preserved ejection fraction in the later stages. The prevalence of pulmonary hypertension in this group increases with the severity of the underlying disease. So in valvular heart disease, 60% of patients with severe mitral valve and 50% of those with symptomatic aortic stenosis will have pulmonary hypertension. So this is what I was talking about in terms of change of the phenotype. So just if you focus on the bottom part of the cartoon, as pulmonary hypertension increases in these group of patients, from isolated post-capillary, it becomes a combined pre- and post-capillary. So a left ventricular phenotype then changes to a right ventricular phenotype. Now this is what most of us in the audience see, the group 3 pulmonary hypertension, which is the second most common cause of pulmonary hypertension. The incidence of this, of course, varies depending on the population you look at. So in advanced COPD with respiratory failure, 1 to 5% of patients will have a mean pulmonary artery pressure of more than 35 millimeters of mercury. And in IPF, when we first see a patient, up to 1/10 of them will have a mean pulmonary artery pressure more than 25. And in advanced lung disease, those who go for lung transplantation, more than half have significant pulmonary hypertension. Why is that important in group 3? Because there is a definite correlation between pulmonary hypertension and the clinical outcome. So this study, which looked at IPF 5-year survival, if your mean pulmonary artery pressure was less than 17, the prognosis was much better, 62% survival as opposed to only 17% if the pressure was raised. If you look at COPD, the hospitalization rate once the pulmonary artery pressure goes above 18 becomes twice as that of those below 18. And if you look at survival data in COPD, the 4 and 7 year survival based on stratified for pulmonary artery pressure of 20, there is a significant difference. So it is very important to know what is happening in terms of pulmonary artery pressure because it has an impact of outcome. Again, if we look at the mechanism in this group of patients, initially you will find that on cardiopulmonary exercise testing, mostly they have a ventilatory exercise limitation. But as the pulmonary hypertension increases, changes occur in the pulmonary vascular bed. There is more of vasculopathy, changes akin to group 1. And on CPET, instead of a ventilatory exercise limitation, you start seeing a circulatory exercise limitation. So sometimes CPET can be very useful in this group of patients in determining the cause of pulmonary hypertension, which is a principal feature. Group 4 pulmonary hypertension is also being increasingly recognized. A large number of these patients were missed in the past. So chronic thromboembolic pulmonary hypertension, although it is still an uncommon disease, it's increasing in incidence, and the guidelines had put a lot of emphasis on this group of patients in terms of early diagnosis. And group 5 pulmonary hypertension has very unclear mechanism. It has a whole host of diseases under it. What is most important is sarcoidosis. And there are multiple studies which have examined this, and they've clearly seen that the prognosis and sarcoidosis in patients with pulmonary hypertension is much worse than those who do not have pulmonary hypertension. To sum up, pulmonary hypertension, although is a relatively uncommon condition, it's increasing in incidence predominantly because of group 2 and to some extent group 3. And the therapeutic strategies, of course, are very different. I'm not going to get into those. Those are for speakers later. So this was just the set for the rest of the discussion on pulmonary hypertension. Are we having questions at the end? Yes. Thank you very much.
Thank you, Pawan, for the lucid talk. Now we'll pass to the next topic. This is clinico-radiological identification of pulmonary hypertension. So may I request Dr. Devraj Josh? Dr. Josh, please.
পিপিটি পাঠিয়ে দিয়েছি তো পাঠিয়ে দিয়েছি ইমেলে কি দিলাম ও নিয়ে গেল আমার থেকে ইমেলে
If it takes time, we can go to the next speaker.
স্যার পাঠানো আছে
দাঁড়া দেখে নিচ্ছি ঠিক আছে বসে সামনে বসে So Somnath Babu, would you come? You have to help. He will present from his laptop. So our next speaker is Dr. Aniruddha De. He will be talking on echocardiography and in diagnosis and evaluation of pulmonary hypertension.
করবে হয়ে গেছে বলছি
হচ্ছে হয়ে গেছে
তো হয়ে গেছে
প্লিজ কাম
ও তাহলে ছেড়ে দেবো
সিরিজটা মেইনটেইন
হ্যাঁ হ্যাঁ ঠিক আছে
by the time the thing gets corrected, let me have some little chat with all of you. See, this PH is a very fascinating area of medicine. I won't say pulmonary medicine because it overlaps with other subspecialty also. And you have seen the list of causes. It's huge. So incidentally, I got interested to PH way back in 2009 when we had a Pulmocon and one of the international authority on pulmonary hypertension before that year agreed to come to Kolkata. His name is Maurius Hooper. So once Maurius came, actually we didn't know what to present. Then I felt the same topic, the clinico-radiological identification of PH would be best suiting me. But it was a great way to boost us. And we thought that why not we start looking at pulmonary hypertension. Maurius was very happy. He met a batch of doctors in the evening at Park Hotel. And while returning, he said, I've been traveling across the world. Your audience and your doctors are really the most intelligent. He praised us like that. But the problem is in Kolkata, in India, we lack in research, we lack in keeping data, we lack in so many other factors. So that yes, it's ready. Thank you very much.
Good afternoon to everyone. So thank you, Dr. Bhattacharya, for giving me an opportunity to speak on clinico-radiological diagnosis of pulmonary hypertension. Now, I have been fortunate to speak on various platforms about different aspects of pulmonary hypertension, but this is the first time I'm speaking on the radiological diagnosis of pulmonary hypertension. Now, pulmonary arterial hypertension, as we all know nowadays, is a diagnosis which has to be made by right heart catheterization, and also the predominantly suspicion is made by the echocardiography. But when you are sitting in your OPD practice, so when are you suspecting pulmonary arterial hypertension? When will you tell your patient? You cannot tell your patient every day to undergo echocardiography. So is there any clue to the diagnosis of pulmonary arterial hypertension, or is it for the severity on prognostication assay? So what are the things which we will look into when we will be discussing the clinical and the radiological features of pulmonary arterial hypertension? So to the points which I will discuss over coming 15 minutes is the clinical features of pulmonary arterial hypertension. Is it all because of the right ventricular hypertrophy or dilatation, or all because of the different etiology of the pulmonary arterial hypertension, or is it something specific to the pulmonary arterial hypertension? Second, signs of the pulmonary arterial hypertension in chest X-ray, CT scan, as well as in the MRI. Fourth one, which I will find it most fascinating, is identifying different etiology from the CT scans when you are evaluating patients of pulmonary arterial hypertension. And fifth one is the most current one, is the cardiac MRI, a fascinating subject for all the cardiologists to detect the pulmonary arterial hypertension. So when to start with is the clinical features of pulmonary arterial hypertension. So when we are talking about the clinical features of pulmonary arterial hypertension, so four things are important. First one, so your pulmonary vasculature, there is a resistance. So there will be a backward pressure. So backward pressure will lead to more or less features of the right heart failure. So all the signs of the right heart failure, that means the distended jugular veins, hepatomegaly, ascites. So all the signs of the right heart failure will be there. And second one, because the resistance is more, so the right ventricular output will be less, as a result of which there will be less flow through the pulmonary vasculature, and as a result the left ventricular output will also be diminished, resulting in signs of the diminished cardiac output, and diminished cardiac output will lead to the symptoms of the shock. So any kind of severe pulmonary arterial hypertension, particularly those due to pulmonary embolism or those kind of things, will ultimately not only will lead to right ventricular hypertrophy or right ventricular failure features, but also to the left ventricular failure feature. So there will be signs and symptoms of the right ventricular failure, and in advanced cases there will be features of the biventricular failure. So when there will be a biventricular failure or forward failure, there will obviously be cyanosis, basal crackles, dizziness, pallor, and all those kind of things. And when you are suspecting pulmonary arterial hypertension and different etiologies, So there will be different. When you are having a patient of ILD, it will be a typical features like dyspnea on minimal exertion. There will be features like scleroderma with particular cold intolerance, Raynaud's phenomena. So these are etiological symptoms and signs which I will not go into details. Now, there is a particular feature called as fatigability. Why fatigability is important? Because many a times patient will not tell you ki I am finding that much difficulty in shortness of breath. So early fatigability, and when I will go into different literature, you will also find shortness in absence of shortness of breath. Typically, fatigability is also present. Now, ominous symptoms is syncope. Syncope is a very ominous symptom because as we all know, syncope is due to decreased cerebral perfusion, and decreased cerebral perfusion means there are symptoms of the forward failure. So when forward failure sets in a patient of pulmonary arterial hypertension, it is a very, very bad prognostic marker. So syncope is a very bad prognostic marker in a patient of the pulmonary arterial hypertension. Weight gain is obviously because of the right ventricular failure features as a result of fluid accumulation throughout the body. Hemoptysis due to various reasons of the pulmonary arterial hypertension. I will show you there are generation of many collaterals. So these collaterals will also lead to the symptoms of hemoptysis in patients of the pulmonary arterial hypertension. So this is a cluster analysis of symptoms in pulmonary arterial hypertension. So what they have found, so they classified all the patients in different clusters. One is the cluster 1 which has been diffuse symptom, and cluster 2 are the severe cardiopulmonary symptom, and cluster 3 are the moderate cardiopulmonary symptom. And you will be very astonished to see the number of patients with severe cardiopulmonary symptoms are not that much. So most of them will have diffuse symptom. That means vague symptoms. It is very difficult to identify based on the symptom whether the patient is having pulmonary. So diffuse symptom number is much more compared to the severe or moderate cardiopulmonary symptoms. Third one is a sleep disturbance. So this is a new study which has been published in European Journal of Cardiovascular Nursing. So they looked into, when I'm talking about the symptoms or clinical, so they looked into sleep disturbance and psychological distress and health related quality of life. And they have found that 28% had mild sleep disturbance, 22% had moderate sleep disturbance, and 16%. So when you are summating all those values, you will have around 64% will have some kind of sleep disturbance. And when I'm talking about this sleep disturbance, this already looked into the other confounding variables. So sleep disturbance and psychological disturbance is also a very important symptom of even pulmonary arterial hypertension, like any other chronic diseases. So this is again similarly the symptom prevalence and health related quality of life, and obviously the health related quality of life is much poor. I will not go into the details. Looking into the symptoms, the most common symptom obviously is the shortness of breath on exertion, followed by the fatigability, and third one is difficulty in sleeping and other features of the right ventricular failure and the left ventricular failure. Now, chest X-ray indicator. So what are the signs which we will look into while we will see the patients of pulmonary arterial hypertension? I will go into the figures. So one is the more than 44 millimeter from midline to the prominent right heart border. In lateral film, the dilatation is suspected by when there is a filling of the retrosternal space and a boot-shaped heart with an upward tilt of the cardiac apex. I will go into each of the pictures first, then I will come. So this is the study where they evaluated simple screening of pulmonary arterial hypertension using a standard chest X-ray, and they have found that hilum size greater than 112 millimeter has got a sensitivity of 82%, and hilum by total chest ratio greater than 0.44 has got a sensitivity of 86%. But the problem lies in the specificity. It is only 30 to 40%. So also many patients, when we are looking at the chest X-ray, just looking a grossly enlarged hilum will give us a good clue to the pulmonary arterial hypertension. We will not miss, but many a times we will subject our patient to investigation which may not clinch the diagnosis of pulmonary arterial hypertension. So this is the picture. As we all know, there is a widening. The ratio when I'm talking about, this is the exact value. That is the 112 millimeter and hilum by chest greater than 0.44 millimeter. This is on chest X-ray, and there is a projection of the right cardiac border. So this is a pulmonary arterial hypertension in COPD determination by the chest X-ray. So they have found that in this patient, they measured the right and left descending pulmonary artery. And when we called it as a sensitive marker, the right descending pulmonary artery greater than 16 millimeter and left descending pulmonary artery greater than 18 millimeter. Now, when you looking at the sensitivity as the specificity of the right side, it is very sensitive and specific because you are having a 93% sensitive and 80% specificity. So, looking at the size of the ascending pulmonary artery as well as looking at the size of the descending pulmonary artery greater than 18 and greater than 16, particularly on the right side, is a very good indicator radiologically to diagnose pulmonary arterial hypertension. So this is a picture, as I already told you, in the lateral chest X-ray, there is fullness of the retrosternal space, and in the normal lateral chest X-ray, here you can see there is a gap. So here there is no gap. And when you are looking at the frontal chest X-ray, there is an enlargement of both right descending pulmonary artery as well as there is enlargement of the left descending pulmonary artery. Now, what do we mean by the pruning of the pulmonary vasculature? Pruning means when you are looking at the peripheral aspect, there is thinning of the vascular marking. So why there is thinning of the vascular marking? Because of the increased resistance of the pulmonary vasculature. So in the peripheral pulmonary vasculature, probably there is not that much flow because of the remodeling. So more the severe and more the chronic pulmonary hypertension patient, in the normal chest X-ray, you will find relative pruning of the peripheral pulmonary vasculature. So this is a frontal chest X-ray with a very prominent pulmonary artery which is coursing to the outer 1/3 of the lung with rapid tapering of the vessel, not that prominent bronchovascular marking in the peripheral aspect. Now looking at the CT scan evidence, so pulmonary artery, we will be talking both the static variables as well as the dynamic variables. So a dilated pulmonary artery can be seen due to elevated pulmonary artery pressure, very easily appreciated on a CT scan, and best location to measure at the bifurcation of the pulmonary artery perpendicular to the long axis. And this is the reference value based on the Fremic heart study. The pulmonary artery diameter greater than 29 millimeter in male and greater than 27 millimeter in female is considered to be abnormal. And while measuring, this is a very important point, whether we should do contrast enhanced CT scan or non-contrast enhanced CT scan. Always remember, for measuring the lumen size, you need to have a contrast enhanced CT. Why? Because you cannot differentiate wall from the normal lumen, and in advanced patient the wall thickness is also much more. So this has to be done by a contrast enhance, and when you are doing the CT you should not repeat for multiple courses. So best way to do a CT pulmonary angiography, provided the creatinine and the renal values are normal, when you will have all the finding, you can exclude pulmonary thromboembolism, you can look into the diameter for prognostication and all those values. Now, the CT determined pulmonary arterial hypertension. These are all papers which has been published, pulmonary artery measurement, estimation of by looking into the size. So until now, the sizes what I already mentioned, the artery ascending out, pulmonary artery right descending, left descending, and the measurement at the bifurcation of the trunk. So this is a CT angiogram, is significantly enlarged. You can see or appreciate the pulmonary artery at the level of bifurcation. And if you compare with the corresponding ascending aorta, the ratio of the pulmonary artery to ascending aorta, it is greater than 1. So pulmonary artery by aorta, the ascending aorta, it is better predicted the mean pulmonary artery pressure. There is a statistical algorithm that is 3.7 plus 24 into, but you need not to remember all those things. And it was found that the simple by looking at the CT scan which one is more dilated, but the main pulmonary artery by ascending aorta greater than 1 is associated with a mean pulmonary artery pressure of 20 millimeter or more. It also carries a very good specificity. So it has a when you are looking at a CT scan, if the ratio is less than 1, so you can reliably rule out the pulmonary arterial hypertension in majority of the individuals because it has got a very good specificity. Now looking at the dynamic measurement of the pulmonary artery, this is nowadays newer concept. So when there is an elevated pulmonary artery pressure, there will be hemodynamic changes which will affect the IV contrast flow into the central pulmonary vasculature. As a result of which, when you are doing the CT angiogram of a chest, first, you will have a ratio where you can clearly appreciate it is much more dilated compared to the ascending aorta, and the increased contrast density in the main pulmonary artery is due to increased resistance at the pre-arteriolar level, leading to the increased pulling of the IV contrast relative to the aorta. So here you can well appreciate the Hounsfield unit is 399 compared to the aorta. With the same injection of the IV contrast media, the contrast uptake is much more in the pulmonary vasculature compared to the corresponding ascending aorta. Now looking at the right ventricular wall thickness, these are mainly for the prognostication indicator. All guidelines, ESC guidelines have included this as a prognostic, but nowadays you may argue that we use pro-BNP as a marker or as a surrogate marker of right ventricle. But when you are looking at the radiology, right ventricular free wall thickness greater than 6 millimeter, it can detect or predict pulmonary arterial hypertension with an 81% sensitivity and 90. So again, it has got a very good sensitive specificity, and right ventricular by left ventricle ratio greater than 1.28 obviously has also got a very good sensitivity specificity. Now looking at the other signs, straightening or bowing of the interventricular septum, obviously due to the right ventricular overload shifting the septum to the opposite side. Septal angle, the angle between the interventricular septum and the line which is drawn from the midpoint of sternum to the thoracic spinous process greater than 135, it can also predict the pulmonary arterial hypertension. So septal angle, when you draw a line between the interventricular midpoint of the sternum to the thoracic spinous process and the interventricular septum, when it is greater than 135, this is also a good indicator. So this is a typical CT. When it is associated with pericardial effusion, it is not usually associated, but presence of pericardial effusion in a patient of right ventricular hypertrophy or dilatation or pulmonary arterial hypertension again is a bad prognostic marker. Now etiology of pulmonary arterial hypertension in CT scan. So if we look into some of the cases like this patient, when you have injected the CT and you have done for the contrast and you have found out this is a case of chronic thromboembolic pulmonary arterial hypertension due to the presence of the filling defect in the pulmonary vasculature. Similarly, this is a typical bronchial and non-bronchial collaterals. As I already told you why there is presence of the hemoptysis. So this is a coronal projection which have demonstrated in the right hand side picture. In the arrowhead you can see there are presence of the collaterals. So these are the collaterals. There are presence of multiple collaterals, and more presence of the dilated collaterals means so there are more and more obstructed pulmonary vasculature. That's why there is generation of collateral, and presence of collaterals is again a bad prognostic marker radiologically. This is another picture again in the arrowhead. You can see, although it is very difficult to appreciate, again the presence of some collaterals, this time even in the SBC and the left brachiocephalic veins. So this is another CT scan with contrast enhanced. It can show you the contrast flow from left atrium to the right atrium, showing the presence of the shunt and severely dilated right atrium. So in a CT scan, left ventricular hypertrophy and right ventricle dilatation and right ventricle by left ventricle ratio greater than 1 again is a very sensitive marker. This is typical of pulmonary arteriovenous malformation as shown by the circle and also by the arrows. So this is typical of aortovenous malformation. So these are the etiologies which you can find when you do a random CT pulmonary angiography, even when you are not suspecting. The same one, this is very uncommon, partial anomalous pulmonary venous return, and the right side is the presence of agenesis of lung. These are typical of different kinds of ILDs when you found while evaluating the CT, and also you will have a clinical picture. This is a patient with emphysema, again associated with pulmonary arterial hypertension. So these are the common features. I will not go into the details. This is very typical, again, the pulmonary arterial hypertension due to hypersensitivity, pneumonitis, as well as different other causes. And this is present in pulmonary veno-occlusive disease, very important when you are talking of pulmonary arterial hypertension. Presence of multiple nodules, ground glass opacity is minimal, pleural effusion associated with a mediastinal lymphadenopathy. And these are pulmonary capillary hemangiometasis, again, as we already told. So now coming to the last part of my talk is the cardiac MRI. So cardiac MRI, just remember, right, for assessing right ventricle, cardiac MRI is a very sensitive indicator. So I will not go into the details, and I will not make you bored by talking about different aspects, but always remember the right, for assessing any kind of right ventricular function, cardiac MRI is a very useful indicator. We have different markers like pulmonary arterial pulsatility, pulmonary artery mean transit time, but these are mainly for theoretical discussion. So again, in MRI, the dynamic interventricular septal shifting from right to left and the right ventricular insertion points. So this is the typical mapping on the cardiac MRI, and we can see there is a term called as modified Luke-Locker inversion, and they have a higher pixel density and more accurate for assessing the extracellular volume content. This is for the extracellular volume content, and more advanced the 4D flow MRI, those things. Just one or two cases, 31-year-old male resident of Guntur. He came to attend a football match at Kolkata, suddenly fell unconscious while playing and was admitted for further management. In CT pulmonary angiography, you can see or appreciate the main pulmonary artery dilated 30.13 millimeter, and pulmonary artery by ascending outer ratio is 1.33. The right ventricle seems to be enlarged. The right ventricle by left ventricle ratio is 1.41. Bowing of the interventricular septum towards the left ventricle. Echocardiography, grossly pulmonary arterial hypertension 120 with a grade 3 plus tricuspid regurgitation. And on the lung perfusion scan, there was suggestion of pulmonary embolism. So another patient, a 32-year-old male with a known case of corrected Epstein anomaly, VSD, patient already on ambrisentan, tadalafil for pulmonary arterial hypertension. Echocardiography revealed again a pulmonary artery systolic pressure of 110. Just the last one slide. The CT scan thorax, the main pulmonary artery diameter was 45 millimeter, grossly dilated main pulmonary artery. Again, another 75-year-old male suffering from rheumatoid arthritis, easy fatigability on echo with a moderate pulmonary arterial hypertension. So this is very sensitive. Why I am showing these multiple cases? Just to have a diameter of main pulmonary artery and the ratio between ascending aorta and pulmonary artery. And this is because of the ILD. So to conclude, symptoms of the pulmonary arterial hypertension are mainly due to right ventricular dysfunction, mostly non-specific. However, shortness of breath, exertion and fatigability. Chest X-ray is an easy and often overlooked investigation for assessment of pulmonary arterial hypertension. MRI and CT imaging modalities are capable of determining the etiology and pathophysiology of pulmonary arterial hypertension, and radiography cannot definitely diagnose pulmonary hypertension, but the signs discussed can give invaluable information to the pulmonologist for approaching a patient with new onset pulmonary arterial hypertension. Thank you.
Thank you, Debraj, for the elaborate discussion and presentation. May I request Dr. Aniruddha Dey now to present the echocardiographic features of pulmonary hypertension. I think every speaker is doing his best and keeping a lot of scopes for discussion. I'll request the audience to prepare with questions so that at the end we can ask them these questions.
Before starting about this lecture, what we are doing as an echocardiographer to determine the pulmonary arterial hypertension for the last 25 years, what we have been taught, what we are teaching, and overall what we are practicing echocardiography to determine the pulmonary arterial hypertension. First is that getting this type of picture, we get the TR, some tricuspid regurgitation, and put the continuous wave Doppler over it and get this envelope from which we can determine the peak TR gradient and the mean TR gradient, and adding the right atrial pressure, which is determined from the inferior vena cava size and collapsibility to give the pulmonary arterial systolic pressure, or in a way right ventricular systolic pressure if there is a no pulmonary stenosis or right ventricular outflow duct stenosis. So that is the thing we are doing for the, and we are categorizing it to mild, something like up to 45, then 40, above 45 up to 65 or 70 is the moderate, and above 70 is the severe. And same thing with the mean pulmonary arterial hypertension. But now the concept has changed. So what we were practicing for the last 25 years, we cannot do that now. Because, or in a way what we do, if I get the PR velocity, so we calculate from the PR velocity, from the peak PR velocity is the mean pressure, and from the end diastolic PR velocity, we get the diastolic pressure of the pulmonary artery. So that is already been covered. So these we are doing traditionally for the last 25 years. The previous studies demonstrated a correlation between this estimate of pulmonary arterial hypertension that obtained from invasive if you take the cohort of patient. But in an individual patient, they always differ. Why? Why that happens? So there are certain recent guidelines. There are many roles of echocardiography, but I will concentrate on what we will be going to practice in the next at least few years. Dr. Pavan Agarwal has rightly pointed out that this is no longer, we should call it, the cutoff is 25. It should be 20. Why? There is a reason is being well explained and well substantiated. Another important thing is that if we do not treat the pulmonary arterial hypertension below 20 or just above 20, between the 20-25 years, there will be untreated morbidity, mortality levels are high. And in addition, what we are already discussing for the last few minutes, that clinical suspicion based on the symptoms and physical examination should be given proper attention before embarking to any investigation. And of course, echocardiography is still a key imaging modality. That we have already discussed. I am not going to this slide, that you know very well. And we also know the most common form of PH is secondary to the left heart disease. You take in any echocardiographic laboratory throughout the world. That is the commonest, almost 70%. And other is 30%. So there is the left heart disease. So what we have to look for, the supportive measurement of classification of the patient with the intermediate or the low or the high probability PH. As we all know, that these are the things where majority are precapillary and mean pulmonary artery are majority is decreased except in the left side, that is in the group 2. So there is certain caveat. I'll actually questions myself that what are the caveat is that. See that errors may occur in accurate measurement of the peak TRV signal. These can result in both either overestimation or underestimation. If the quality of the Doppler signals is poor or it is eccentric, it will be inaccurate. So while estimating the right ventricular systolic pressure from the TRV using the Bernoulli equation, see the TRV is squared and multiplied by 4. So even a small error in the absolute measurement of the TRV can result in a significant changes to the estimate of pulmonary artery systolic pressure. And so you have to have a very clear envelope Otherwise, you'll like to miss, there will be disparity between the RSC and the echocardiography. You sometimes have tear signals even absent in a certain percentage of patient. How to determine then the pulmonary arterial by echocardiography? You know, the prevalence of tear in patient with the PSP less than 35 mm of mercury is only 80%, but increases to greater than 95% those with PSP more than 50 mm of mercury. So if the tear signal is absent, probability estimation should be based on the clinical context into consideration. Other concordant clinical and echocardiographic signs of RV pressure overload. Beside, absence of tear is insufficient to exclude the presence of pulmonary arterial hypertension. For example, I can give you a study. One study has shown that in patients with particularly with the scleroderma, there is a very important disease, being screened for PH, if TRV is cut off at 2.7 meter per second was used, this would have excluded some patient who had a mild pulmonary arterial pressure more than 40 mm. So we'll miss that patient. So what to do? So in patient with the trivial TR or in a suboptimal continuous wave Doppler spectrum, then injection of intravenous agitated saline is a must. You have to do it. It's considered because to augment your Doppler signals. As a default, if clinical suspicion still remains, you have to do RHC. See, if you get this type of pictures, you are getting the velocity of near about 3.22 meters a second with great concern. Now, if you augment with the saline, then you find that it gone up to 3.5. So your mean systolic, pulmonary arterial systolic pressure gone from 50 to 60. So that's got varying. What is the caveat 2? In order to obtain an estimate of the pulmonary systolic pressure, what happens? We estimate the RA pressure derived from the measurement of the inferior vena cava and the dimension and the collapsibility. However, in many patients, IVC dimension cannot be obtained because of the previous use of long-standing diuretics or something like that. Patient was dehydrated. In those measurement is possible, the accuracy between the eco-estimation of the RAP and the invasive measurement is as low as 34%. So you are bound to get the disparity. So these are the caveat. What is the caveat 3? It is well recognized that in patient with the severe free-flowing TR, that the correlation between the TR velocity and the RVSP is poor. But rather it has been recommended you do not do this in this type of patient and should not be performed. Hence, information obtained from echocardiography can only grade the probability of PH being patient, not the absolute value, rather than give a definitive diagnosis. Therefore, when assessing the probability of PH, the measurement of TRB should always be mentioned in conjunction with other echocardiographic criteria, not the absolute value, what you are writing it. Of course, you sometimes need to invasive measurement. And number 4, for getting a good envelope, experienced technician and interpreting physicians are essential. Because you learn the echocardiography in 1 month and started reporting the pulmonary artery pressure, that is bound to get wrong. You have to have a curve of learning. Consistency of skilled technician and readers, and that applies to any technologies, modality particularly. Caveat 5. The RV, the chamber of the highest concern in PH, is the least emphasized and the standard echocardiography. You see any echocardiography report, there are a lot of things is being written about the LV. E by prime, anything, a lot of things. For RV, 1 line. Normal right ventricle. Nothing else. You scan any 100 echocardiography report, you will find out of the 100, 90 will be like that. Only 10 report will find out. That's why we are missing this something. And caveat 6, of course, it can estimate the LVDP by echocardiography, but it may not be true in all cases. So what we'll do? Now we have to do like that. You have to give the probability of the hypertension. That is, if you get a TR velocity less than 2.8 meter per second, or more than 2.8, less than 3.34, or more than 3.4. If you are getting more than 3.4, no, you are satisfied that this patient is having high probability of pulmonary arterial hypertension. If you get the less than 2.8, and out of the 7 criteria I will tell you, at least you have to have 2 criteria. If it is absent, there is low probability. If it is present, then is a high probability. And if it is between the 2.8 to 3.4, again, you have to have 2 important echo features out of 7. That I'll tell you. If it is absent, again is the intermediate probability. If it is present, then high probability. So your report should do either it is a low probability hypertension, it's an intermediate probability hypertension, or is a high probability hypertension. Nothing else. So this is actually a summary. What are the 7 criteria? You have to think the 3 areas. One is the right ventricle, one is the pulmonary artery, and one is the inferior vena cava. In the right ventricle, what you will see? Right ventricle, left ventricle basal diameter ratio. This ratio has to be more than 1. And the flattening of the interventricular septum, as a result, there will be eccentricity index between the 2 axes of the right ventricle will be more than 1. So these are the 2 things we have to see in the right ventricle. Pulmonary artery, 3 things. One is the right ventricular outflow tract. You have to give a pulse wave Doppler and find out the acceleration time should be less than 105 millisecond. And second thing is that, or you have to have mid-systolic. If you get a mid-systolic notching, well, fine. Second thing is the early diastolic pulmonary velocity should be more than 2.2 meter per second. And third is that PA diameter at the level of the bifurcation should be more than 25. So these are the 3 things in pulmonary artery. And in the inferior vena cava and the right atrium, there are 2 things. Inferior vena cava absolute value would be more than 21. And there will be collapsibility. There is a new addition that if it is less than 50% with a snip, you take snip, or less than 20% with quiet respiration. Whichever may you practice, that has to be there. And right atrium, you have to be the right atrial area will be more than 18 centimeters a second. And echocardiography then will provide information about etiology and the prognosis of the patient with the pH. Patient with, these are the things to diagnose the pH. Now, if you have an established pH, then you have to exclude the left-sided heart disease and any intercardiac shunts. In addition, right ventricular dilatation, dysfunction, and other additional measurement has to be taken. So, in a nutshell, I'll go one by one. This is the way TR velocity is taken. You have to align the jet properly. You have to get a good envelope. You have to trace the envelope, and you will find the TR velocity and some estimation of the pulmonary artery pressure. This is the way pulmonary artery measurement has been done. And this is the pulse wave Doppler. In the RVOT, you can determine the acceleration time. This is the early diastolic PR. You can take this is the peak PR and this is the early diastolic PR you can get. And this is the mid-systolic notching you can get. And this is the way you do the eccentricity index. In the both axes of the LV, you find out. Because of the flattening, these will be more than 1. Because of the high RV pressure, there will be flattening of the interventricular septum. This is the way you measure the LV basal diameter and the RV basal diameter and the ratio. This is the way RA area should be measured, and this is the way inferior vena cava should be measured 1 centimeter before it enters into the RA, and maximum diameter you have to take, and then take the collapsibility either with a snip or with quiet respiration, whatever you need. In addition to that, there is certain additional measurement you might have to take to determining the severity of the pH. So we can we say this is a severe pH or not? Well, there are features. They are particularly useful in those patients with the confirmed diagnosis of pH. What are those? Again, there is 3 parameters. One is the right ventricular dimension, both the right ventricular dimension 1, 2, and 3, fractional area change, and the TAPC, tricuspid annular systolic, plain systolic excursion. Of course, you can do the right ventricular performance index. So how should you define the mild, moderate, and severe PH? Not by right ventricular systolic pressure, not nowadays. Not by the ratio of the RVSP to systemic blood pressure. Define pH severity by the degree of RV dilatation, RV dysfunction, PA pressure elevation, and decrease in cardiac index. These are the 4 most important features now we have to take into account. So these are the way you can take the right ventricular basal diameter, this is the mid diameter, and this is the right ventricular long axis diameter. There are certain, I'll not go into the absolute values that is written in the book, everybody will can tell. This is the way we determine the right ventricular fractional area shortening. That should be less than 35%. And another is the tissue doublet velocity should be more than 9.5 centimeter per second. This then myocardial performance index, I'll not going to. Another important feature is the pericardial effusion. Echocardiography, if you get in a pulmonary hypertension, the pericardial effusion, it is a marker of severe pulmonary arterial hypertension. Unless something extra is there. Then rightly pointed out, the RV hypertrophy. RV hypertrophy can reasonably be determined by the echocardiography from the subcostal view. If you take the cut in the subcostal view, where the anterior leaflet touches the right ventricle, you take the cut perpendicularly. If it is more than 7 millimeter, of course, CT here said the 6 millimeter, echocardiography, you take it to 7 millimeter, is definitely right ventricular hypertrophy. Then another thing is the right ventricular GLS, global longitudinal strain. This is a very early marker of right ventricular systolic dysfunction, and that can happen in a early pulmonary arterial hypertension. We have seen a lot of patients in the COVID era. The TAPC is normal, RV fractional area is normal, RV is not dilated, but still the RV systolic function reduced by particularly the RV free wall GLS. If RV free wall GLS is less than 20%, you must be careful. And another thing is that consider, of course, you can determine now fairly well by the 3D RVA. If it is less than 45%, that is another thing. TAPC, if it is less than 17 millimeter, is always abnormal. So beside these are the way we can determine how severe is the pulmonary arterial hypertension. In addition to that, there are some marker in assessing the patient with the pH. These measures include the stroke volume, cardiac output, and the pulmonary vascular resistance for the further improvement. Of course, these you can determine echocardiography. Though not very fair, but sometimes we can determine these pulmonary vascular resistance by this formula. In a particularly ICC unit, we do routinely practice, and there is some correlation is there. Not very perfect, I'm telling you, but it can be done. Both the pulmonary vascular resistance, then cardiac output, and the cardiac index. So in particular, these should prompt care, if this is there, careful assessment of the LV systolic and the diastolic function, measurement of the left atrial volume, and the exclusion of the left-sided valve disease. Color flow Doppler should be used to exclude the atrial and the ventricular septal defect. Following a thorough clinical review, a bubble study and the transesophageal echocardiogram may be considered in some cases, particularly exclude the cardiac cause of PH, especially in those patients with the confirmed PH. So to summarize my slide, this is a slide you must remember. So in patient with the suspected PH, the following echo parameters should be used to assess the probability of PH. First is the peak TR velocity. In the ventricle, the eccentricity index. Then the basal LV and the RV diameter ratio. In the pulmonary artery, the RVOT acceleration time or mid-systolic notching. Early diastolic PR velocity, PA diameter, and RA and IVC are area, and RBC size and collapsibility. I'll finish within 1 minute. One important case I'll tell you, so that this video will remember in your, particularly the fellows who are there, how it looks like a pulmonary arterial hypertension. In this particular cases, whatever I have said, all the features are present. So that's why in this index case I selected. is a known smoker for 20 years, severe respiratory disease, anasarca, severe indications and dyspepsia. And this is his chest X-ray, and they are very expert to interpret. I'm not expert in the chest X-ray. This is the ECG, is nothing but except some right axis, some clockwise rotation, some low voltage in the ECG that you commonly encounter in the lungs cases. And this is the echocardiographer. When you first put it in the subcostal view, you can see the right atrium is hugely enlarged. Not only that, this enlargement right atrial pressure is high. How you can know this septum is totally deviated towards the left. So even with the first look you can find. And another look is that size of the RA and RV, both the same. If RV size is like RV like LV, that means RV is dilated. No other call. There you have nothing to see. No measurement is required. If RV is equal to LV, RV is enlarged. Then you can see fairly accurately how is the free wall thickness of the RV, that is more than 11 millimeter, 10 millimeter. And this is the eccentricity index. You can see there is a totally depressed septum. And if you measure this, this will be more than this axis. You see the pulmonary artery. You see that this is the aorta. The index is that pulmonary artery size is usually size of the aorta. You see the branch pulmonary artery is the size of the aorta. If one of the branch pulmonary is the size of the aorta, you can determine this how much pulmonary artery pressure is having. So looking at each and every thing, you can find out this there. So this is another view. You can see the trabecular band being hypertrophied. So this is the right ventricular hypertrophy. Same eccentricity index. And you can see the color flow. One thing must be clear. Dr. Bhavan was seeing that the anomalous pulmonary venous drainage. So you can see all the pulmonary veins are draining directly into the left atrium. Nothing is going to the right atrium. So there is no anomalous pulmonary venous drainage. Then you can see the TR. From the TR you can determine same thing, the photo I have shown you. They determine that I am not repeat this one. And last, the inferior vena cava. You can see this is a dilated inferior vena cava, absolutely not collapsing at all. No variation in the respiration, even in the quiet way. So this is the way. Even you can do the hepatic Doppler study, and this is the one. Thank you. Good luck. Thank you.
Thank you, Dr. Dey, for elaborate discussion on the echocardiographic features of pulmonary hypertension. So we have already traversed a journey from clinical to radiological to echocardiography. Now I invite Dr. Shubhanand Roy. I am sure he doesn't require any introduction to present us with right heart catheterization. Shubhanand.
Thank you, Partha, for your gracious invitation to talk on this subject. After so many elaborate lectures and technical prowess, I should stick to a basic apparatus which came first for diagnosis and classification, and also some glimpses into the treatment. Now, yes. I should start with a quote from Eugene Brunwald in 2022. It is not 2002, it is 2022. It is mistyped here. As time and financial pressure still emphasis to interventional opportunities, right heart catheter seems to have been de-emphasized in the current era. Nevertheless, perhaps no other widely available study in medicine provides as much as integrated real-time physiological data for use clinically. Till its inception in 1960s by Frostman and the invention of the balloon catheter by Swan-Gunch, the right heart catheterization was the basic tool for diagnosis and treatment of pulmonary hypertension. Till 2004, this was a rule. Then came the era of non-invasive advancement and also some confusion about the diagnosis
and definition of pulmonary hypertension, which Pawan already said. And there, pulmonary artery pressure, even the pulmonary systolic artery pressure was taken as a sine qua non of pulmonary hypertension, and right ventricular catheterization became the last resort for pulmonary hypertension. Then came some important people who said, and everywhere it is written 2002, I'm sorry, it is 2022, guidelines erroneously placed RHC for advocating hemodynamics as the last test, and only if pulmonary hypertension is suspected. We encourage those working in the pulmonary hypertension field to rethink their approach to diagnosis, and rather than deferring the definitive hemodynamic assessment to the end of the workup, they should make it right choice from the very beginning. And here came the new guidelines which showed that pulmonary artery, right heart catheterization became so important for establishing the diagnosis and classification for pulmonary arterial hypertension. Now, what is gained? The right heart catheterization is the gold standard for diagnosis and classification, we all know. Also, it is mandatory for hemodynamic assessment of the heart and lung transplantation. People were initially hesitant to take right heart catheterization as an invasive procedure, which must have a mortality and morbidity, and it is found that it is almost negligible. The mortality is less than 0.001%. It is not 0.01, and the morbidity is less than 1%. And also, when a pulmonary hypertension is suspected, it can establish the diagnosis to get the mean pulmonary artery pressure, which is very difficult to get with echocardiography, as we have seen. We have we have heard Dr. Oniruddh today. It is very difficult to ascertain. And PVR also, it is also a parameter which is very difficult to get with non-invasive investigations. It is only better found and better estimated by right heart catheterization. So the classification also requires the PCWP or PAWP, which is equivalent to LV end diastolic pressure or LA pressure. And also for treatment, we need some tests like vasoactive test and exercising, hemodynamics on exercise, which are additive. So in a nutshell, our estimation and our workup of pulmonary hypertension should begin with a suspicion from clinical knowledge, clinical wisdom, and with echocardiography, which is an extension of clinical wisdom, and should be established by right heart catheterization. And right heart catheterization should come in the forefront. Then what is the circuit? Why it is so important? This is a very basic slide. If you see that from the right atrium, the blood goes to the right ventricle, to the pulmonary artery, then goes to the arterioles, then PCWP we get, and from the venules, and then from the LA to LV. Now, if there is a obstruction at the arterial level, you will have a pulmonary arterial hypertension, and it is precapillary pulmonary hypertension. Now, if there is a backflow from the LV, if the LV pressure is high, then LA pressure is high, the venular pressure is high, PCWP is high, and it can affect the arterioles. So it is a post-capillary hypertension. Basically, we are standing in midway and before the capillaries and after the capillaries. So pulmonary hypertension is basically two. One is pre-capillary and second is post-capillary, and third one is mixed. Beyond that, nothing is. There are a lot of things which can be explained by these simple two facts. And also, how you diagnose? When you see at the circuit, the right atrium and right ventricular pressures are equal in diastole because the tricuspid valve is open. The RV and PA is equal in systole because there is no pulmonary hypertension if we take this situation and the valve is open. LA and LV is similarly in diastole they are same. So the PA diastolic should be equal to PCWP and LA in diastole. So if I find that a PA diastolic and PCWP and LA are same, my hemodynamic consideration is perfect. Why I'm saying this? I'm coming to that later on. Now, how I do it? First is access. You can have an access, you can have an access to the brachial vein by an ultrasound. You can have an access to the IJ by the ultrasound. Also, you can have a femoral vein access, which we can do by ultrasound or by common puncture method. And you put a Swan-Ganj catheter in. And this Swan-Ganj catheter is a balloon tip catheter, and you need not do anything. You need not have a fluoroscopy then. You just push the catheter and it will go. And I'll show you that. It is always guided, should be always guided by an ECG. And by ECG, you know where you are going. So by that, you know that your you are going into the right pathway. So you get the pressures on. Once you go inside the circuit, go through that circuit, you will get the pressures and the oxygen saturation data, which we call oximetry, and all pressures should be taken at the end expedition. This is very important. Now, let us look at this. Though it is under fluoroscopy, and you can see that I just inflated the balloon. There is a balloon. You can see the balloon right now, and you see the balloon is inflated, and you can see the balloon is inflated. Now you will just push the catheter. Just push the catheter and it will go into the right direction. It will take its own course and go into the direction. And as you just see that it has gone inside the pulmonary artery and into the PCWP level. Now, how you know that you are in the PCWP? That is one of the most important thing, where from the erroneous calibration of the pressures come. If you see that the balloon is properly inflated, you should not inflate the balloon with a large bubble. It should be less than 1 milliliter of air, and it should be fixed to the point where it can be pushed, and there will be no movement of the tip. This is number 2. And number 3, you take a oximetry from there. If the oxygen saturation is more than 95, you know that you are at the right place. And why the oxygen saturation will be more than 95? You know that the oxygen saturation in the pulmonary artery is less because it is a deoxygenated blood. But when you are pushing the catheter down into the venule, it will take the blood from the LA or the pulmonary venules, and it will have a saturation more than 95%. So if these 3 parameters are meticulously followed, then your PCWP pressure, wedge pressure, will be perfect, and you know that you are getting the LA pressure and you are getting the left ventricular end diastolic pressure if there is no obstruction between the two, that is between LA and LV. So then you can have some calculation package. Then what calculations you have? You should calculate the cardiac output first. Now, this is another point where there is some errors is inflicted. Why? Because cardiac output is measured by Fick's principle. What is Fick's principle? The amount of oxygen consumed in the body, which is divided by the difference of oxygen content in the artery and the vein. It is very simple. It is called Fick's principle. Now, what is the amount of oxygen that is consumed? It is very difficult to discern because you need a mask, you need an apparatus by which you can calculate the oxygen consumption in 1 minute. But in most of the laboratories, we do not have this instrument. We have a nomogram from where we can derive the oxygen consumption. Now this nomogram, which is based on a lot of principles like Demer, like Lafarge, there are a lot of principles, but they have a error. They have an error of around 17 to 25%. So on the higher side, there will be a 25% error. If you take an indirect fixed principle. So direct fixed principle is direct measurement of the oxygen consumption, but indirect is what we practice in all the laboratories is by the nomogram, and this nomogram has got some errors. And you calculate the O2 content depending on the oxygen saturation. You measure the oxygen saturation in the pulmonary artery. You measure the saturation in the RV, RA, and then in the SVC and the IVC, and through that you calculate the content of oxygen in blood. That is, what is the content of oxygen? It is, I have given the formula, that is 1.36. It is the the constant for into the hemoglobin percentage into the oxygen saturation, and by that you calculate the VO2 or oxygen consumption and divide the oxygen consumption by the difference between the pulmonary arterial oxygen saturation and the mixed pulmonary arterial oxygen saturation, oxygen content. And but through that, and a multiplier 10 is used to convert O2 content from milliliter to deciliter to milliliter to liter. So with that you measure the cardiac output. Why cardiac output is important? Cardiac output is important to determine the pulmonary vascular resistance. Now I have talked about the pitfalls, and direct FIC is accurate. I told you that indirect FIC is a range of inaccuracy which is about 15 to 20%. So from this cardiac output calculation you calculate the PVR, that is pulmonary artery pressure minus PCWP by cardiac output, and SVR or systemic vascular resistance, which is the difference between the aortic and the RA pressure and the cardiac output. And also mean pulmonary artery pressure, you can measure it or you can get it from the your measurements. Now from the computer. Now this is the normal range of pressure. So we know we are not going into it, and this is the calculated parameters which should be calculated, and usually they come in a package. And also in some cases we can have the thermodilution catheters, which is a slightly costly catheters with some sensitive sensor at the tip, and it will give you the total package. When you just put the catheter in the pulmonary artery, it will give you the total package with all these calculated parameters. So the diagnosis of pulmonary hypertension is on the platter if you do it. Next is the oximetry run. Why the oximetry run is important, and it is a basic thing to all the cardiological fellows, that once you measure the oxygen saturation, and if there is a jump of oxygen saturation from RA to RV, or the SVC to RA to RV, and RV to PA, there is a chance that you will be getting a shunt, a left to right shunt. So any jump of oxygen saturation between the SVC to RA or IVC to RA, that is about 7%, or RA to RV, that is more than 5%, and the great vessels more than 5%, and or any level more than 7%, there is a shunt. And this shunt is, I'll take just 1 minute. And this shunt is, if it is in the RA, then it is interatrial septal defect. In is a ventricle, it is ventricular septal defect, and in the great vessels, in the PDA and aortopulmonary window. So pitfalls of PCWP measurement, I told you that if you are meticulous, there will be verification of the position of the catheters, waveforms, and as well as O2 sat. And next comes the two very important things, the vasoreactivity testing, which is important for treatment, and there is a definite protocol of vasoreactivity testing with nitric oxide inhalation nowadays. And if it is positive, then you know that you are dealing with a patient which will be benefited by vasodilator therapy. And Also, the exercise right heart catheterization, which is also difficult to get in a normal laboratory because it also involves some of the X-ray experiments. I mean, some of the instruments, and there already Pawan has told this. Then I am not going into this. And the fluid challenge, I would rather impress upon this because this is very, very important. In most of the patients which are presented in our lab for right heart catheterization, they are given Lasix, and they are almost normalized normal volume, and if I do a right heart catheterization on the resting phase, I do not get a raised LV pressure. This is the basic thing, and we have checked it, and we corroborated it with the LV pressure and saw that the LV end-diastolic pressure is not not increased. So these patients, if they are dehydrated or if they are euvolemic maybe, then the chance of getting a normal PCWP or LV end-diastolic pressure is much more. So we need a fluid challenge test by giving 500 milliliter of normal saline maybe within 5 to 10 minutes, and to test again and to see that whether there is a rise of PCWP more than 15 or more than 18 millimeter mercury. So that will clinch the diagnosis of heart failure with preserved systolic function. So this should be the algorithm. So to say one thing, that RHC is no more the last resort. We should begin with a properly conducted RSC. Thank you very much for patient hearing.
Thank you, Dr. Roy. We have now reached the treatment part. May I request Dr. Ranjan Kumar Sharma to speak about the treatment strategy of pulmonary hypertension with specific reference to class 2 and class 3. We cannot cover the whole pulmonary hypertension, so we have selected a particular part of it, which is the most intriguing and difficult.
Before I start, just about Dr. Rai's fluid challenge in right heart catheterization. We have now recently, many studies have been done, passive leg raising. If the patient has come with a suspected heart failure and your wedge pressure is normal, make both the legs elevated by 50 degree, keep it for 1 minute. If there is a rise of wedge pressure more than 19 millimeter, it's a diagnosis. It's a very, very sensitive test, and we need not give in a fluid challenge. This has simplified our diagnosis of heart failure. Yeah. But this swan gun is a very soft catheter, it's no problem. Anyway. So this slide has been described by Dr. Agarwal, so I'm not going to the details. But the thing is, you see class 2 and class 3, group 2 and 3 are very, very common. And they have lot of overlaps. And I will be showing some cases which will have a class 2 and 3 pulmonary hypertension. They both are very, very common in community. And we know that this has a large impact on the mortality and symptoms. And they can both coexist. That is the problem. In other classes of pulmonary hypertension, like primary pulmonary hypertension or your pulmonary embolism or sarcoidosis, the prognosis and the management is quite difficult. And the response to treatment is not predictable. But in class 2 and 3, we have definite treatment. The pulmonary hypertension levels can be brought down significantly, and we have definite drugs for them, and this is easier to treat. In some systemic disease where pulmonary hypertension is there, but other symptoms can be very, very predominant, and the pulmonary hypertension is there, we are generally not looking for it. So any patients who have a risk of development of pulmonary hypertension, we must look for pulmonary hypertension, even if the symptoms of pulmonary hypertension are not obvious and your findings are not obvious. And this is all described, so I am not going to the details of this pre-capillary and post-capillary. And this concept is known to you, so I am not going to it. So if a post-capillary hypertension is there, you will have a pre-capillary component also in most of the patients. Once there is an increase in the left ventricular end diastolic pressure, ALF pressure rises, the pulmonary venous pressure rises, the pulmonary capillary pressure rises, and there is a reactive hypertrophy, reactive constriction of the arterioles and small arteries. And this chronic constriction will cause hypertrophy of the muscles, and there is a decreased response to NO, there is increased sensitivity to the endothelin. So there is a progressive hypertrophy. And so in long term, you will find that the patient has a significant pre-capillary component also. So a chronically raised post-capillary hypertension, in long run will have a pre-capillary component also. So just coming to a case. So the case is these are very it's a real cases, and I have not synthesized it. And this you will get in your clinical practice day in and day out. Patient came with shortness of breath for 6 months. She had well controlled blood pressure on telmisartan and amlodipine. ECG showed left axis deviation. Otherwise, ECG was normal. Echo was done. It was mild concentric LVH with LA diameter of 35 millimeter. Grade 1 LV diastolic dysfunction. Chest X-ray CTR was 60%. Pulmonary bay was full. RPA was slightly dilated. But the clinician did not give them much importance because the echo finding was not very, very abnormal. But patient came with the symptoms of shortness of breath. Blood biochemistry, renal function was normal, and she was sent back home. ঠিক আছে, ও ভালো হয়ে যাবে. And this was the X-ray. Although the X-ray showed there is a pulmonary hypertension, right pulmonary artery is dilated, MPA is dilated. The importance was not given because echo was found to be normal or near normal. Now patient comes within 6 months with rapidly progressive shortness of breath, palpitation and leg edema for 3 days. She had been taking atrophy for low back pain for 3 days. The blood pressure was 176/98, pulse 110, LVS4 was present, fine crepitations in the lungs with elevated JVP. Lab parameters, ECG tachycardia, LAD, ECG, blood urea was slightly raised, creatinine 2.4, troponin normal, NT-proBNP was elevated. Now this time echo was done properly. IVS was 14 millimeter, ejection fraction 66%. Left atrial volume was high, grade 3 LV diastolic dysfunction. LV filling pressure was 24 millimeter, means wedge pressure is 24. IVC was distended with low collapsibility, grade 1 TR, and the pulmonary artery systolic pressure was 55 and PA mean was 34. So patient had a significant pulmonary hypertension, uncontrolled hypertension with deterioration of renal function. So the salient features were patient was hypertensive, obese, had 6 months of shortness of breath with fairly normal function investigations. There was some clue of X-ray, but it was not given importance. Then after NACID, they had a rapid deterioration and developed pulmonary hypertension. So why the patient was not diagnosed in the first place? It was not properly interpreted. NT-proBNP was not done. A patient who has come with shortness of breath, this NT-proBNP has to be done. It's a very, very sensitive test. But again, now we have recently found that many patients come with shortness of breath. We go for all the parameters with echo. It is found to be normal. NT-proBNP is found to be normal. And it has been found that if you go for right heart catheterization, you will find features of LV diastolic dysfunction in good number of patients. So if you have any suspicion of pulmonary hypertension, even if your NT-proBNP is normal, your echo is normal, patient has to be undergoing this RHC so that you can pick up pulmonary hypertension in early stage. And then exercise echo, yes, it was not done, but again, it's a technically demanding thing and you need a very good expert to do this exercise test. And this passive leg rising, I have said, it was, if you do right heart catheterization, it is very, very simple to diagnose. And this happened because of the NACID causing altered hemodynamics and sodium and water retention, and leading to this precipitation of overtness of LV diastolic dysfunction that was there, and that led to the development of pulmonary hypertension. So, whether this patient required any hemodynamic assessment for diagnosis of pulmonary hypertension, this patient I say no, because you have a echo evidence is quite clear, and it is class 2 because you have a filling pressure is quite high. You don't require any other assessment for to look for it. So it's a classical class 2 pulmonary hypertension, and the treatment of reduction of pulmonary wedge pressure by diuretics, by maybe ARBs with your SGLT2 inhibitors will reduce the pulmonary hypertension, reduce the diastolic dysfunction, and can improve your pulmonary hypertension. So the management of this patient is not very difficult. The problem is the diagnosis is difficult. They come to us quite frequently, but they are not diagnosed. This is another patient. This was sent by Dr. Bhattacharya to me. This patient was 65 years male patient on smoker on multiple antihypertensive with uncontrolled hypertension. She used to have exacerbation of COPD for the past 3 years, never got hospitalized, and was first admitted in July 2022 with features of AECOPD, with blood pressure of 180 by 90, pulse of 118, regular, leg edema was there, elevated JVP, centrally cynosed with overt features of COPD. So this was his X-ray. Severe LVH, ejection fraction 62%, left atrial enlargement. Grade 2 TR with RV systolic pressure of 105. ECG LVH with strain, biatrial enlargement, blood investigations were normal. So it was a case of uncontrolled hypertension, COPD, and corpulmonal. And at the time of discharge, patient was on amlodipine 10 mg, telmisartan 80 mg, chlorthalidone plus aldactone, and the blood pressure was still not controlled, 160 by 90. He was on inhaled bronchodilators. Saturation at the time of discharge was 96% on room air, and PA systolic pressure came down to 65. So the control of blood pressure to some extent and management of COPD decreased the pulmonary artery pressure from 105 to 65. And there is a significant reduction. So I say the class 2 and 3 are manageable to some extent if it is treated well. But thereafter there were 3 more hospitalizations in next 6 months. Every time the BP was on higher side. Every time there were features of congestive heart failure. The systolic pressure, RV systolic pressure every time more than 100. And at the time of discharge, the systolic blood pressure came down to 65 to 70 millimeter. And only mini-press XL 5 milligram was added for control of blood pressure. Now patient is getting hospitalized again and again. So this patient was taken for catheterization. Angiography was done because a person who is having severe LV diastolic dysfunction, heart failure, we need a coronary angiogram to rule out with a long history of hypertension and smoking. Renal angiography was done to rule out any secondary cause of renovascular hypertension. The saturation at room air was 90%, and on oxygen it became 100%. This is important because a person who has a significant pulmonary hypertension, Dr. Aniruddha was showing that septum will shift towards the left, and you can have an opening of the foramen well, and there can be shunting of blood from RA to LA. So this cyanosis may not be always because of COPD. This cyanosis can be because of shunting of blood from RA to LA. And if you give oxygen, if there is a 100% oxygenation, this shunt is not there. So just by giving oxygen and looking at the saturation, you can rule out shunt. And cardiac catheter pressure data, the RA mean was 18, RV pressure 90 by 18 millimeter. So the RA and diastolic pressure and RA mean pressure is equal. Pulmonary artery pressure in room air was 85 by 60. The mean was 74. And after giving oxygen, it came down to 60. So this improvement in saturation decreased the mean pressure from 74 to 60. So you have a precapillary hypertension, that is hypoxia reactive, that got improved on just giving oxygen. LV pressure, the LV end diastolic pressure is 36. So you have a significantly elevated LV diastolic pressure because of severe hypertrophy and uncontrolled hypertension. Aortic pressure by 185/95. So this is the right heart catheterization that Dr. Rai was saying. The wedge pressure and the PA diastolic pressure, it should be almost similar in a normal person. If the pulmonary wedge pressure increases, the diastolic pressure will go up in the same fashion. But there can be some precapillary component can be there because of reactive pulmonary hypertension. The diastolic pressure can be slightly higher than the wedge pressure in a chronic case. And again, the systolic pressure of pulmonary artery and RV systolic pressure should be equal. So in my case, so this concept of I did not go for this cardiac output measurement and PVR management because it is not easily available, it is costly, and you have a chance of error also. So just looking at this diastolic pressure gradient, if you have a diastolic pressure and wedge pressure difference is less than 7 millimeter, it means there is nothing in between. So we call it as a isolated post-capillary. If the diastolic blood pressure is higher, more than 7 millimeter from the wedge pressure, means the precapillary component is also higher. So we need not go for the pulmonary vascular resistance testing in all the patients. Although it is more sensitive, but you can have a fair idea by just looking at this only, because I just went for this calculation to look for what is the precapillary component, which is the postcapillary component. Just looking at this diastolic blood pressure and wedge pressure gradient. So how to interpret this data? The number one, there was a normalization of saturation by oxygen, giving suggestion that there is absence of shunt. The elevated PA pressure and RV diastolic pressure is due to right ventricular hypertrophy and RV diastolic dysfunction, and it is secondary to long-standing pulmonary hypertension. PA systolic pressure, mean pressure and diastolic pressure were very high, although I did not calculate the pulmonary vascular resistance. Here the LVDP was 36 millimeter. This is a post-capillary component, that is a passive pulmonary hypertension. The precapillary component in this patient, that is the diastolic blood pressure gradient, means diastolic blood pressure minus LVDP. That was 24 millimeter in room air, and it was 10 millimeter on 100% oxygen. So that is the precapillary component, and this difference happened because of the hypoxia, reactive pulmonary hypertension. So this precapillary component is partially reactive due to treatment of due to hypoxia, and can be managed by giving oxygen and treatment of COPD. And total transpulmonary gradient is also a concept that has to be understood once you are going for right heart catheterization. This mean pulmonary artery pressure minus wedge pressure, that is a transpulmonary gradient. So what we can do to this patient? If you give therapy of diastolic dysfunction by control of blood pressure, giving low dose loop diuretics, SCL2 inhibitors, spironolactone, ARBs, or maybe ARNI, you will have some reduction of diastolic blood pressure, and pulmonary hypertension will regress. Management of COPD will regress the precapillary component of hypoxia. Long-term control of this pre and post-capillary hypertension will lead to regression of hypertrophy, so you will have improvement in the long term. And a pulmonary hypertension react or a specific drugs will only act on the precapillary component. So many of the pulmonologists and we cardiologists are also using for control of this precapillary component. We do not have a very good effect, although we are trying with so many drugs, and we hope that the newer drugs will be more useful for this type of hypertension. Thank you.
You have touched upon you have discussed a very fascinating area, seemingly a little difficult, but those students who are at the back seats, I would request them to get into this business, because PH is coming in a big way in our day-to-day practice. Well, we have got a very short presentation followed by question and answer. This presentation is from my institute. May I request our research fellow Shayoni to present it?
Thank you very much, sir. I thank all the esteemed panel members and my guide, Dr. Bhattacharya, for giving me this platform. So today I, on behalf of Institute of Pulmocare and Research, would like to present our experience with pulmonary hypertension over the past few years. So pulmonary hypertension is a quite common etiology that we see in our everyday practice. However, group 3 PH, that is lung disease associated PH, is the most common one. We often see patients with shortness of breath coming to our clinic, but unfortunately we are unable to treat them due to the lack of endorsed guidelines. Further, the difficulties and hesitations associated to get right heart catheterization done has emerged as one of the major obstacles in our area. Further, this discouragement by experts in 2013 to vasodilator treatment for COPD-PH further confused us regarding the treatment and diagnosis for pulmonary hypertension. We then decided to develop a feasible algorithm for the pragmatic assessment of pH, and this is how we came up to our novel diagnostic criteria, that is clinical radioechocardiographic criteria for the diagnosis and assessment of group 3 PH. This criteria comprised of the clinical symptoms of PH, the radiological assessment done through chest X-ray and HRCT, and Doppler echocardiography for measuring the pulmonary systolic arterial pressure. We summarized that at least 1 point from each category needed to be positive for a patient to be diagnosed with PH. This algorithm was further supported and endorsed by our framed consensus, that is the Kolkata PH group. On the basis of this algorithm, we estimated that approximately 30% of our elderly patients had pulmonary hypertension. So now if we see the global prevalence of PH, that is, if we compare the Occidental and the Oriental, we can see that the major burden of pulmonary hypertension lies in the Western countries. So in the similar way, we also tried to understand the etiological prevalence of group 3 PH in our OPD practice. And on 356 patients, we tried to reduce the relative percentage distribution of class 3 PH and saw that COPD PH was the highest, followed by DPLD, asthma, TB, and other etiologies. If we categorically summarize the parameters, we saw that the systolic pulmonary arterial pressure was persistently high amongst the patients, and the overall CAT score was also relatively quite poor. This was the publication. So simultaneously, we derived several byproducts from our consecutive studies. For instance, in this case, we observed that approximately 12% of our patients with a history of tuberculosis often had a chance of developing PH. Further, pulmonary arterial dilatation was also quite common in patients exposed to chronic arsenicosis. But we were still in a dilemma as to how we can treat these patients despite of all the glaring obstacles that we were facing every day. Moreover, the recent guidelines of 2022 also did not recommend vasodilator therapy for patients with lung disease. However, if we consider and observe the survival statistics of these patients, we can see that they are grossly compromised. And according to the Gießen Pulmonary Hypertension Registry, it has been deduced that the 5-year survival rate of lung disease PH accounts to only 38%. So we then decided to go for a compassionate treatment strategy for group 3 PH patients. Here, we targeted only severely sick patients and subjected them to all possible means of treatment. The symptomatic patients were included in our trials, and these patients usually came with a DSAT max of more than 3%, as noted from our exercise test, that is 2-chair test. They usually belong to class 3 and class 4 functional status and had an echocardiography-derived PAP pressure of more than 45 mmHg. These patients were then given a graded dose of vasodilator treatment and were followed in a subsequent follow-up visit. Now I come to the fact as to what is two-chair test. I will not go into details as it was discussed a lot yesterday. So since we had logistic constraints and could not perform a regular 6-minute walk test for these patients, we developed this modified exercise test to note the post-exercise desaturation of the patients. This is a standard report that was generated where we noted the pulse rate change and the saturation for the patients after every 10 seconds for 2 minutes. The blue curve indicates the pulse rate change and the red curve notes the saturation. The saturation, that is the maximum desaturation, that is desat max. Here, in this case, it is 10%. So keeping in mind our algorithm and the compassionate treatment therapy strategy, I would like to discuss a small case study of a 60-year-old man. He was an ex-smoker and he presented to our clinic with a basic saturation of 94%. The WHO functional class was 3 and CAT score 15. According to the two-chair test, the desat max was 7% and echocardiography derived pap pressure was 50 mmHg. The patient was given all means of treatment and was then recommended with a vasodilator therapy of tadalafil 20 mg for a period of 1 year. After a year, if we compare the baseline parameters and the follow-up status of the patient, we can see that his health status, the desat max, and the functional class improved considerably. So these findings gradually gave us some hope towards our treatment strategy, and we published it in different places, including our own bulletin, that is the Pulmoface. So over the years, we kind of developed our own preamble as to how and when we could treat these COPD patients with vasodilators. So this came with our own scheme of events, which primarily include first to treat the COPD. Then we treated the underlying comorbidities of the patient. We tried to manage the hypoxemia of the patient and provided them with the best means of pulmonary rehabilitation. We conducted 2CT on a regular basis to check the WHO functional class and echocardiography to understand the systolic pulmonary arterial pressure of the patient. Those patients who had a desat max of more than 3%, we recommended them with a sildenafil with a graded dose. We conducted regular follow-ups and looked for changes in their two-chair test and health status. So keeping in mind this preamble, we conducted another study with 84 COPD-PH patients, amongst which 57 patients were given a vasodilator treatment and was observed after a follow-up period of 3 months. We conducted a statistical analysis and we can see that the CAT score and the maximum desat max of the patient significantly differed after a period of 3 months. So this further gave us confidence and we decided to go for the hemodynamic endorsement of our algorithm. We were lucky and got an opportunity to conduct right heart catheterization for 77 group 3 PH patients, amongst which again COPD PH was 51%. We then conducted a pilot study with 18 COPD PH patients who were differentiated on the basis of their desat max. And here we can see that the pulmonary vascular resistance statistically differed amongst both the groups. Again, we had a byproduct from the subsequent studies where we observed that echocardiography tend to overestimate the PAP pressure when compared to right heart catheterization by 69% approximately, but it did not tend to miss any diagnosis of patients with PH. So when we see if we consider our current focus, we are performing randomized trial to further develop a scientific rationale of our study to treat COPD PH patients. These are the recent publications that we had, and thank you.
Thank you, Shani. It has been a very wonderful journey from the beginning. Now, because of the time constraint, we have to, restrict to some extent. I would request the experts and the speakers. I request one by one. They can come with a comment or a question so that the rest of the people can answer. I'll be just sitting quiet. If there's any question directed to me, I'll be answering on behalf of Shayone. So you can come and take the chair. Please, press my mic.
I have a question.
Yes.
What I have read is if you give a vasodilator to a COPD patient, you are making more perfusion to a non-ventilated area. So you can have a VQ mismatch.
Yeah, very good.
So that is the reason it is not recommended.
So actually, that is one of the reasons why it is not come up.
And the degree of pulmonary hypertension is usually not very severe in COPD. So the RV dysfunction is not a very problematic thing in COPD. If RV dysfunction is there, or if the pulmonary artery pressure is very high, then probably it makes a sense that you give a vasodilator therapy. If neither of them is present, my belief is like that.
What not believe, you are true. Because what guidelines say that if you have got a pulmonary hypertension in COPD, there are two classes of patient. The one class of patient is just 5% at most. They have got high pulmonary artery pressure, mild to moderate COPD. And these patients should be treated like pulmonary artery hypertension with vasodilators without any hesitations. Fine. The other group is severe COPD with mild to moderate pulmonary hypertension. And these patients, their pulmonary hypertension adds to their quality of life. They worsen the quality of life. They compromise the survival, and there is no recommendation of treatment. Because number one, there is a chance of VQ mismatch after vasodilator. Because number two, many of these patients are 2+, group 2+, group 3 pulmonary hypertension, because we do not know what happens in the pulmonary venous circuit of these patients. Because we are taking in consideration the left atrium, the left atrial pressure, the pulmonary capillary wedge pressure. And we know that in COPD, both pulmonary arteries and pulmonary venues, they're all affected. That segment of the whole, circuit is relatively unknown. We do not know what is happening out there. Plus, there are so many other technical glitches, like measurement of the pulmonary artery pressure by catheterization, by echocardiography. There are so many, difficulties. So a lot of them has added to it, and the guideline has not come up with any recommendation because they don't have any evidence for treatment. So what we thought that we have seen that patients are suffering. We have seen the patient may not have started with gross right heart failure. We have started treatment. And then somehow that two-chair test has evolved. Now we are doing two-chair tests. We are actually, validating two-chair test with hemodynamics. And so far what we have found that this two-chair test can distinguish the transpulmonary gradient below and above 12. So that's a very major finding. If you can understand the transpulmonary gradient, that means you can understand the precapillary vis-a-vis postcapillary. So if you can decide there is a precapillary hypertension, there is a rationale of giving treatment. That's how that our approach was correct. It came up spontaneously. We went on thinking on it. We are still doing this, but this is one revelation that this post-exercise recovery response test can considerably, or I will say fairly, distinguish between pre and post capillary pulmonary hypertension. So this has happened. Maybe we are in the very early part of the learning phase. It might be much more clear in future.
Partho, can I make a small point here? The transpulmonary gradient and diastolic pulmonary gradient, these have been obsolete nowadays in the new ESA guidelines, because they sometimes mar the diagnosis. It is more important to get the pulmonary vascular resistance in these patients. And no, not really difficult. If you do a RHC, it is not very difficult. And now the point is, what you said is absolutely correct. That is, in many of the COPD pulmonary hypertension patients, there is a ventricular contribution to the pulmonary hypertension. So basically, we need to differentiate which is a combined and which is an arterial hypertension maybe. So if it is a combined, then probably the vasodilators will not be a very good value.
You are right, sir. Because diastolic dysfunction is so common in COPD that if you do not address diastolic dysfunction, perhaps you are doing a mistake giving vasodilator to these patients. to answer the first part of your question, when we looked at the difference, then there was same significance between the high and low DSAT max for pulmonary vascular resistance and the diastolic gradient and the pulmonary pressure. So there is the same difference. And if you make a ROC curve, they are coming almost same. So it is also able to differentiate the pulmonary vascular resistance below and above 3 Wood's unit. So all this, in fact, we have been stuck for a long time because of relatively high wedge pressure in almost all of our patients. And in this series where we have compared the DSAT max, all our patients had got over 15 millimeter of mercury pressure, capillary wedge pressure. So it was difficult for us to appreciate how to go ahead. And we actually held the whole exercise of trying for a publication for over 2 years. So now it's intriguing to understand why our population has got so much of high pulmonary capillary wedge pressure. Even with that, DSAT max has been able to differentiate the two groups. Had the capillary wedge pressure been little low, the distinguishing capacity of this particular parameter would have been far better. The DSAT max.
I just like to make a clinical comment here. This is just clinical medicine. When you see a patient of pure COPD, and in echo you expect a pulmonary artery pressure of less than 50. Whenever you see a pressure which is more than 60, you should definitely think that this is not because of COPD and this is because of something else. And this patient needs investigation. If you do not investigate, you will miss something and patient will one day come with severe heart failure. And the most common reasons in our setting today would be COPD leading to hypoxia leading to left ventricular dysfunction, or hypertension leading to left ventricular diastolic dysfunction, or an arrhythmia, especially different types of arrhythmia and atrial fibrillation in particular, is again another cause, and coronary artery disease. So 4 things you must rule out in these patients: hypertension, coronary artery disease, arrhythmias, and hypoxia. And if you do not look for these things, this patient, like I think somebody presented a case, will come with severe heart failure.
Yeah,
after
if I can add to that, COPD and HFpEF is a very common combination. Most of us working in the CCUs and ICCUs will, corroborate with me that COPD and HFpEF are very common combination. In fact, those patients at their first presentation would have a pulmonary artery systolic pressure of 70 or plus. As you treat the heart failure, it will settle down to whatever Devanuda just said, to a value less than 50. So it works like magic. Just 3 days of treatment with diuretics and the pressure comes down.
So so there are 2 parts. May I respond to both of you? First to Dr. Ghosh Roy. You have mentioned 4 causes where pulmonary hypertension may be affected. I agree to it because it's been well established. Left ventricular diastolic dysfunction, as I have been through the literature, can cause pulmonary hypertension. We have, however, found no association of DSAT max with left ventricular diastolic dysfunction. We have to be more thorough on it, but we have not found. What we have found that the patients who have got heart failure with preserved ejection fraction, the DSAT max has got some association. Second, that in our patients, when we have got a disproportionately high, so-called 50, 60 beyond, we also question why it is so. Then we went bit thorough on it, and at least 40 to 50% of these patients have got concomitant pulmonary thromboembolism. So they have got a component of chronic pulmonary thromboembolism associated pulmonary hypertension. That is group 4 pulmonary hypertension. I think that is neglected. Regarding ICU admitted patients, my view is that in a sick patients with a lung disease, pulmonary artery pressure is going to rise, be there heart failure or not. So that is a special situation which we should not consider. What we are considering, the patients who are walking to us in our day-to-day OPD practice, they've got a poor quality of life. Their CAT score, as we measure the health status, is above 12, 13. They've got easy fatigability. And these patients have got pulmonary artery pressure, which is 40, 50 systolic pressure. And if you can improve their quality of life, like the patient we have displayed, which Shavani has presented, so that is a good thing. My focus is onto that segment only, not to the very sick patients, not to the patients who have got a very high pulmonary artery pressure, but the patients who have got moderate to severe pulmonary hypertension and mild to moderate to severe COPD and mild to moderate pulmonary hypertension.
So when we are
No, the point is this is this is due to the guideline bias, yeah, I can call it. Right heart catheterization was considered as the last resort of the pulmonary hypertension workup since 2004. Now onwards, since 2018, 19, and now onwards, it has come up again, and people thought that it is not really justified to treat pulmonary hypertension before doing an RHC. That's why it has been glorified now.
Please use the mic. You're not audible.
No.
And I think one of the reasons is practical reason. See, in the West, the drugs are very expensive. You cannot start a patient without a confirmed diagnosis. And that's one of the reasons why they do RHs. In our country, sildenafil is very cheap. So when you have a mismatch between the cost of investigation and the cost of therapeutic intervention, people tend not to do diagnostic test and straight away start on therapy. I think that's a very important reason why also this happens. Apart from this fear, unnecessary fear of right heart catheterization.
And also, I have quoted Ryan's statement. I did not quote the whole thing. You can read it. And he has said that if the oncologist, they barge on, doing a biopsy before treatment, why not right heart catheterization plan? This very word he used. You can write it.
Personally, I appreciate.
Once we probably the question, answer to Dr. Pavan Agarwal is another is that beside what you have answered it, maybe the young cardiologists forget to took the right heart catheterization itself. Like Dr. Subananda can do it, but the young cardiologists can't do it.
They are not interested in doing it. I have seen it practically.
No, why? I think I will answer your question. It should not blame just one or two. It is a very costly test now. I mean, it should be done in 5,000 rupees anywhere, but unfortunately, everywhere it is, I think, costing more than 10,000, 12,000, 14,000 they are charging. So that is one big problem. Second thing, catheters are no longer available. Availability of Goodell-Lubin catheter, Cournot catheter, balloon flotation catheter is now becoming very, very difficult. And what we are doing with this multi-purpose catheter. So, which is not the ideal catheter to do a right heart catheter.
Devanu catheters are available. Arrow
No, it is not available, I'm telling you.
We get it regularly. There's no problem. Arrow can make.
Oh, you are getting it from maybe centralized Fortis.
No, not at all.
But as individual centers, we are not getting it.
No. We are getting here.
I have another question.
One more thing. Let me complete this.
Yeah.
So we are, third thing is that now many people are not doing right heart catheter. Unfortunately, what I see, the new cardiologists do not know how to do a right heart catheter. Fourth point is when you're doing in pulmonary hypertension, you have to do a vasoreactivity test at the same time. So vasoreactivity test, again, facilities are not available. So question is that the amount that the information that you get by doing a right heart catheter is not actually cost effective. And the risks that you're taking.
No,
so it is because of that people are not doing it.
Yeah, I differ here. First of all, we do regularly right heart catheters. We do regularly. And amazingly, it gives very good results. Amazingly, I can tell you that. This is number one. Number two, there is a difference of 25% in the estimated peak. But in science, you know that close approximation to the truth is almost truth in biological science. You cannot have 100% always. This is number two. And number three is vasoreactivity test. We have tried a lot of things. We tried with NTG, we tried with the adenosine, but there is still. But nowadays, in the new guidelines, they have said the only nitric oxide or ileoprost, nitric oxide inhalation is the right thing. So in that way, it will be difficult, and exercise will be difficult because exercise will be difficult. These two are difficult, I admit, but fluid challenge, or if you can go through the internal jugular, the leg grazing, these can be possible, and they can give you good results.
One more question I had. See, from your data, we know theoretically use of pulmonary vasodilators can worsen the VQ mismatch in a group of patients. So in terms of group 3, the tentative use now is inhaled treprostinil in patients only with ILD pulmonary hypertension, not COPD. So in your series, did you find that giving sildenafil worsen hypoxia?
Yes, of course.
Because
We have seen, see,
that
that's
would be very interesting. You see, individual patient data would be more useful than the group as a whole.
But you have to
in the learning process.
See, as you learn, you have to frame a strategy. You know, what people have seen, one of the author, I mean, the editor sent me a letter rejecting my paper that there are so many reports that this is risky. And I went through all the, publications related to use of vasodilators in COPD PH. And each and every one had a lot of flaws, small number, different endpoints, this, that. So whatever it is, we from the very beginning, we thought that we'll start with a very small dose. Actually, what people did a mistake, they replicated the PH trial to COPD PH. We started from 12.5 milligram, even to 6.15 milligram in certain people. And once they tolerated, we have built up the dose. The most important was the grading administration, grading dose. So they tolerate mostly. Even then, in some patients, roughly in 10% patient, we have to drop it. And a lot of side effects. Side effects are quite a few. It is not free of side effects. But I can tell you 75% of the patients roughly can tolerate. And I believe that 75% patient, if they get a good relief of their shortness of breath, why not?
Parsada, can I make some practical points? I was enjoying the debate between RAC, yes or no, other things. I mean, in our quest for refinement, the ESC ERS guidelines are brilliant. But let's not forget one fact. Let us not make it too difficult, the approach, so that people shy away from it. We were just I was talking with Devanuda, our junior friend sitting at the back, how much of this they are conversant with, be it the finer techniques of RHC or whatever Aniruddha has said. So we are doing, neither our younger colleagues in cardiology are neither interested in RHC nor doing a proper echocardiography. So that is the basic problem. We are not addressing that. If you do a proper echocardiography study, let me tell you that you are not going to miss a single case of pulmonary hypertension. There can be 5 millimeter error in judging your PASP or mean pulmonary artery pressure. But we are not doing our job. That is the basic problem.
I appreciate your comment. This is unfortunate, but it is important at the same time that in such small conferences, we focus on these areas so that our youngsters know that they have to face this drama in their real life. And tomorrow, if they cannot deal with, the patient will go. They will go to Chennai, to Delhi, to other places, wherever they find good response. They will ultimately seek well-being. And if you cannot afford it, they will not stick with you. So this is a question of survival for all of us. And if it has not been done in the formal training institutes, a time will come that our people will have to suffer.
Like
so we have to make a way out.
Anjanda presented, the lady, her diagnosis could have been established much before, had she been subjected to a simple stress echo.
See, no, sir, the basic X-ray. It's a overt right ventricular hypertrophy. The X-ray, if people cannot read, that's an unfortunate thing. Anyway, that's a different topic altogether. If we drift to it, we'll go to some other areas. So,
Again, comment on this.
Sir, any comment has to be substantiated by data or publications.
Now, this about is vasodilator.
You are true. We are finding DCM because of a lot of comorbidities. Now we are finding people surviving much longer. So maybe DCM is going up.
There was a publication of mitral stenosis with severe pulmonary hypertension and RV dysfunction being treated with sildenafil for betterment of RV function. And the person has to be given money. He had a courage to do this trial, and he had a concept. Because if your mitral stenosis is advanced heart failure is there, right heart failure, patient's symptoms of orthopnea, PND are not there. And he is now disturbed because of RV dysfunction. So there is no reason that you will not give the therapy of pulmonary hypertension to improve his RV systolic function. So the quality of life can improve.
Yes.
And that publication was done.
Yes.
So it's not that the guideline says it is contraindicated. One has to have some reasoning to start in therapy.
Can I recollect another experience? Just last OPD, there was this ASD pulmonary hypertension which had come to see us. We are in a doubt whether to close it because PASP was around 55, 60. So whether to put a device or not. That was the issue. In the meantime, I prescribed her
Yes,
some
sir.
sildenafil and one endothelin antagonist also. So now the issue, my junior colleague, a fully qualified cardiologist, sir, are you, is it allowed to be given in Eisenmenger syndrome? Now, bosentan has been given a 1A indication long back in Eisenmenger, and so has been the endothelin agonist very, I mean, they have 2A recommendation. Okay, so this is the kind of awareness that we have. So our problem is to spread awareness about pulmonary hypertension and its treatment. Yeah, mitral stenosis, if it is end stage patient has intractable right heart failure, and if it still can be corrected and the pulmonary hypertension will reduce, only the operative mortality will be too high and the post-operative
And
course will
also, you know, in
strongly.
mitral stenosis, you know, I do not find any justification of putting, you know, sildenafil and others.
No, I mean, I don't justify.
Mitral stenosis because these are vasodilators, and in a stenosis, if you give vasodilators, the gradients will again increase. So this is one point. But the point is, all of us who practice cardiology, in mitral stenosis, whatever pulmonary hypertension you see, once you balloon dilate and you see that the pulmonary hypertension vanishes. This is so
So that brings us to the Heath-Edwards classification.
Yeah.
It stops at 3. It never goes to plexiform arteriopathy. So once it goes to plexiform arteriopathy, it is irreversible.
So thank you very much for.
Please don't give sildenafil or any vasodilator to mitral stenosis patients. Please do not give it because. No, it's okay.
No, I admit.
If you are very experienced to give it, but as of now, it is very, very dangerous. Patient's quality of life is bad because of left heart failure, left atrial failure. And truly speaking, the right heart failure actually protects them from pulmonary edema. So that is actually a good thing for them. But if you are very confident, you can try it. But if you're not confident, just because Professor Ranjan Sharma has said, don't give it.
He has just said that there is publication about that. Sometimes you are cornered. Sometimes you have got nothing to do. And I think people should be bold enough to experiment.
Sir, Pathoda, in a study, what was the amount of overlap in the classes that you find? Was it
now for the last, I mean, the calculation which we are looking at 100%, I've got group 2 and group 3 pulmonary hypertension together. 100% of our patients. That's very strange.
So in this overlap cases, it's very likely we can give the vasodilators. I think that is a place where it works, I think.
I think we should treat, if there is a overlap, we should first target the group 2, and after that we'll re-evaluate, and then we'll think of treating group 3.
See, I think there is a slight danger of over treatment if we give this message, you know, that treat all group 2, 3 patients with pulmonary hypertension drugs based on very dubious quality of echoes half the time. So I think this should not be treated by everyone unless you have real experience in managing these patients.
No, many times it comes after giving all the medications and all, we are not able to give enough benefit to the patients. In this scenario, I think.
But there are many patients I see who are on these drugs based on one very dubious echo and no group, no class 1, just group 2 and 3. I think subjecting patients to pharmacotherapy in this should not be encouraged at all, you know, unless you are doing it as a part of some kind of a study or, you know, experience. Because this message, if it goes out, you know, will just increase unnecessary pharmacotherapy in these diseases. Because we see it every month. I see a patient who is on sildenafil on the basis of what I don't know.
I think, thank you very much. This area is so interesting. We hope that we will have in future we'll have a whole day session and interaction between us, because this is a real learning area where we should be much more aware. Thank you very much. I thank all the faculty and guests. So now we are reaching the fag end of it. I see the researchers are waiting very keenly to know the result of their presentations. Before that, I beg 10 minutes time from them because there are two small presentations which are very important, which might help them also. So may I request Dr. Rick, where is Rick? Rick to present the impact of pulmonary rehabilitation briefly. This is a non-pharmacological intervention. We all have got our relatives suffering from some or other chronic respiratory disease. And what Rick is going to say that without any treatment, you can improve their quality of life.
Thank you, sir. So today my topic of discussion will be our experience of pulmonary rehabilitation at IPCO. Firstly, why pulmonary rehabilitation? Since it's a globally proven non-pharmacological intervention which is very helpful for patients with respiratory ailments. Next, what are the problems we faced when we are trying to develop a pulmonary rehabilitation program for the patients was how to develop a pragmatic module for the patients. So we assessed for the patient's feasibility to attend pulmonary rehabilitation and development of pragmatically feasible modules. Based on our study, we formed 4 pragmatically feasible modules. Module 1 with monthly visit, Module 2 with once or twice visit per week. Third module consists for quarter annual visit of the patients, and in the module 4, patients can visit as per their desire and requirements. So the real life turnover was that the most patients got inducted in module 3, which was quarter annual visit, followed by module 1, that is monthly visit, and at their own discretion was followed by that least in module 2, which was like once or twice weekly visit. Now the patients, those who were inducted in module 2 were 110. Out of them, 84 patients followed 12 follow-ups, and we have evaluated them for parent data for all these 84 patients at their induction and at the completion of their follow-ups. Now the interventions that we provided were non-pharmacological. Beside that, nutritional intervention, psychological intervention, and other interventions were also provided. So in the intervention part, we worked on educating and motivating the patients, their preparation and primary investigations like 6-minute walk test, 2-chair test, and ECG, followed by non-pharmacological interventions of airway clearance, breathing exercise, and strength and endurance exercises. The strength and endurance exercises were chosen and were customizable as per the patient's requirement upon the physician's discretion. So this is the basic evaluation process of the patients. They got inducted, they get their non-pharmacological intervention, we record their primary data, we record their follow-up data, we process the data, we looked into the insights from all these data, and then we can form insight into the patient's development. So what were the findings? So I will talk under these assessment protocols like CAT score, 2-chair test, 6-minute test, and as you can see, all these are there. So CAT score shows a significant decrease. Also, 2-chair test shows the patient's stable characters. In 6-minute walk test, there was a significant increase in the patients in the total group. Activity score also showed significant increase. Peak cough flow has significant increase. Peak expiratory flow also showed increase. Upper limb strength was definitely showing a increment. Lower limb endurance also got significant increment, and the overall power that is derived from static cycle ergometry shows high significance. So in summary, we can show the slides like this, the results. So in summary, we can say that pulmonary rehabilitation appears useful in COPD patients. It can develop their functional as well as emotional ability. Also, at present, we don't have comparisons for various modules. Probably we'll be putting that in the forward future. So thanking you all. Thank you.
Thank you, Rick. Now I request Dr. Ananya to come and sit on this chair. and sit on the chair. Yeah. And and give a mic to her. She's heading our pulmonary rehab department. So what the report you have seen just now, Rick has presented, is the impact of pulmonary rehabilitation. Rick has already impressed us that there is an overall global improvement in different parameters with this exercise and other things. And she is a person who does it. So would you please tell us what are your types of interventions? Just one,
Yes, sir.
please sit down and please answer. This is for everybody. This is a kind of generalization. If you practice this, any chronic lung disease, there will be some or other bit of improvement. So you tell me what kinds of exercise you advise your patients.
First, when the patient comes to our OPD, we first check the any postural deformity or not, and patient is having any secretion or not. Then we clear the secretion by postural drainage and some of the exercises. The exercises we divided into two groups, that is breathing exercises and the strength and endurance exercises, and other than general exercises. In the breathing exercises,
No, just a moment. You can go over this chair on the table, besides the table here. So the next question. So what she told that she first examines the patients, try to assess the sickness, try to assess any physical deformity, try to understand the problem. And she said that if there is secretion, means if there is a lot of cough and phlegm in the airways, try to clear it first. And after that, she embarks upon the exercises. And what she has told that there are basically two types of exercises. One is a breathing exercise and other is a general exercise for increasing the strength and endurance of the muscles, including the respiratory muscles. Achha, does general exercise like walking helps respiratory muscles also? Answer in yes or no. Yes. So if a patient can walk, or if a patient starts walking, it will improve his respiratory muscle function. The respiratory lungs are like to bellows, they have to be expanded by positive force. So if the muscles are strong, they will breathe better, so they'll feel better. So can you show me one or two important breathing exercises? Just one or two.
Yes, sir. First of all, the pursed sleep breathing exercises. First, the patient wants to lips are pursed, that just like this, and exhale the whole air from his mouth and put his fist in front of the lips and exhale the air from the mouth. That is pursed sleep breathing.
So what she is talking is that you breathe out slowly with pursed lips. That means you breathe out against a bit of resistance, and that resistance is imparted by your fist. As you make the fist tight and place tight on your mouth, the resistance will be high. You make a loose fist, put it on your mouth, and try to blow out. So it will put some resistance. But if you gradually improve that strength of the fist, it will put more and more resistance. So if you give a little resistance, your airways will be slightly opened because of back pressure. It is kind of splinting from inside by placing a bit of resistance on a pliable tube, right? So this is pursed sleep breathing. What is next? One more important breathing. You can stand up and say.
If the patient, many of our patient is having breathing pattern deformity, that is paradoxical breathing, then we have to correct the breathing pattern. We have to correct the breathing pattern, that is diaphragmatic breathing. One hand in the chest and one hand in the abdomen. First, exhale the air from the mouth just like this, and your abdomen will be outside, that is bulge, that is correct. If the abdomen is constricted, then it is not correct. Then we have to go for the breathing pattern correction.
What she is talking is that once you breathe normally, you expect your abdomen to bulge as you inspire. And what happens in our patients, these patients, they have got sometimes paradoxical breathing. They are taking a deep breath in, the abdomen is also going behind. This is not right. It should bulge. So she looks at the type of breathing. If there is a paradoxical breathing, she has to correct it. And for that, she prescribes diaphragmatic breathing. She asks the patient to put a hand on the chest and put a hand on the tummy and asks the patient, you breathe in and see whether your hand is going up, forward. So if that goes forward, that means you are breathing abdominally. This is called abdominothoracic breathing. The diaphragm is pushed down, the abdomen is bulged, so the hand goes forward. So this correction is very important. If a patient has got shortness of breath from any lung disease, anywhere you see, and just look at the breathing pattern. Many a times the breathing is not correct. And if you can make the patient breathe like this, that the abdominal bulges when she or he is taking breath in, you will find the patient is grossly relieved from the shortness of breath. So this is a big clue. So thank you very much. If what the message is that if you can correct two issues in breathing, one is get rid of the secretion. Second, you allow fast tree breathing or breathing against a bit of resistance. And second, you see the abnormal breathing. If they are just corrected by abdominothoracic breathing, the patient will get relief. So this is the message. Thank you very much. We end this session here. I request Shayanti to bring the results. Thank you very much. Bring the results of our scientific presentation. So we had two kinds of scientific presentation. One is poster, the other is platform presentations. So what we did, I was totally inert in the issue. The experts have given scores. Some people were selected for platform presentation from the poster area. That selection was not under my control. What I have done, I have told them to get the average score. Suppose somebody has been in the poster presentation alone and three judges have given three different scores. So we actually averaged it. And someone has been in the both poster and platform presentation. So we took the score of poster plus platform and then averaged it. So thus we got the final marks, and through that, with that, we have decided three winners. So I will tell the names. May I request Dr. A.K. Shah, sir, please come. Ashu. So this is I'm declaring the third prize. There is a small cash prize with certificate. This is Joyatri Dotto from IICB Kolkata. Small memento. The second is a runners-up. May I request Dr. Nitai Dotto, sir, would you please come? The award goes to Orchita Roy. Orchita Roy of IICB Kolkata again. Okay. এটার জন্য আবার অঞ্জন দাকে ডাকি। Thank you, Dr. De. Now, may I request Dr. Anjan Datta to come on stage? And who is the winner? Oh, this is Rick Chakraborty. Rick Chakraborty from my institute. I'm happy at the same time. I reiterate that I had nothing to do with this. Thank you, Rick. Congratulations. Dr. Anjan Datta, sir, please kindly hand over the prize to him. Action. Now the prize for the postgraduate quiz. May I request Shantanuda to come? And this second prize, the first prize has been already given because he had to catch a flight. And this is to Onubhav Maulik and Nazma Squib, NRS Medical College team. quiz. There is a second prize. Requesting Dr. Aniruddha De. Sir. Dr. Aniruddha De, sir, would you please hand over the third prize to Muhammad Saddam Hussain and Saddam Hussain from RG Khan Medical College. Saddam. Who else is from the RG Khan Medical College? And Ronnie Chakraborty. I'm sorry. Huh? Congratulations, Saddam and Ronnie.
স্যার এগুলো আপনি দিয়ে দেবেন পার্টিসিপেশন স্যার
বলে দেন
So now we will give the certificate to those who have presented the poster. So now I will first invite Dibakar Roy from Bose Institute. Thank you for your participation in Pulmocon. Next, I would invite JC Aleama Jose from Metro Hospitals. I think she has left. Later. Next, I would invite Paromita Roy of Bose Institute. Thank you, Paromita, for participating. Next, I would invite Sazia Firdaus of Bose Institute to please come ahead. Thanks a lot, Sazia, for participation.
May I call our senior physician Orunda? Sir, would you please come and just and hand over some certificates to our.
So next I would invite Anindita Bhattacharya from IIT Kharagpur. Next I would call upon Ria Manna of University of Calcutta. Next, I would invite Shubham Ghosh from Institute of Pulmocare and Research. Next, I would invite Shayanti Kormukar from Institute of Pulmocare and Research. Next, I would invite Srijita Sen from Institute of Pulmocare and Research. And lastly, Shayani Sengupta from Institute of Pulmocare and Research. So thank you all for participating in this poster and presentation. It helped us increase our knowledge in the fields and definitely have made us more knowledgeable in these 2 days of Pulmocon. I hope everyone enjoyed their time in Pulmocon and had some messages to take home. So now I would like to invite Dr. Parthasarathi Bhattacharya sir for a vote of thanks for all.
And this is my pleasant duty forever because I happen to have started this conference. I've been working as a chief organizing person for last 20 years. And this time I'm very happy that I could pass over the baton to Abhishek. And as it's a customary, but I am talking from the core of my heart that this is basically an outcome of a passion. And hardly there was professionalism to start with, and still we lack a lot of professionalism, so-called quote unquote, for holding conferences. There is a huge list to thank, and I might miss somebody, but first I will give thanks to all the delegates and all the participants from different institutes who came with their scientific work to display. And it's been found in most of the conferences, this area is not that highlighted. It's relatively neglected, but I think that's the most important area. Although I couldn't myself give much time, and most of the delegates were busy in listening to the talks and all, but still I feel that this area we try to improve upon every year. And I'm very happy that so many people have joined this time, and I congratulate everyone, those who have received award and those who haven't. Doesn't matter. The spirit is most important. The talk of Dr. Somiran Panda today, I think, had you been there, you would have understood. You may understand what I want to mean, because there is uncertainty, and award is nothing. It is most important to take part and to keep spirit of doing something new, something different, something which can change our quality of life for betterment. So after that, I congratulate every delegate who has come. And following so, it is the faculties. My friend Aniruddha is sitting, so it's a wonderful occasion, Aniruddha and Nitai. So everybody has come, they have given their best. And I understand there was lack of time, a lot of difficulties. We are learning. We have got some compulsions to accommodate something, or maybe too many things together. If you want to be more detailed in discussion, you need to have more focused conferences on particular small areas. And I hope that tomorrow, day after tomorrow, or maybe in future, we'll venture into that kind of conference where we would expect you people will come with your much more better scientific input, and we'll get faculties. Our faculties will do much more on that particular areas. It's very heart touching that many of our seniors have come. Orunda has been sitting from yesterday morning till evening. Today, see, he's still here. Like Anjunda, Shantanuda. I call them Dada because they are really my Dadas. Somebody from my college, somebody not from my college, doesn't matter. And they are the constant encouragement. Unfortunately, not unfortunately, incidentally, the PGTs are relatively sparse in number, but I believe that with time the trend will change, they will come more and more. See, any conference is not possible without support from many kind of people. So if I start from looking from the left hand side, the first thing is audio visual, what I can see. Second is lighting. So I thank you, Somnath Babu, your team, for helping us. Third in the back, I can see the catering service. Thank you, my Dada. He's also my Dada in true sense. And his daughter is there. So I thank you all for helping us in this conference. And then I look at my friends from different pharmaceuticals. They are, in a word, what would I say, the prime support of such conference. So nothing is possible without their help. They work with me like a family member. They never think that they are sponsoring a conference. What I feel that they feel this conference is their own business, the way they work with us. So I thank you all. This is just a customary, but it's a genuine thanks to all of you. And lastly, I have to look at myself, the venue. The money is not the all. They have arranged these all things for us. So I convey my thanks to them. And lastly, coming to my people, my staff members, such kind of conference takes a long time to prepare. And we are a very small institute. My research workers, my staff members, everybody, they involve themselves like they involve themselves in a family function kind of thing. They never say no to anything. They're all spontaneous, and they do everything happily. I'd hardly bother about small nitty-gritties. And you have seen me just calling on telephone, everything is managed more or less. We are not professionals. Had we been professional, we had been much more sharp in this business. But there's amateur people doing something, trying to do something in the best fashion, possibly can be exemplified by our performance at this state in this conference. So with that all, if I have missed anybody, I thank him or her, and I wish that the conference would continue. And I have completed 20 years. It's a quite a long time, and I believe my successors will do better than me. I hope next year onwards I'll be able to get Abhishek or somebody else and to drop all my responsibilities upon their shoulder. I'll be there, and it will continue. It will be bigger. Nobody knows what will happen. We have a lot of plans. Man thinks a lot, but man proposes and God disposes. And sometimes man proposes, and God also supports. So whatever will come, we'll take it. We'll hope that we'll do better work tomorrow, both in scientific field and educational field and patient care, with utmost passion, honesty, and sincerity. With this all, I fold my hand and thank you all for coming. Thank you very much.